So with the first session, without any delays, I would like to invite the chairperson, Dr. Deepak Lote sir, a senior consultant physician from Akola, and Dr. Panikar sir from Mumbai.
We have first Dr. A.K. Das and then...
For the first session, we have Dr. A.K. Das sir from Puducherry, who's going to join over Zoom call for us. Over to you, chairpersons.
Good morning, everybody. At the outset, I would like to thank Dr. Sunil Gupta and his team for this privilege that he has given. Ashok Kumar Das, as we all know, needs no introduction. He has been my PG teacher, and I would like to say a few words, a PG examiner, and I would like to say a few words about that. He is an erudite scholar, great teacher, prolific writer, and above all, astute examiner. Even our batch had the misfortune of appearing for the exam twice, even without failing. Because of the eccentricity of a lady examiner, the entire batch was failed. I think similar episode occurred here also in GMC Nagpur, and all the students were failed. Fortunately, a note of dissent was given by other teachers and the result was not declared. So we had to appear for the exam again. It was conducted again. All four externals were called and Professor Das was one of them. And I realized that he wants to expose your knowledge and not your ignorance. A thorough gentleman, and with this few words, I again say that it is my proud privilege to be chairing this session. Professor Ashok Kumar Das.
Thank you, Professor Lote, for the kind words. I remember that incident vividly. It was injustice done to everybody, and once again it happened when the same examiner couple also killed one thesis and the candidate was not allowed to appear. I was called to one more college, one more university, I will not name it, and I found thesis was in perfect fitness of things, and I also got that boy passed. Thank you very much for reminding me. The examiner is to help the students, not to penalize the students. Thank you very much in this personal note. Can I start now?
Yes, yes.
Yeah. My dear friends and esteemed colleagues, thanks to Sunil and the entire team for this wonderful flight given to me and to captain this flight. I'm going to speak on a very important topic. Important and contemporary challenge, the pre-diabetes. The choice is imperative. The burden, the biomarkers and the management, how it is important in the current scenario. Now, why should we screen anybody for the pre-diabetes first of all? Now, there are 5 criteria that is valid for screening for any disease. Number 1, the disorder is an important public health problem. And diabetes is the most important public health problem, so screening is a must. Early asymptomatic stage exists? Yes, it does exist. A suitable screening test is very simple, 75 gram per hour post-glucose. Accepted treatment available? Of course, yes. And currently, DCGI has approved a drug which we are using without approval, Metformin, which is approved today. Early treatment during asymptomatic stage improves the long-term outcome. It improves and changes the destiny of the patient. What is pre-diabetes? Pre-diagnosis of diabetes is called pre-diabetes. We diagnose diabetes before it comes in. It's a warning sign. Pre-diabetes should not be viewed as a clinical entity in its own right, but rather than it's a precursor of diabetes and cardiovascular disease. The American Diabetic Association says pre-diabetes is a pre-diabetes, pre-hypertensive and pre-CVD. Associated with obesity, definitely, especially with abdominal obesity, visceral obesity, dyslipidemia, and when high triglycerides and low HDL cholesterol. and of course I said hypertension. And metabolic syndrome usually exists with no symptoms, or there can be high blood glucose level. Dear friends, what are the characteristics of prediabetes? The early manifestation of the prediabetes, this glycemia, can be of two types, or both can coexist. It can be impaired glucose tolerance, in which the postprandial, the fasting plasma glucose is normal, but the after food, the blood glucose is between 140 and 199. If it becomes 200, it becomes diabetic. So fasting glucose FPG is normal, but the postprandial glucose is impaired in the sense it is above 140 but below 199. The second variety is impaired fasting glucose, in which there is an elevation of the fasting plasma glucose between 100 to 125, and it occurs in the absence of any postprandial glucose. Only the fasting glucose is higher than 100, less than 125. The postprandial is within 140. So it can be either IGT or IFG, or it can be combined both. Dear friends, what does it really mean? Now you will find that there is loss of beta cells function in the stage of prediabetes. Now we have almost 50% of the beta cell loss before when the prediabetes sets in. If you look at the various the beta cell glucose sensitivity of the lean NGT, obese IGT, IGT and type 2 diabetes mellitus, you see the IGT people already have the beta cell very close to the type 2 diabetes mellitus. Therefore, approximately 50% of the function is lost at the diagnosis of prediabetes. What is the burden? We'll examine its prevalence, what are its type 2 diabetes risk, what are the complications, and it is a precursor of metabolic syndrome. Many other syndrome like PCOS, like hyperglycemia in pregnancy, GDM, on which we had a wonderful meeting day for a study, they are all part of this game. Prediabetes, is it a path to diabetes? Answer is yes. Is it a window of opportunity? Yes. To intervene absolutely effortlessly and change the destiny of the person not to become diabetic. Let's see the prevalence. The impaired fasting glucose in 2021, according to the IDF Atlas 10, was 541 million, 10.6%, and IGT was about 319 millions, about 6.2%. It is expected in 2045 there will be 730 million of the impaired fasting glucose and 441 millions of 7% adult will be having impaired glucose tolerance. Therefore, this is a very important issue. Coming to Indian statistics, at a glance, the IGT in 2011 was about 20.4 million. In 2021, today it is 40.1 million. Look, if you look at the impaired fasting glucose, please remember that impaired fasting glucose is always much more than the impaired glucose tolerance. IGT is less than the IFG. So IFG here, India was very high in 21. We found about 75 million people who are having impaired fasting glucose, and you see in the 30 and 45 is going to become 50 million and 80 million, 85 million. Dear friend, if you look at the IC1 in-depth study, which we have published on the 15 state data, it was about 10.3%. That is the prevalence of prediabetes. The prevalence of prediabetes varied from 6% in Mizoram to 14.7% in Tripura. The prevalence of impaired fasting glucose was higher than the prevalence of impaired glucose tolerance. I already said that. What are the risk factors? Age, male sex, obesity, hypertension, and family history of diabetes, independent risk factors that we found in this particular study, I7 in-depth study. This graph shows the prevalence of the pre-diabetes. Mizoram 6%, Manipur 7.5%, it rises. Punjab, Tamil Nadu is about 8.3%, it is about 10% in Bihar, Gujarat about 10.2, Karnataka 11.7, Assam about 12. To come to the Tripura, it is 14.7. But what is not shown in this diagram, the paper is under publication, we also found that about 20% to 24% prediabetes in states like Kerala and also some parts of Pondicherry. So it's a huge clinical problem. Now, this prediabetes progresses to diabetes Even among villagers, we found that the abdominal obesity, etc., increases very fast. Now, this is a very important slide. I'd like to draw attention. What are the predictors of incident diabetes, pre-diabetes, and dysglycemia? Which type of pre-diabetes progresses to diabetes? Now, the IFG, IGT can progress to diabetes if the person has a elderly person, positive family history, if there is abdominal obesity, if the 2-hour post-glucose is nearer to the diabetic value but not at it yet, if the HbA1c is not at the diabetic range but close to it, HOMO-IR is positive, giving the insulin resistance does exist. There is high serum triglyceride. Please remember, if a person is having high serum triglyceride, we alert that he may develop diabetes. Low HDL cholesterol and physically inactive. So these are the constellation of factors which pointer that it can go to full-blown diabetes. There are a few factors for the progression to pre-diabetes, similar factors, I will not describe them. Therefore, there is a study in Chennai, the CUP study, Chennai Urban Rural Epidemiological Study. It was found that any dysglycemia is reported over 10 years, not in 1 or 2 days, over 10 years in 22, 30, and 52% cases. And among those with NGT, those with normal glucose tolerance, 20% converted to diabetes and 26% into pre-diabetes. So the overall conversion rate to dysglycemia is 45%. I will again remind you that those who have normal glucose tolerance today, 20% convert to diabetes and 25.7% to pre-diabetes over 10 years, giving an overall dysglycemia of 45.1%, a huge number. What is the burden of pre-diabetes? The burden of pre-diabetes is almost same as type 2 diabetes. There is hypertension, visceral obesity, glucose intolerance, dyslipidemia, endothelial dysfunction, hyperinsulinemia, and end organ damage like diabetics. And insulin resistance is a strong predictor of pre-diabetes. So pre-diabetes burden is almost similar to type 2 diabetes burden. Now you look at the cardiovascular risk and pre-diabetes. The cardiovascular risk is increased by 13%. Coronary disease, coronary heart disease, CHD, by 10%, stroke by 6% increase, all-cause mortality by 13%. So this is the suffices to mention, the CV risk is increased many-fold in people having impaired fasting glucose or impaired glucose tolerance. Therefore, the cardiovascular risk of pre-diabetes is extremely high. Dear friends, this is the recent paper which I presented last week, about 10 days back in ADA. I've just brought the gist of it. Just try to understand this. It took some time for me to read the abstract and I was not there, but I want to convey this message that it was shown that irrespective of the fact whether the person develops diabetes or not, whether he develops other metabolic aberration or not, the presence of pre-diabetes increases the risk of major clinical event and death. So pre-diabetes can be a major indicator of other clinical events to come and death. And the risk relationship between pre-diabetes and clinical events are stronger for the younger people than the older people. Very important message, I would like to give it to you. Now, impaired fasting glucose has a significant role in atherosclerosis. It has been shown that cardiovascular risk is increased with impaired with IGT and IFG. And those with IGT, I'll repeat again, those with IGT, impaired glucose tolerance, are at more risk for developing ASCVD. And lipoprotein abnormalities also exist in the people with the pre-diabetic stage. I want to make a long story short by saying what is the site of insulin resistance and how does it influence the lipoprotein other lipid changes. You remember very, very briefly, IFG, impaired fasting glucose, that is hepatic insulin resistance. In impaired glucose tolerance, there is skeletal muscle insulin resistance. So here, IFG, fasting glucose impairment, hepatic insulin resistance, in the IGT, skeletal muscle resistance. And they give rise to the impaired increased production of the ApoB, inability of the insulin to suppress VLDL production, and gives rise to various types of lipid abnormality. Here also there is impairment of the free fatty acid uptake, increased availability of FFA, and they give rise to other types of lipid abnormalities. Now, dyslipidemia is a part and parcel of prediabetes. Association of lipid profiles with insulin resistance and beta cell function has been found in various categories of glucose intolerance. Dyslipidemia might diminish the compensatory insulin secretion to insulin resistance in the subjects with IFG and IGT, and high LDL cholesterol as triglyceride is associated with increased probability of prediabetes. Now, coming to a very simple fact about hypertension. Now, hypertension is very often associated with prediabetes. Now, it is needless to mention that you see that in the finding of impaired glucose tolerance, it was found that the cardiovascular disease and hypertension almost same as the diabetic. There is a complication of prediabetes. You see, as the glucose level rises, you find the carotid intimal medial thickness also increases, meaning thereby once the blood glucose, fasting blood glucose, impaired glucose tolerance rises, the atherosclerosis also increases. Now coming to the biomarkers. Now, in the development of type 2 diabetes mellitus, the progressively rising glucose levels occur relatively late, and by then the beta cell function was already 50% or more than 50% is gone. Therefore, is there a marker by which can identify the people who are more prone to prediabetes, who are more the marker which is sensitive and precise biomarkers? Now, there are clinically relevant biomarkers. It's more important to identify the persons. So I'll tell you clinical biomarkers. Very simple, but we are not allowed to it. Family history of diabetes in a first degree relative. High risk race, we are in high risk race. Sedentary lifestyle, hypertension, dyslipidemia. History of CVD, a lady having PCOD, somebody having obesity, and any degree of HIP, hyperglycemic pregnancy, are clinical biomarkers for prediabetes. Please be alert when you see it next time. There are traditional biomarkers like dysglycemia, like HbA1c a little higher than the normal, fructosamine assay is higher, glycated albumin OGTT 1.5 Ag also higher. There is a paradigm shift to these to novel biomarkers. I'll just describe them. Novel biomarkers for prediabetes are adiponectin, retinol binding protein 4, and leptin. It has been shown that the adiponectin is inversely related to the risk of incident prediabetes. Please remember, adiponectin is a good marker and directly correlated with insulin sensitivity and correlated with insulin secretion. Retinol binding protein also is associated with metabolic risk factors such as BMI, waist circumference, hypertension, lipid parameters. A leptin deficiency or resistance leads to uncontrolled food intake, obesity, and that is a marker also. In India, we have studied adiponectin in the various groups. This is a study from the Ramchandran's group. Adiponectin secreted by the fat cells, regulatory functions on energy metabolism. Its low level of adiponectin are predictive of future development of diabetes. It was shown that in Indians, pre-diabetics, there was low plasma adiponectin level. Now, the same thing has been done in different perspectives, and the relation between the adipokines and the anthropometric biochemical variables, I'm going to that. This is a very interesting part, vitamin D and pre-diabetes. The physiological mechanism of vitamin D involvement in glucose homeostasis include insulin secretion action. Vitamin D facilitates insulin secretion and action. Therefore, some suggestion have been put that vitamin D may be associated with the pre-diabetic, and there is a study which was an open label randomized study to analyze the effect of vitamin D supplementation on glycemic profile and body composition in pre-diabetic vitamin D deficient overweight Asian Indian women, and it was observed by giving vitamin D, there was significant reduction in the fasting blood glucose, 2-hour glucose post GTT. Therefore, it suggested vitamin D may be beneficial, and vitamin D may be a biomarker for the pre-diabetes, but not universally accepted. How do you manage diabetes? Now, what are the goals of diabetes management? Preventing pre-diabetes, converting to diabetes, lowering the risk of the micro and macrovascular complications, promoting pre-diabetes to go back to normal glycemia and reducing the cardiovascular risk factors like smoking cessation, hypertension treatment, reduction in the lipid level. Now, treatment, as we know, is non-pharmacological and pharmacological. Non-pharmacological is weight loss. The goals are not simple. You have to lose the patient to lose 5 to 10% of the initial body weight for obese people, overweight people, achieving to get the result, and 30 minutes of exercise. And this exercise has been quantified, 30 to 60 minutes of aerobic exercise, resistance training, and also details has been given. How do we take the lifestyle measures by this simple thing, by sleeping, 6 to 8 hours of sleep, diet. Important factors to control is to lose 5 to 10% body weight, therefore maintain the ideal body weight right from the time of pregnancy, and refined food grain, juices, trans fats to be avoided. Saturated fats, simple sugars should be limited, ample quantity of fibers, and important individualized percent of calories from fat and carbohydrate per age particular. Regular exercise like brisk walking, swimming, dancing, cycling are very important. I will not carry home to Newcastle. Now, pharmacological treatment is not necessary for everybody. The threshold for prescribing drugs are when there is severity of hyperglycemia. Number 2, there is a self-perception of severity, and poor adherence and poor response to lifestyle changes. Now, Metformin today has stood out as the drug of choice for pre-diabetes, and it has got a shot in the arm because DCGI in this meeting on the 7th of April, 8th of April, has approved Metformin in pre-diabetes. It was used before. Today we have got the approval. Now, what is the role of Metformin? The role is primary prevention of diabetes, when Metformin is given in the perspective of diabetes prevention. Secondary prevention, that is when we give in the pre-diabetics, not to develop diabetes. Primordial prevention, when Metformin is given to all pre-diabetes patients to prevent vascular complications. Dear friends, now there are 4 studies, DPP-1, DPP-2, DPS study, Finland study, American study, and our Indian IDPP-1, IDPP-2 by Ramchandran study, Indian Diabetes Prevention Program. In all the program, the Metformin has been used. I'll just summarize it to say that in the Western study, the dose used was 850 milligram BD, and they found that over about 8 months to 10 months, they could lose about 2.1 kg. And in the Indian Diabetes Prevention Program, a blessings in disguise, it was observed that the low dose of Metformin at 500 milligram BD doses was equally effective as lifestyle measures to prevent diabetes in the Asian Indians. So we need only 500 milligram dose, which is very effective in our setup. Now, if you look at the other study like DCLIP study, which was done by Mohan, in the 3-year follow-up study, there is a 32% reduction in the diabetes incidence in intervention participants over the control. So, in the intervention was NSM, lifestyle modification, and or Metformin. And most participants, you see, most participants, about 72% participants required Metformin in addition to lifestyle. I am not diminishing the importance of lifestyle, but if it cannot properly done, then additional Metformin, as in 3/4 of the cases in DCLIP study and in Ramchandran study, about 80%, when Metformin was given, they found it very useful. And you know, the proper dietary study and proper supervision by sending monitors, giving training for exercise, by dietary recall, by analyzing the diet is also very expensive. So it is not, it is necessary. It is the first primary step, but Metformin becomes necessary in 75 to 80% cases. Now, if you look at this, it was also shown in a state-wise diabetes prevention program, Metformin, sometimes twice daily, reduce the 3-year risk of diabetes by 32% in overweight, morbidly obese Indians from any pre-diabetes. Therefore, we look at the ADA guideline, Metformin therapy for the prevention of type 2 diabetes should be considered in adults with pre-diabetes as typified by the diabetes prevention program. If you look at the ICMR guideline, it says when lifestyle alone is not sufficient, especially in those with combined IFG and IgT, where progression to type 2 diabetes appears imminent, use of metformin in addition to lifestyle measures may be considered, especially in Indians who progress rapidly to diabetes from the pre-diabetes stage. In our own RSSDI ESI guideline also, we have said that people with pre-diabetes failing to achieve any benefit on lifestyle modifications after 6 months may be initiated on oral anti-diabetic agents. Metformin in younger individuals with one or more additional risk factor of diabetes, regardless of BMI, if they are overweight and IHG plus IGT, metformin can be given 500 milligram twice daily for 6 months of follow-up of diet. Dear friends, the AAC comprehensive type 2 diabetes management algorithm also has mentioned that beyond lifestyle measures, majority will require metformin for preventing pre-diabetes going into full-blown diabetes. Dear friends, metformin is the first oral treatment to be approved in India for use in pre-diabetes. The approved indication of pre-diabetes is as follows: reduction in the risk of delay of the onset type 2 diabetes in adults in overweight patients with IGT or IHG or combined, or people who have increased HbA1c who are at risk of developing type 2 diabetes mellitus, and in spite of good dietary control, lifestyle measures are still progressing towards diabetes. Before I close, I'll mention two things. There are many drugs which are said to be useful for pre-diabetes to diabetes prevention, like insulin, like liraglutide, bioglitazone. All of us know proactive study, like glitazone, orlistat, alpha-glucose inhibitors, vitamin D. But all these 6-7 groups of drugs, insulin, lira, bio, rogi, orlistat, alpha-glu inhibitor, and vitamin D, they are not recommended for the prevention of pre-diabetes as per the global guideline for the two reasons. Number one, the benefits very modest, not as big as metformin. Number two, they reduce diabetes in the short term, we do not know the long term. And number two, on the pre-diabetics, where cardiovascular benefits have not been shown. So huge cost, there is not enough data. Third, not enough data in the pre-diabetics prevents cardiovascular risk factors, and cardiovascular death is not yet found out. So therefore, these drugs are not recommended today, the global guideline for prevention, pre-diabetes. The drug indicated only metformin today. Now, because of the same reasons also, because of lack of preventive efficacy or limited efficacy with drugs like biguanides, ARBs, ACIs, and estrogen are not indicated. Therefore, I will end by saying that pre-diabetes, person of type 2 diabetes, the conversion rate from pre-diabetes to type 2 diabetes is very high among Asian Indians. The risk for macrovascular disease starts at the stage of pre-diabetes, as it increases the risk of CVD events, MI, stroke, and CV death. Pre-diabetes has been linked to retinopathy, neuropathy, and nephropathy. Biomarkers help in identifying people with a high risk of developing diabetes. Identification and aggressive treatment of pre-diabetes is mandatory. Lifestyle intervention is the key, but metformin is the only pharmacological agent recommended for the prevention of diabetes or post-treatment of type 2 diabetes. Clinical experience with metformin is the largest. Randomized clinical trials in India and abroad have supported the efficacy of metformin in diabetes prevention. The pleiotropic benefits of metformin beyond glycemic control, like antiviral, anti-cancer, immunomodulatory function, anti-inflammatory function, lipid-friendly function, anti-aging, also play an important role in the long-term management of dysglycemia. Thank you very much for a patient hearing.
Thank you, Dr. Das. Wonderful presentation on metformin and pre-diabetes. Is there any question from the audience, or I could ask him a question? The question, Ashok Bhai, is that
Yes.
pre-diabetes, NAFLD and metformin.
Yeah, that's a very important question. It was believed, and it is also some people still use. They still use the metformin for the NAFLD. But the current evidence metformin is not that useful in the NAFLD progression prevention. It has given way to pioglitazone, obexopalic acid, and other newer semaglutides are coming now. So to take a short answer, my dear friend, I will tell you that metformin was indicated some time back. We are all using metformin for the NAFLD, there's nothing wrong. But today we have better drugs in pioglitazone, in the obexopalic acid, in the glutide, semaglutide, etc., which are coming into market. They are much more useful than metformin. But you are correct that metformin was used. In some cases today also metformin is being used in the NAFLD.
Any other questions? What should be the dose is the question of metformin.
So those actually, sir, is a very, very important question. I think very practical, very important question. I have used metformin for the young people who have got IGT, starting with a dose of as low as 250 milligram twice a day or 500 milligram SR. The maximum dose I have used is 500 milligram PD. So most of the patients respond to 250 milligram twice a day or 500 milligram SR once a day. Very rarely 500 milligram twice a day.
Thank you very much, Ashok Bhai. I think we are running late already.
Yeah, thank you.
Thank you very much. Give me a big hand, ladies and gentlemen.
I did and the entire team at the audience, and my regards and sincere greetings to the chairpersons for conducting the meeting early morning. Thank you very, very much. Thank you.
Thank you.
Yes, sir.
Dr. A.K. Das, sir, thank you very much for joining from all the way from the Pondicherry. We are missing you badly. Yesterday also missed you. Yes, your message was very strong at the time of inauguration. Thank you very much, sir. Thank you. Thank you.
Thank you, sir. Thank you. I'll just on share. Can you Neelam, on share my screen? Neelam, can you on share my screen? Yes, sir. So that others, Vijay can put his slides.
I would request Dr. Sunil Gupta, sir, to please felicitate our chairpersons for the session, and I would like the chairpersons to felicitate Dr. A.K. Das, sir.
Thank you. Thank you. Virtually, I will. Thank you, sir. Thank you, Sunil. I'm enamored by your kind gesture. So nice of you. So nice of you. Thank you. Thank you. I'm not physically present there because I'm in an ICMR program in a very distant village in Agartala. Agartala is in Tripura. I'm in a very distant village for a field visit for a very important diabetes program called Diabetes National Model Study, which is very important for us. Thank you.
Thank you. Over to MOC now. We are already late by almost 15 minutes. I feel you need to cover up.
I now request Dr. Debashish Chatterjee and Dr. Aishwarya Yalamanchi ma'am to chair the session and Dr. Vijay Panikar sir as speaker.
A very good morning, everyone. I first would like to congratulate Dr. Sunil Gupta sir and his team for organizing such a wonderful conference and making me a part of it. The next topic for today would be 100 years of oral hypoglycemic agents. And the speaker is Dr. Panikar sir, who does not need any introduction. Although so he is a consultant endocrinologist, Department of Endocrinology, Diabetes Metabolism, Leelavati Hospital, Mumbai. He is a very eminent speaker and is a very good researcher, has more than 20 research publications and has written many chapters in textbooks and medicine updates. So the floor is yours.
Thank you very much for a very kind introduction. At the outset, I must thank and congratulate Sunil Gupta. He's been a very dynamic character. Sunil, Are you listening? I am talking about you. वो साला उधर भी चुप के बैठता है. He has been a very dynamic character. I have known him now for over 20 years. And he has that zest, he has that zeal, कि कुछ करे. And he goes ahead with that and does an excellent job. Good show, Sunil, good show. The topic given to me is last 100 years of oral anti-diabetics. So I did some research, कि 100 साल से किधर से आया anti-diabetic. But if you look at all the oral hypoglycemics, they have gone through a lot of trials and tribulations. They have not had a cakewalk. All along they had some problem or the other. So when you talk of 100 years, the French lilac, which was a folk remedy during the old days, and from the earlier 20th century, the anti-hyperglycemic effect of this plant, guanidine, was isolated and used to treat diabetes during 1920. That would be the only OHA that I can think of 100 years. But in the 60s and 70s, the biguanides came. Metformin was widely studied in the United States. Metformin in United States. Metformin was studied in France, and buformin was studied in Germany. Now, biguanides, 1960, they were launched, fenformin and metformin, but fenformin was withdrawn in 1970 because of increased risk of lactic acid. And simultaneously, the US banned metformin in the same year. That also will cause lactic acidosis. But basically, metformin and lactic acidosis is a case of guilt by association. Metformin and fenformin are two distinct molecules. And metformin, the modest elevation of fenformin causes reduced glucose oxidation and enhanced lactic production. And I'll just show you the difference between the two, molecular wise. If you look at adherence to mitochondrial membrane, it's poor with metformin, strong with fenformin. Electron transport is absent, inhibition of glucose oxidation is absent, interference with lactate turnover is absent. And this probably explains why metformin is different from fenformin in terms of its propensity to cause lactic acidosis. And you have this Cochrane review, which was published in 2006. 2006 studies, 47,000 patient years of metformin, and no evidence of excess risk of lactic acidosis. Then came the UK PDA study, which showed that in a subgroup of obese type 2 diabetics given metformin, they had excellent cardiovascular outcomes. 32% relative risk of all diabetes-related endpoints, 42% related deaths reduction, 36% mortality. So the US approved metformin in 1994 after the UK PDA study came and showed that metformin had its benefits. So there are few contraindications to the use of metformin. They are mainly centered around renal parameters and risk of lactic acidosis. And the ADA recommendation is stop metformin if the eGFR is below 30. That is where metformin was. So what is metformin today? It is the first line glucose lowering drug in every guideline. Metformin is safe. There is hardly any risk of hypoglycemia. They mainly have GI symptoms. It is inexpensive and has been shown to reduce microvascular complication and cardiovascular mortality in some studies. Metformin-induced lactic acidosis is rare, and metformin-associated lactic acidosis, that is MALA, is often caused by other conditions. The comorbidities which are there, that is what causes the lactic acidosis rather than metformin per se. Then we come to the next molecule, the sulfonylurea. The history of sulfonylurea began in 1937 with the observation of the hypoglycemic activity of synthetic sulfur compounds. 5 years later, Jan Bond was treating patients with antibiotic sulfa group and observed hypoglycemia. And in 1946, Auguste confirmed that sulfonylurea compounds stimulated release of insulin and therefore required some pancreatic beta cells. So in the 50s, the first sulfonylurea, tolbutamide, was marketed in Germany, and this was followed by the introduction of the other first generation agents called clopropamide, acetohexamide and tolozamide. I have been in practice for almost 50 years now, and actually I have seen all these drugs. I have used all these drugs during our term as residents and subsequently. And these are good drugs, yes. But there was another story here. The UGDP study came in 1970. And what did that study tell us? It was initiated in 1960 and published in 1970 that patients who were treated with sulfonylurea, and here they looked at tolbutamide, had an excess of cardiac death. In fact, 12.7% death on tolbutamide group, 4.7% compared with placebo, 6.2% with fixed dose insulin, and if you had a variable dose, adjusted dose of insulin, it was 5.9. So this led some experts to conclude that sulfonylurea as a class is bad and it is associated with increased cardiovascular risk. And I remember those days, my bosses used to tell me, "Arey, let us not use this anymore, abhi insulin hi use karenge." And that was the momentous day for us after the UGDP study. But people questioned the UGDP, and that is when the UK-PDS study came. So UK-PDS recruitment started in 77, and then we had a whole host of studies coming. Study ended in 97. And in the UK-PDS, they had three groups: the conventional group, the intensive group. Intensive group was with sulfonylureas 1 and insulin. The metformin was a small group allotted to the obese type 2 diabetics. Now, what did you find in the UK-PDS? That all the three therapies were similarly effective in reducing HbA1c. All three therapies had equivalent risk reduction for major clinical outcomes compared with conventional therapy. And there was no evidence of deleterious effect on the myocardial infarction, sudden death or diabetes-related death. So the UGDP, which maligned the sulfonylurea, was now put to rest, and you had UK-PDS which told us that they are all equal. And if you have a good glycemic control, that is what will give you the benefit. Then came the Digami study. This was done by Mamberg, and this was diabetes mellitus glucose infusion in acute myocardial infarction. And what did they do here? All patients admitted with acute myocardial infarction who had a sugar about 200 were given intensive insulin treatment. And that insulin treatment was IV insulin for 24 hours, followed by 4 injections a day for the next 3 months. Kept them only on insulin. And what did they find? That in all subjects there was a 28% risk reduction. In those patients who were not previously on insulin, there was a 51% risk reduction. So it became the norm at that time. I remember the cardiac surgeon, cardiologist, all surgeons, "Arey, discharge me insulin hi rakhna." Everybody said, "No, post-operative only insulin, peri-operative only insulin, discharge at least for 3 to 6 months on insulin." That was the fallout of the Digami study. Now this insulin glucose infusion, like this I have already told you, but there were certain concerns and arguments. Other medications not reported at 1 year and 3.5 years, the conventional group and the intensive group, the insulin group. Sicker patients were excluded. The patients who were on insulin, they had more frequent visits to the physician and they had a decent control of sugar. The conventional group was left to fend for themselves. They had poor control, so how could you compare that? So overall reduction of mortality of MI could indicate bias. So then came the Digami 2 study. And what was Digami 2 study? 48 hospitals, 6 countries, 3 groups. Group 1 was given a glucose insulin potassium infusion 24 hours followed by home treatment, just like in Digami 1. Group 2, followed by standard control. Initially given insulin infusion and then given standard control. And group 3, routine metabolic management based on local practice. But in all these 3 groups, they saw to it that the glycemic control was adequately maintained and comparable. So what did they find? Overall mortality was lower than expected. Overall mortality similar to non-diabetic population. 3 glucose management strategies did not result in differences in metabolic control. They all could control their glucose very well. Target glucose levels were less frequently achieved in the intensively treatment insulin group. So here, what came out of Digami 2 was that don't talk about insulin, that insulin is going to do this X, Y, Z. No, it is good glycemic control. If you achieve good glycemic control, that is your goal. So what was done to show that, oh, OHs are bad? No, all that is gone. It is good glycemic control. This was that a lot of studies now show that sulfonylureas do not increase the risk of cardiovascular disease. Then in 72, glycoside was approved. It was patented in 66. Glipizide and gladuride came in 84 and glimepiride came in 95. Then came the Carolina study which confirmed that sulfonylureas are safe when it was compared with. So the key takeaways from all this was that sulfonylureas are the most commonly used second line drug. Last line, one of the most important findings to emerge from this set of trials was the CV safety of sulfonylurea. All the cardiovascular safety trials showed the benefits. So sulfonylureas are good molecules. Then the glitazones. 1996, glitaglitazone was launched, but it was stopped because of hepatic side effects. And in 2000, you had rosiglitazone and pioglitazone. Then the rosiglitazone came into trouble by Steve Nissen, who showed that there was increased cardiovascular death with rosiglitazone. It was almost banned everywhere, including India. But today, as of 2013, the rosiglitazone has been given a clean sheet. And at that time, when rosiglitazone got banned, the greatest beneficiary was sitagliptin. The sales of sitagliptin just zoomed. Subsequently came the pioglitazone bladder cancer trials. France suspended in 13th of June 2011, Vietnam suspended it, but Vietnam withdrew it, and India banned it in June 2013. So pioglitazone banned by Union Health Ministry, the scientific evidence was ignored before banning the drug, the whole issue was taken up by the advisory board, and finally on 31st July, Government of India revoked the ban on pioglitazone. There is a lot of story behind how this got banned. That is another thing. But as of today, this is a comment by Robert Ryder and Ralph DiFranzo, that pioglitazone is inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer, plenty of evidence of cardiovascular benefit. In conclusion, pioglitazone is a very valuable treatment option in Indian patients with type 2 diabetes recommended by the guidelines. Benefits far outweigh the risk in those patients responding well to pioglitazone. Careful selection of patients and monitoring the response will help in optimizing treatment. Then came the DPP-4. All these DPP-4s came, they reduced the HbA1c by 0.6 to 0.8. All these studies were done, DPP-4, CVOT studies, and what they ultimately came out was that it can increase heart failure. That is the US FDA drug labeling. It can also cause disabling arthritis, which could start anywhere from 1 day to 1 year of treatment with DPP-4. And what is our experience? Till 2008, we had only these 3 drugs, sulfonylurea, metformin, and glitazone. And when the 4th drug that time was insulin, now DPP-4 came, could we use 4 drugs? Yes. In fact, we did the study, efficacy of DPP-4 as a 4th drug, and wonderful results. In fact, almost 80% of the patients did not have to go on to insulin, adding DPP-4 as the 4th drug when it had come in the market. Vildagliptin had a short time here, went out. Colesevelam is not available here, but it's okay once. SGLT2 came, beautiful results, reduces atherosclerotic events in secondary prevention, but heart failure across the board in primary and secondary prevention, excellent renal benefits across the board with all the SGLT2s. And then SGLT2, when it was launched here, this was the previously before 2012 we had 4 drugs, and now we had a 5th drug. Could we use a 5th drug? Yes, we did that. This is efficacy of SGLT2 as a 5th drug. So when insulin is not an option, you could still use it as a 5th drug. Good results here. I'm going fast because I'm running short of time. Almost 80% of the patients didn't need to be on insulin. But at that time, the cost of SGLT2 was tremendous. Today, fortunately, it is quite low. It has become generic and it is affordable to all our patients. And now we have a new molecule, the oral semaglutide. All these pioneer studies have shown that it has a good HbA1c reducing effect, almost 1 to 1.5. Body weight changes 3 to 5 kg. But what is it? The studies have shown that semaglutide is not inferior to placebo. The cardiovascular benefit, Pioneer 6 showing 21% non-significant reduction in MACE. So we yet to have strong evidence to show that it has cardiovascular benefit, but the other studies have shown. But when you look at currently what are the OHAs available, combination should address the pathophysiological targets. You need to achieve good glycemic control. All your OHAs can do that. Preserve the beta cells, which will give you durable glycemic control, only a pioglitazone. Treating insulin resistance, only a pioglitazone and metformin. Should not cause hypoglycemia. There are only 2 molecules which will cause hypoglycemia, sulfonylurea and insulin. Should not cause weight gain. Only 3 molecules will cause weight gain, insulin, sulfonylurea and the glitazones. So SGLT2 and GLP-1 will cause weight reduction, and now we will be having twin cretins very soon coming, which gives you almost 20% weight reduction. Renoprotective benefit, again, SGLT2 is the main, DPP-4 some studies have shown and PIO has shown. And cardiovascular benefits, metformin, PIO, SGLT2, GLP-1. So these are the drugs which we today have in an armamentarium, and we are quite comfortable with that. So you could have pathophysiological cocktails, multiple, since I already rang the bell. So the strategy is macrovascular damage starts many years before the onset of diabetes. And microvascular complications are linked to dysglycemia. So your retinopathy, nephropathy, neuropathy starts after your sugar goes up. But your macrovascular complication starts more than 15 years before the onset of diabetes. And that is driven by insulin resistance. So insulin resistance and its complications and beta cell preservation have to be adequately addressed for long-term outcome. If you address insulin resistance and dysglycemia right from day 1, we will be able to prevent and minimize all diabetic complications, including NAFLD, which is driven by insulin resistance. Metformin plus PIO, most durable, less weight gain. Add an SGLT2 and that becomes an unbeatable combination. So you have a metformin, PIO and an SGLT2. You could add GLP-1 also, if cost permits. So metformin, PIO gives you the best results when endogenous insulin are present. I won't go into this. Thank you very much, ladies and gentlemen. So the current scenario is you have all your molecules today, all the OHAs are now considered safe. There is no question of any doubt in your mind. When to use, how to use is your prerogative, understanding the pathophysiology of type 2 diabetes and treating accordingly for the best outcome for your patient. Thank you very much.
Thank you, Dr. Panikkar. Excellent talk. History of oral hypoglycemic agents from biguanide to SGLT2 and semaglutide. You covered each and every corner of this topic so nicely. I don't think that any question is there from the audience. Even then, I will request any question from audience. They are welcome.
Thank you.
I think there is no question. Thank you, sir.
Thank you, sir.
Thank you very much.
Thank you.
I request Dr. J.K. Sharma, sir, to felicitate the chairpersons, please. And the speaker.
Thank you so much, sir. Now we have achieved our required altitude and now we can go steady. For the next session, I would like to invite the chairpersons, Dr. Shankar Vasisht, sir, and Dr. Anand Kate, sir. Dr. Shankar Vasisht, sir, is a senior general physician from Nagpur. Dr. Anand Kate, sir, is a consultant physician, internal medicine, Nagpur. We welcome you, sirs. Over to you, chairpersons.
Thank you, Dr. Sunil, for including us to come here and be chairpersons for one session. We all know when we should do HbA1c, but what we should know is what are the instances when we should not do HbA1c. To enlighten us on this, we have Dr. Sunil Jain, who will start his lecture. He is a DM endocrinology from JIPMER, Chandigarh, and also consultant endocrinologist and total diabetes hormone institute in Indore. He has been a key faculty for CME like PGC, DMR, and diabetes and PGC 84 thyroid. Over to you, sir.
Good morning. Thanks to chairpersons and thanks to Dr. Sunil Gupta and team for inviting me. And in next 15-16 minutes, I will be talking on when not to do HbA1c. Obviously, we understand that HbA1c is an important test, but we have to simultaneously understand that HbA1c is an indirect test. It is the glucose and hemoglobin binding which creates HbA1c. And that's how glycated hemoglobin, which was described, we know that glucose has to enter inside the RBC and then it is going to bind to the amino acids on hemoglobin, and that's how it is going to create HbA1c. So we need to know few fundamentals. Then only we can understand the HbA1c and when not to do it kind of thing. Now, there is a HbA1c and glucose connect. That's what we understand, that 1% increase in HbA1c will lead to around 25 to 30 milligram, and that's how these tables are created. Now, few basics. Where does the glucose bind to hemoglobin? Just to understand that hemoglobin, normal adult hemoglobin is having alpha chain 2 and beta chain 2, and that's how this is a tetramer, and on the beta chain, at the terminal portion, there is an amino acid called valine, there glucose is going to bind. Obviously, now to understand HbA1c relationship, if anything goes wrong is the hemoglobin structure, then the HbA1c will become a less reliable test. So now we are assuming many things when we are considering that, okay, HbA1c is a representative of last 3 months of average glucose. These assumptions may be correct in around 85 to 90% of our patients in practice, but in around 10 to 15% patients, these assumptions may not be correct. As I told you, that is the binding relationship. That's how we are considering. If mean RBC age is consistent among individuals, that is an assumption. We are considering that the adult hemoglobin, I have told you that it is binding to primarily the beta chain valine amino acid in HbA, so this percentage also matters. We are considering that this ratio is consistent. We are considering that the entry of glucose inside the RBCs is happening at a consistent rate among all human beings, which is actually not happening, and which is responsible for a concept called glycation gap. And glycation rate, so there are so many variables here now. How the erythropoiesis is happening. Suppose erythropoiesis becomes faster. Let us take an example. Somebody had a bleed. Now a big GI bleed has happened to somebody. What will happen? A lot of blood loss happened. New RBCs are appearing into the blood, and these new RBCs obviously are now going to have a diluting effect, and that's how the HbA1c go on a lower side. Somebody who is having CKD, and now you started erythropoietin therapy, and now new RBCs appearing into the system, scenario will change. Then secondly, the binding relationship of glucose with hemoglobin. Again, there are many influences here. Then comes the glycation rate. Then any structural alteration in the hemoglobin. We know there are more than 1300 hemoglobin variants are described, while a specific structure for a normal hemoglobin is needed for this glucose hemoglobin binding. Erythrocyte destruction. There are many instances when erythrocyte destruction is going on faster. That means the RBC lifespan changed. That means our all assumptions of calculating glucose to hemoglobin relationship are gone. And there are few laboratory assay interference as well. And that's how these are the instances when we can have glucose HbA1c disconnect. And that means those are the circumstances when we should not do HbA1c, or we should understand how to interpret it. Let us take few examples. Anybody who has vitamin B12 deficiency, which is rampant in our country, folate deficiency, many patients of CKD, aplastic anemia, what will happen? Here there will be a false increase in aging, also has been connected with more glycosylation of the proteins. So what will happen? The HbA1c will go little on a higher side. Erythropoietin therapy. Iron therapy in a patient with iron deficiency anemia. Iron deficiency anemia also causes false increase, but the mechanism is different. Loss, etc., as we discussed. Now, there are so many HB variants, and we know that the sickle cell causing hemolysis. Then there are certain HB variants which are not causing any hemolytic anemia, but again, there is a change in the amino acid on the beta chain, and because of that, hemoglobin A1c measurement becomes unreliable, and there are two hemoglobin variants I would like to specifically talk on. There are more than 1300, but here there are two which are seen in our day-to-day practice. One is called hemoglobin D or Punjab, hemoglobin Punjab. Another is seen in the eastern part, like this Assam and that region. There are many patients who are having HBE. This is also very common in the Thailand and those regions. And here, if you are doing HbA1c by HPLC, then it becomes erratic. While in HBD, that is hemoglobin Punjab, we have seen a variable results in HbA1c, and sometimes patients reporting with the HbA1c of 10 and they are non-diabetic. These are also such circumstances has been described. So these are the scenarios. In addition, these hemoglobinopathies can cause hemolytic anemia, and that's how it can cause falsely low amino acid alteration, altering the binding capacity and interfering in the methodology. Fetal hemoglobin. Let us take an example of a neonate, and suppose this neonate is having diabetes, neonatal diabetes. Now we know that at birth the majority of the hemoglobin is fetal, and fetal hemoglobin is having HbF, that is the gamma chain, and gamma chain has glycine rather than valine at the terminal chain, and that's how the relationship now will alter. Now the glucose can't bind. effectively as much it is doing with the valine, and that's how you will see that the HbA1c will be falsely low and not a reliable test there. There are certain conditions like hereditary persistence of fetal hemoglobin, and many hematologists treat their patients with hydroxyurea, which is known to increase the fetal hemoglobin, and that's how it is going to cause a falsely low HbA1c. And these hemoglobin variant we already discussed. Some may interfere on one of the most popular method which we use for HbA1c measurement, that is HPLC. Because when glucose binds to hemoglobin, it increases the net negative charge on hemoglobin. Now this hemoglobin runs faster than electrophoresis, creates a separate band, and that's how HPLC is considered as a very good method, because now it is going to form a different band when we are using HPLC method to measure hemoglobin A1c. Another interesting concept of glycemic variability, and that's what I was talking about, that it's assumed that the glucose is entering inside the RBCs and binding to hemoglobin with a constant rate in every individual, which is not going to happen. And you see in clinical practice that few patients have HbA1c around 7, but their SLPG trends are generally on a higher side. Another patient who also has a HbA1c of 7, but their HbA1c trends are on a quite lower side. Still both patients have a same HbA1c, and it is because few individuals' hemoglobin binds to glucose more avidly. They are called high glycators, and that's how, in spite of a good glucose level, their HbA1c on a bit higher side. On the contrary, there are few whose glucose hemoglobin relationship is less avid. They're called low glycators, and that's how this concept is called glycation gap. Increase people who have high glycators. Then iron deficiency state. And I tell you, if we consider like as ADA considered HbA1c 6.5 or more as a criteria for diagnosis of diabetes and a solo criteria, I believe that in India we are going to diagnose falsely many patients with diabetes who are actually normal glucose tolerance because of just iron deficiency. Because iron deficiency leads to a lot of alteration in our system, and it leads to increased lipid peroxidation and increase in a compound called malondialdehyde, which leads to more binding of glucose with hemoglobin, and that's how up to 1 to 1.5% increase falsely can happen in iron deficiency anemia. High dose of aspirin, aging also increases glycation, while low glycators, and these are the things which are associated with false decrease. Erythrocyte destruction rate. Somebody who had underwent splenectomy, obviously what will happen to their RBC survival? It is going to increase. Now the same RBCs are circulating for a longer duration in blood, so hemoglobin has a higher chances to bind with glucose, and as I told earlier, we are just measuring a percentage of the glucose bound hemoglobin versus normal hemoglobin. That percentage will go up. This is obviously hemoglobinopathies, G6PD deficiency, hemolytic anemia. These are well known. But what often is missed are certain drugs. Now, patients with leprosy receiving Dapsone. Now, this Dapsone is causing subtle hemolysis. And do the HbA1c of the patient. You will see their HbA1c around 5.5, 5.66, and you feel, oh, very good control. But look at the glucose, it is 250, 300. That happens. And one more issue, patients who are having cirrhosis, portal hypertension, splenomegaly, and because of now their RBC destruction is going on a faster rate, and I have seen these many such patients in whom I see their HbA1c is quite low. So cirrhosis, hypersplenism, please be careful in interpreting HbA1c. The HbA1c may be normal, blood glucose may be 250, 300. RBC lifespan in such situations has been shown to get reduced from average of 120 days to 20 to 30 days. That's the huge big difference can happen when the patient is having a big splenomegaly and hypersplenism. And CKD can have both variances. A patient with a triglyceride more than 800, when you do a diagnosis of diabetes, there are many patients whose triglyceride can be more than 1000. Lipemic sample, it can decrease HbA1c, while hyperbilirubinemia can falsely increase. So many clinical settings are there when, and I told you that's how 10 to 15% circumstances when you have to see that how to interpret HbA1c. So don't just jump on a conclusion when you see a HbA1c of 10. There can be reasons other than glucose also, which may be responsible for this alteration in HbA1c, and these are the many factors which I try to touch upon in my presentation. And specifically, one important point for clinicians, if any patient has a significant anemia, always first try to understand what is the cause of anemia before interpreting HbA1c. Your patients may have autoimmune hemolytic anemia, they may have different HbA1c, hemoglobinopathies, they might be having hypersplenism, they might be having G6PD deficiency, they might be on drugs, like we discussed Dapsone, erythropoietin therapy, etc. And here there will be a false decrease in HbA1c. While iron deficiency anemia can cause false increase in HbA1c, you see somebody whose hemoglobin is 8.9, microcytic hypochromic anemia, and HbA1c reported is 7.2. Don't label this patient as diabetic, and the treatment is not metformin, treatment is iron therapy. And if you give iron therapy, this patient's HbA1c is going to revert to normal because it was no hyperglycemia. Similarly, all these nutritional anemia, including B12, folate, can cause false increase in HbA1c. So, my comments about some practical tips on HbA1c. The interpretation should be based on complete medical history. When unexpected results are there, then always consider that the glucose-hemoglobin relationship seems to be disconnected, and you should find out the reason, and then finally decide whether you should carry on HbA1c for this patient or now discard HbA1c as a test for glycemic control. And that's what those 5 factors we discussed. And if you feel that, okay, HbA1c is not appropriate for this patient now, then consider other ways of measuring HbA1c like SMPG, glycated albumin. You know, now in CGM technology, we measure a parameter called glucose management indicator, which is basically a similar kind of thing like a calculated HbA1c based on those data. So they are the glucose representative information giving us average. That's how we can use it. So any patient with significant anemia and polycythemia, hemoglobin variants, including high HbF or fetal hemoglobin state, as I discussed, specifically in neonatal period also. History of splenectomy or any patient who is having hypersplenism, and CKD stage 4 onwards, it can be both ways, falsely low and falsely high. G6PD deficiency, blood loss, blood transfusion, many drugs, very high TG, etc. So it's a large number of clinical scenarios if you interpret it, and that's how there are many areas where we should be careful in interpreting HbA1c, and I try to enumerate and highlight and give explanation for the reasoning behind the same in my presentation. Thank you very much.
Thank you, sir. I think Dr. Jain elaborately explained the fallacies of interpreting HbA1c, especially in our scenario. In cases of anemia and hemoglobinopathies, it is very important. So it is necessary to remember that glucose, blood glucose disconnect with HbA1c and interpret the results of HbA1c. Any questions from the audience, please?
Nice talk, Sunil. Wonderful. The IGS and the IFCC method of estimation of hemoglobin A1C is supposed to be much more superior. It has tried to overcome all the fallacies which you mentioned earlier. So many countries now have adopted IFCC method of estimation of hemoglobin A1C rather than the NGSP method which you have been talking about all this time. Except countries like US, Japan and India are the only one who go by percentage of the glycation of the hemoglobin. What is your opinion about it? Whether we should adopt that policy to overcome all these problems of interpretation of the A1C?
There are two comments. Number one, IFCC is just a representation of a different way. One is talking of percentage and they are talking of millimole. Methodology remains the same. And if the methodology means there are 4 ways of measuring HbA1c. Either you can go by HPLC, you can go by boronate affinity chromatography, you can go by immunoassay method or enzyme linked method. Now, whatever are the results are there, if they are expressed in millimole, that is IFCC. If you are representing in percentage, NGSP is certifying all these 4 methods. So whatever we are talking clinical scenario, they are not going to get solved by just changing the millimole to the percentage units.
When I heard David Sachs talking about the A1C, he said that the estimation method by IFCC is very complicated. It's time consuming and labor intensive. And therefore, there is a formula which is used now to convert the IFCC to the NGSP to IFCC. But that formula conversion is not accurate. It is just for a working formula. But if you look at the methodology of estimation of A1C by that method, it's very labor intensive.
It's a 0.0191 multiplied by 3 divided by HbA1c. That is the formula which is being done for IFCC. But please try to understand, we are not going to change the scenario because iron deficiency has created the difference. Now, whatever the methodology changes, the physiology is not going to alter. That's the big limitation.
Thank you. If there are no questions, we'll conclude the session. Thank you very much, sir.
Thank you.
Thank you so much, respected chairpersons and respected pilots, sir. I would request the chairpersons to felicitate the speaker, Dr. Sunil M. Jain, sir. I would request the organizing chairman to felicitate the chairpersons, Dr. Anand Kate, sir, and Dr. Shankar Vasisht, sir. With this, now we move on to the next session. For this session, I would like to invite the chairpersons, Dr. J.K. Sharma, sir, and Dr. S.D. Suryavanshi, sir, from Nagpur. The pilot for this session is Dr. B.M. Makkar, sir, from Delhi. Over to you, chairpersons.
Please. Good morning, all. I think Dr. B.M. Makkar does not require any introduction, but as a customary, he is Director Dr. Makkar's Diabetes and Obesity Center. He is President-elect RSSDI. He is member of American Association of Clinical Endocrinology International Committee, Post-Director of Advanced Certificate Course on Diabetes, and he has a lot of publication in books, national and international journals. Over to you, Dr. Makkar.
Thank you, sir. Good morning, everyone. At the outset, I would like to thank Dr. Sunil Gupta and the organizing committee for this very kind invitation and all the hospitality that I've been, enjoying. I am going to speak on Vildagliptin, stepping up the game for improved adherence. And this is a sponsored session by Novartis, and this is my disclosure slide. So this presentation, I'll briefly introduce why diabetes is a major concern in Indian setting, why it is important to achieve good glycemic control and why we are not able to achieve the same, and how lack of adherence to therapy is a major challenge, and how by improving, the decreased frequency of dosing can help in improving adherence and achieving the glycemic goals. So this slide basically shows how the prevalence of diabetes has increased in India. In 1980, we had only about 12 million diabetics. In 2016, we had 64 million diabetics. And currently, we have more than 74 million diabetics. So from 1980 to 2022, our number of diabetics has increased by more than 6 times in last 4 decades. That is the kind of disease burden we are looking at. Now, why we have so much diabetes, being seen in India? Is it related to our Asian Indian phenotype? We all know that we are a different ethnicity, which has higher predisposition to develop type 2 diabetes, coronary artery disease, dyslipidemia, and all kinds of problems. And this is because we have higher body fat, higher fat mass in the body at lower levels of BMI. So if we compare ourselves to the Caucasian population, we have almost 2 times higher body fat for the same BMI as Caucasians, and this is associated with higher insulin resistance and higher lipid levels and higher level of inflammation in our vessels. And this is what leads to increased risk of developing diabetes and coronary artery disease in Indian setting. And if we look at the comparison with Caucasian population, we had a study way back in 2000 which showed that we get diabetes almost 10 years earlier as compared to Westerns. Now we are getting data that diabetes is happening almost 20 years earlier as compared to our Western counterparts. And this is because of the increasing level of overweight or obesity in younger population. And because we are getting diabetes early, we have longer duration of diabetes to live with. And the longer the duration of diabetes, the higher is the risk of developing complications. So young onset diabetes impacts Indian during early part of life and predisposes to higher risk of complications. And this slide shows the prevalence of diabetes in various age groups. And if you see at the age of 40 years, almost 20% of people are having diabetes. And at the age of, after the age of 60 years, we have almost 2/3 of the population with diabetes. Now, if you look at the level of glycemic control, I think this is a misprint here. Almost 75% of type 2 diabetes patients fail to achieve good glycemic control. The average A1C, the people who are achieving A1C level of less than 7% is only about 25 to 30%. And this leads to increased risk of mortality, morbidity, high cost of care, high risk of hospitalizations, poor quality of life, absenteeism from work, loss of income and all that stuff. So it is very important that we try to improve the average glycemic control. And to do that, adherence is one of the important, modifiable factors which should be looked upon and improved to improve the glycemic control. So if you look at the adherence level, only 43.5% of Indian patients showed adherence, good adherence to anti-diabetic medication. And this is again one of the factors leading to unfavorable outcomes in terms of glycemic control. Now, what are the factors which contribute to poor medication adherence? The first thing is lack of awareness about disease. Poor level of awareness or education about disease is one of the key factors. Then everyone, needs to have intensification of therapy. So it is not that you have started somebody on 2 drugs today and lifelong person can continue on same dose, or the change is not required. So ongoing changes in treatment are required. Treatment complexities are issue. Then you have to use, multiple dosing. Things like AGIs need to be given with every meal. the person tends to feel, to forget the medication. Fear of hypoglycemia is one. And, there are multiple factors. One other important factor in the Indian setting is the cost of therapy. People tend to save money if they are feeling all right, they are not testing sugar, they feel I am doing fine, they tend to skip medication. So studies have shown that higher the dosing frequency, higher the chances of adherence. People who are taking only once day dosing, the chances of adherence are 80 to 95%. But if they are taking twice daily or thrice daily, the adherence drops to anything between 40 to 70%. So having reduced dosing is very important. So if you address adherence, try to improve adherence, it is an important factor which can help improve glycemic control. And the galvasode, which is the Novartis molecule which is sponsor for this session, is now Vildagliptin once daily preparation, which is modified release Vildagliptin. Earlier we were using 50 milligrams twice daily. So this is a modified release Vildagliptin 100 milligram, which comes as a single pill to be given before breakfast in the morning. And this is the mechanism of action. This has a gel polymer coating. And once it is ingested, the outer coating gets wet and starts swelling. And the drug in the outer coating gets released into the stomach. And as the tablet absorbs more and more, water, it starts swelling. And the drug inside the matrix diffuses into the gel. From gel, it goes by a simple diffusion across the concentration gradient into the stomach. And once this drug has absorbed more than required water, it starts disintegrating and you'll have the drug coming from the core of tablet. So there is a long ongoing release of medication which gives you 4 hours good glycemic control. This was a study which looked at the comparison between Vildagliptin 100 milligram and 50 milligram given twice daily and showed that if you look at the mean DPP-4 inhibition time, at 1 hour of dosing, there was 90% inhibition. And this was seen both on day 1 and day 6. So right from day 1, you start getting good inhibition of DPP-4 enzyme, and it stays during the course of therapy. And this is same whether you are giving twice daily dosing or once daily dosing. And this is the, this slide basically shows that even with 100 milligrams dosing, the peak concentration, the Cmax, doesn't shoot up more than the normal release tablet. There is always a fear that you are giving double dose, you will have a higher Cmax. That may lead to increase in the risk of getting adverse events. So the Cmax is not going up and the safety is maintained, so there is no increased risk of getting adverse events. And the study clearly showed that there was no adverse events, there was no issue relating to the PK/PD of the single dose formulation or the change in the vital parameters of the subjects who were there in the study. Another thing that was observed was that efficacy and safety of both the formulations was similar, or safety was as good as when it is given 50 milligram twice daily. So this study looked at that once we are giving once daily Vildagliptin, what is the area under effect? What is the glucose control under particular time slot? Does it change during 24 hours? So, and it was comparison between 50 milligram twice and 100 milligram once. So 0 to 5 hours, there is no difference in area under effect for glucose. 6 to 10 hours, again, there is no change. Between 10 to 24 hours, again, the area under effect is similar, whether you are using twice daily or once daily, and overall 24 hours area under effect is also similar. To summarize my presentation, once a day formulation gives you better adherence. It has similar efficacy and safety compared to Vildagliptin twice daily, and tolerability is also good. So it is an effective and safe mode of treatment for patients with type 2 diabetes, reducing the pill burden and improving the adherence. With this, I conclude my presentation. I would like to invite you all to come for the RSSDI National Conference at Chennai on 6th to 9th October. And please block your dates. It is going, after 3 years, we are having this face-to-face meeting, and we are expecting more than 5,000 people joining, and you will see a wonderful scientific program also. Also, I would like to invite you for the advanced certificate course in diabetes that I've been running for last 12 years at Delhi on 27th, 28th August. This is in collaboration with ESD. Thank you.
Thank you very much, sir, for this wonderful presentation and very pragmatic approach in treating the diabetics, particularly in reference of increased compliance of the patient by once a day. I was thinking this is a glucose-dependent action of the DPP-4 inhibitor.
Absolutely.
Which increases the level of the GLP-1.
Yes, sir.
Decreases the level of glucagon and increases the level of insulin. Being glucose-dependent, what is the relationship between a slow-release drug and the glucose-dependent, because the prandial and postprandial...
Very, very important question. I think you need to connect two things. We clearly know that all these DPP-4 inhibitors or GLP-1 receptor agonists, they act in a glucose-dependent manner. Why? Because once the glucose level drops low, there is decrease in the GLP-1 secretion from body or increase in the glucagon level. Both are going to the baseline. Normally, GLP-1 is reduced, GIP is increased, glucagon is increased. That is why you want to give DPP-4 inhibition. Now, what is DPP-4 inhibition doing? Increasing the half-life of GLP-1. And it is the under the effect of GLP-1 that you have glucose-dependent action. Okay. Now, this drug is only inhibiting DPP-4. So we are concerned that DPP-4 inhibition is good for 24 hours time. Whether it is twice daily dosing or it is once daily dosing, how different is DPP-4 inhibition? And I showed you the study, PKPD study, that right from 1 hour, you have almost 90% of DPP-4 inhibition achieved, which is sustained over 24 hours.
So the extent to which the DPP-4 will be inhibited will remain constant throughout with such type of preparation.
Yes. I will take you back to the slide if it goes. Oh, no, it's already other presentation.
All right, sir. The questions are invited for this important topic if there is any question.
One more.
What time should we take it?
The best, again, taking cue from what sir just asked, that it gives you glucose-dependent action. So when would you like the DPP-4 inhibition maximum? The maximum DPP-4 inhibition is required when you are taking food. So you should take this about 1 hour before food. 1 hour you are having maximum DPP-4 action happening, and once you are taking food, it is already acting, and it is acting for next 24 hours.
Would it be compatible with metformin if it is combined with metformin in a single dose?
I am not sure. This particular formulation is not available as metformin combination as of now. And if it is combined, we have to see what is PKPD data.
Sir.
Is it only DPP-4 alone that is inhibited, or DPP-6, 7, 8? They also have some...
the affinity for DPP-4 inhibition is few thousand times higher as compared to 6, 7, 8, 9. So there is negligible effect.
It is negligible.
Yeah.
So, with that, we close this session. Thank you very much. Thank you, everyone. Thank you, sir.
Thank you so
Thank you,
much.
sir. It was a wonderful talk.
Thank you so much, respected speaker and respected chairpersons. I request the chairperson, sir, to felicitate Dr. B.M. Makkar, sir. With this, now we move on to the next session. A highlight of the conference, the Hello Diabetes Academia Sushruta Oration. For this session, I would like to invite the chairpersons, Dr. Ramesh Munle sir and Dr. Sunil Gupta sir. We recognize the presence of MMC observer sir, Dr. Pradeep sir, Rajdeep sir. I request the team HDA to please prepare the oration.
A very good morning to you all, and we are going to listen to Dr. Muruganathan. I think he has come here on a couple of occasions, and he is one of the best orators in the field of diabetes and medicine. Dr. Muruganathan is MD, FRCP, FACP, and FRCP. He is basically a general medicine man, but with a special interest in diabetes. He was an ex-emeritus professor at Tamil Nadu MGR University, the immediate past governor of American College of Physicians of Indian chapter, the dean, Indian College of Physicians, president of Hypertension Society of India, past president of Association of Physicians of India, 2013 and 14, the past president of Tamil Nadu IMA and past dean of IMA CGP. He is the editor for Adult Immunization, Progress in Medicine, Medicine Update, 2013 and 17, and a Manual of Hypertension. And the various honors he has received is B.C. Roy Award for President of India 2005, WHL Excellence Award in Population Hypertension, Best Performing Doctor Award from Tamil Nadu Government, received Lifetime Achievement Award from Dr. MGR Medical University, Dr. Savitha University and KG Foundation and Dr. Mohan's Institute and Indian Society of Hypertension. With these words, I present to you Dr. A. Muruganathan.
So we have a pleasant task of giving him the oration. And before he starts his oration, we will have a small cultural, traditional way of felicitating him with the shawl and striefel and the medallion.
The citation reads, Diabetes Care Foundation of India, Nagpur, and Sunil's Diabetic Care and Research Center, Nagpur, is privileged to award Hello Diabetes Academia Sushruta Oration 2002 to Dr. A. Muruganathan for the yeoman services in the field of medicine and exemplary delivery of oration on clinical errors, myths, and misconceptions in diabetes. During the 8th Hello Diabetes Academia 2022 International Conclave on 24th, 25th, and 26th of June at Nagpur. This is from Dr. Sunil Gupta, Managing Director, and Dr. Kavita Gupta, Director and Trustee of DCFI Nagpur.
Good morning. Good morning.
Good morning.
This is Captain Dr. Muruganathan calling from HDA Airport in the Hippocrates channel. Sit back and relax. I think our crew team, under the leadership of Kavita, would have taken care of all your nutrition and diet and then your comforts. So with this, I will take you to the maybe 40,000 feet high. You may get some turbulence
not because of the flight, because of my, fumbling. Please bear with me. Again, I tell you, put all your mobile phones in the flight mode. Let me take the flight. I thought, when I saw the HD airport and the channel and the captain and the pilot, navigator, I thought also this is very good. But, medicine is also like that. You'll have to take navigation, you have to get good experts. You should have good host, everything in the conference. The conference was fantastic. I think we should give a appreciation to the host, Sunil Gupta, Kavita, and the family are taking care, especially yesterday night cultural program was very good. I see a lot of my good friends, Anand Kate is here. I'm very proud, the Vidarbha chapter in Nagpur was inaugurated by me when I was the president of API. And I see Sadashiv Rao and then Makkar, J.K. Sharma, all my good friends are there. So I'll now take you to the topic. Few days back only, Sunil told me the oration topic. He said, you also add clinical error. Originally, I was supposed to talk on myths and misconception, but he said you add clinical errors also in the subject. I thank Makkar because Makkar is a very good friend of mine. He finished his talk 7 minutes earlier. So please, the master of ceremony or the people, please make a note. Makkar has already told me you can take those 7 minutes in my account. So let me talk with that background. Now the oration is called Sasutra oration. All of you know who is Sasutra, was the surgeon in the Gupta courts. Again, Gupta courts. Sasutra is in Gupta courts. Samrita, that is Sasutra, Samitra, surgeon. Now, I always start with clinical errors. So many errors are there, clinical errors. It's a very big topic by itself. And the clinical errors may be due to diagnosis, management, prescription, talking, so many things. Even the previous speaker spoke about HbA1c. In case if you have iron deficiency, you get a false HbA1c. This happened about 20 years back in one of the hospitals. A lady came. What was the diagnosis? It was diagnosis very obvious with vein engorgement and all that. So it was ascites. The junior doctor started giving Lasix and then take care of all these LFT, etc. And then only then the senior doctor came and saw the patient is a lady, and the lady was pregnant. It was not ascites. The junior doctor did not ask any history. He saw the picture like this. Everybody is tempted to say it is ascites. And then the chief asked the lady, why didn't you tell that you are pregnant? No, he did not ask me. So please, ladies and gentlemen, clinical history, clinical examination is also the order of the day, even in 2022, with so many gadgets around. Again, another fascinating story. See, sometimes when you are tall, it's good, but when you are doing a presentation, the computer is down, so we have to lift it or, we have to bend down. It's a fascinating story. A 23-year-old girl came, palpitation, glucose recorded was 600. Immediately, the junior doctor gave 10 units. After 10 units of insulin, she was admitted again with hypoglycemia, with palpitation. When you recheck the hemoglobin, when HbA1c it was 4.9, RBS was 82. What was the reason? You can see the blood test HbA1c. This is date. This lady was taking dates and then coming to the clinic without washing the hands. Then the blood sugar was this much. Shilpa, welcome Shilpa. So the moral of the story is you should wash your hands properly before you do a blood test. It's not an exaggeration. This happened in one of the hospitals. And the patient always remembers dates. And recently also we saw the patient. And I saw the literature. It was reported. Somebody took a banana and then the leaves, the skin, without washing, it took the blood pressure, blood sugar, it was high. So you have to wash your hands, even with some soaps, sometimes it doesn't go, they say. So simple washing of the fingers, diagnosis based on only capillary glucose, insulin administered without verifying, don't make diabetic diagnosis with one single value. Then this is again real case scenario. You can see they always give 10U, 3U, 5U like that. The U sometimes looks like 0. So what is 6U becomes 60 units. So please make sure you write legibly, and then 3 international units becomes 310 units. So always mark the units in a separate thing, and don't give telephonic order. And especially with your accent, when you say 30, it looks like 30. When you say 40, it may look different. So always give a specific order, don't give a telephonic order. And now the recent NMC guidelines, teleconsultation, you should be very careful when you give telephonic orders. Again, this is a 60-year-old lady presenting with a recurrent severe hypoglycemia, glucose 32 milligram, severe hypoglycemia with confusion, resolved with dextrose infusion. What is it? In market you get insulin vials 40 units, some vials are 100 units. And you have 40 units syringe and 100 units syringe. If suppose you take 100 units vial in 40 units syringe, you know what will happen. That's what will happen. So you should be very careful what you are using. I don't want to go into the details, everything is there. The take-home message is Insulogen 30-70, always write 20 and then 40 units insulin syringe. Or in your hospital, take only one syringe available, either 40 units or 100 units, or the drugs also 40 or 100. Case 4, 140 units of insulin and HbA1c more than 15%. You know what is this? This is insulin injection site selection rotation. This is lipodystrophy. Because the patient has taken insulin only at one site, they develop lipodystrophy. And in the lipodystrophy, when you give injection, the absorption is less, and you have to give more and more insulin, and the control is not there. So you have to know where all to give injections, and of course these are basic things, how you should go, and then how to rotate, how to avoid clouding, how to shake. All these important precautions you should advise the patient. Again, you should not use insulin needle again and again. Maximum use 3 to 4 times, otherwise the insulin needle will get blunt like this, and it may cause injury, it may cause lipid dystrophy. And skin thickness does not depend on age, gender, or BMI or ethnicity. You always inspect the injection site before you give injection. Then how long insulin should be given once a vial is started? There is no clear instruction from companies also, but not more than 28 days. So once you open, you should use within 28 days. 28 days, some companies give different instruction. You see the instruction. Again, coming to the storage. Many times, insulin storage is not done, efficacy is lost. Especially, I belong to Coimbatore. We do a IDM charity trust. Myself, not myself, mainly Dr. Krishnan Swaminathan, endocrinologist from Coimbatore. We have got 550 children, we have adopted the children. What we do, we not only give free insulin, we give insulin glucometer, also we give them refrigerator. Because most of them are poor people, poor family, they don't have refrigerator. So we give them, because storage is very important. Many times, these people keep their syringes, insulin vials in the house over near to the kitchen. They have only one room. That's a problem. So storage is very important. So make sure the storage is adequate. Never leave the needle attached to the pen. So what all things you have to do? Insulin type, injection technique, change of needles, injection site issues, lipodystrophy, storage of insulin, other endocrinopathies, insulin resistance, and non-compliance. It is the difficult glycemic control on high dose of insulin. Please check insulin storage sites, injection, and insulin lipotrophy. Simply rotating sites can prevent complications. And don't follow the other Americans and the European guidelines for storage. Finally, please take 60 seconds to talk about hypoglycemia. Whenever you give prescriptions for the patients, please talk about hypoglycemia. That can help you. This is an old person, about 62 years, central pontino mynolysis because of the insulin. hypoglycemia, and we lost him. So please, take at least 60 seconds and explain what is hypoglycemia, how to prevent hypoglycemia, and what to do when there is hypoglycemia. Insulin is a miracle drug, but used with utmost respect and care. I always say, when you give medicine with care, it is called Medicare. When you give medicine without care, it is medicine. It is a sin. So be careful about medicine, and then remember 40-100 units, go low and slow, and do no harm. If doubt, please refer to experts like Sunil Gupta. Now, there are so many things I can talk about myths, errors. Because, when you write the prescription, it's very difficult. Nowadays, we write very fast. When you give some vitamins, it becomes anti-diabetic drugs or anti-mitotic drugs, and then you land up in problems. So write legibly. Again, when a patient comes, recently, about 2 months back, somebody by name Lata, she came to me. I saw her report. The report says she had 600 milligram of sugar. I never thought she had any diabetes. Then when I inquired, there was one more Lata who was 15-year-old, type 1 diabetes. Instead of her report, they gave this report. And accidentally, luckily I saw, and then I asked. So please ask who's the patient, what is the age. Take some time and do it. And especially when you come to the clinic, your mind must be focused. Mindfulness is the key word. Whether it is diet or the drug or the treatment or the love or the whatever you do, if you do the mindfulness only, it's good. I always say even eating, many times I said dietitians are here, mindful eating is the key. Mindful eating means you must eat with intention and attention. Eat with intention, attention, mindfulness in everything, and especially when you practice, even if you have a quarrel at home, if you have something else also in your mind, please focus and do, and you can avoid many errors. Okay. Now I will go to myths and misconception. My talk will be going to be introduction, myths, villain, challenges, solutions, and conclusion. Of course, I don't want to go into the introduction of how diabetes is rampant here. So I will, diabetes myths busted. I classify my myths and misconception into 5 Ds. D. First D, myths about diseases. Second D, myths about diet. Third D, myths about drugs. Fourth D, divine related. And fifth D, daily activities. Myths about the disease. They always say in villages and in small towns, I think Hello Diabetic has got adopted so many villages nearby in Nagpur. Good work done by Sunil. They always say diabetes is because of the karma. There is no karma, it's only your body, it's a lifestyle disorder. Some people think eating sugar produces diabetes. And then diabetes is contagious. They say if somebody has got diabetes, you will get it. And then diabetes is not, some people say diabetes is a very sweet disease, not to worry, it's a simple disease. So you will have to explain what it is. And then some people think, I'm too young to get diabetes. Diabetes comes in only older age. And some people think, I'm too old to get diabetes. And I'm too good a person to get a diabetes. This happened in my own family, my auntie, very saint lady, very pious lady. When we diagnosed diabetes and told her, you are having diabetes, no, I have no vices, nothing. How can I get diabetes? She could not, I could not convince her. So, everybody thinks they're too good, diabetes may not come. And then no one in my family had diabetes. So people say it's family, it runs in family. I don't have a family with diabetes. And then I feel fine. I'm all right. I don't have any problem. Many times it's a silent, in the initial stage. And then people read in the internet and things like that, say that their wounds won't be healed. I feel I heal easily. It's a myth. Again, diabetic early, the wounds can heal very easily without any problem. And the symptoms like, thirsty, hungry, all that may not be there. Many people, educated people, they read internet and Google. I always say Google is a bad doctor. I spoke once on Google, good, bad, ugly. Spoke most of things, what competes with us, not the other doctor, the Google doctor. I am not overweight, so I may not get diabetes. I am a rural farmer, because a farmer, rural working, they may not get diabetes. And diabetics affect only the rich and affluent. Not so. Even the poor people, they get diabetes, especially type 1 children. If you see, many of them are very poor. And then diabetes is a bigger problem in the Western countries, not in India. And they say heart disease is very rare in diabetes. In fact, in a women, especially obese women, diabetes after menopause, they have more heart problems than men. So diabetes is very common. I mean, heart problem is common in diabetes. The depression, diabetes, they say I won't get depression. Depression, diabetes coexist. Sorry, I'm rushing because each myth, what you have to do, you understand the history from the patient, take some time to explain. Then only patient will be convinced. Otherwise, they will have a false belief. Women with diabetes should not get pregnant. Now coming to I finished about the disease. Now I'm coming to the diet. Diet is a big myth. You know, there are a lot of myths among the rural people, cultural, various cultures, various educated people also. And diabetes can take honey and jaggery. Everybody thinks, you know, honey is very good. And especially in some of the older medicine, they say if you lick honey, it will cure diabetes. So you have to take some time and explain honey is not good. And then black jamun, fenugreek, bitter gourd, and neem leaves, taking these will cure diabetes. Diabetes should not eat rice and potatoes. People with diabetes should avoid carbohydrates. Diabetic patients should not eat fruits. Diabetics should not eat they should eat special diabetic food. There are so many myths about diet. Of course, you can talk about black jamun. It's okay, it's good, because jamun is known to improve blood sugar. Fruit is 82% water, 14% carbohydrate, the fiber, etc. You know, good things you can always talk about fenugreek and jamun fruit, bitter gourd, and neem leaf. Some people, especially villages, they take neem leaf. Honey, I want to emphasize. Oh, so fast. Okay. I told you, another 5 minutes I have borrowed from our friend, and my oration was 25 minutes, and you have given me only 20 minutes. Kavita and Sunil is there, they'll support me. Okay, audience also says okay. Audience poll, agree. So honey is, you know, contains around 75% simple sugar and 25% water. The 1 teaspoon of honey contains 25 calories compared with 16 calories of 1 teaspoon sugar. So these are all the many things. Even our friend Silpa again and again tell us, don't take Britannia Marie biscuit. They think Marie biscuit is very important. It is good. Everybody takes, especially diabetic patients. She will say, don't take Britannia Marie biscuit. I don't know, Britannia, Marie and Silpa has some quarrel, I think. That is why she always tells about the Marie biscuit. Camel milk. You know, in our place, Tamil Nadu, lot of people are from Rajasthan. They say camel milk cures diabetes. I tell them, it may cure diabetes. Bring camel to your home and take everyday camel milk. And then again, this is the revolution now. And then paleo diet. I know suddenly all the dietitians from Mumbai and Hyderabad and Chennai are becoming richer and richer, because they control the diabetic in my town, in every town. They have a nice setup of the phone calls. They call everybody and give them every day what diet they should take. And the charges are something like 30,000 per month for just phone calls. And they are making big money, and they give so many advices which the patient believes, not the doctors. And of course, the paleo diet, of course, we already said. And people with diabetes should take special food. Fruit is a rich, healthy food. Again, they always have a myth about insulin, and then they have a misconception, metformin or any drug can produce kidney injury. And there is a vaccine for diabetes. There is a myth. Only thing, diabetic patients should take all adult immunization vaccines. 5 vaccines, they should take major 5. And then divine related. This is very important, because in our part of country, there is a place called Metupalayam, where there is a Swamiji is there. When you go to him, he will touch with his hand for 5 minutes. Then people think his diabetes is healed. It's called healing touch. It's called Todu Vaidyam, touching art of eating. So there are so many divines, and then somebody does a puja, somebody does a remedies for diabetes. and then they exercise, people think they should not exercise in diabetes. Who are the villains for this? Why myths and misconceptions are there? It is because of the social media, Facebook, WhatsApp. WhatsApp is a notorious thing. We don't respond to WhatsApp, especially if you get a myth, like, somebody said in Kerala, if you take 5 mangoes, I take the blood sugar is normal. So mango is very good. He has published in the WhatsApp. So many people have seen, they said it's rubbish. But you should not say it's rubbish. You should, immediately counteract. Bring somebody like me, take a blood sugar in front of me, and after taking 5 mangoes, my blood sugar went up to 1000 milligram. Prove it. What he does it, all the other people, they prove it falsely. And our doctors should react and give response. Whenever they get any myths and misconception, don't be quiet. Talk to them, call the media, call the papers, call the television, everywhere you tell them this is wrong. We don't do that. And then again, okra is again going in every patient, their family, neighbors are doctors' equivalents. People respect the neighbors, not the doctors. Any advice you give, one of the senior in the olden days asked, what is the profession which is more common? The minister said it is the medical profession. He asked why. Because if you have a cut injury, everybody will give advice. 101 advices will come for a small thing. Everybody thinks they are doctors equivalent, and then do what is right, not what is easy. And there are a lot of challenges where because of lack of time, lack of communication skill, lack of infrastructure, not everybody like Sunil can have a big team to talk to people. You should have a good counselor, good advisor, lack of fund, inertia from the doctor's side, and government to take serious action. They advertise in the TV that they can cure diabetes. Government doesn't take any action. Suppose if a doctor commits a small mistake, there's a body to take action. But for them quacks, there is nobody taking action, especially in the advertisement in the television. So solution is knowledge is very important. And I request the diabetologists sitting here, like Sunil Gupta, Anand Kate, you start a course, especially in summer vacation, start a course of 3 weeks for all the +2 girls and boys. Girls is better because they absorb better and then go back home and teach them. Like, this is Daphne score, Daphne, and then Desmond's courses, where they teach the non-medical people how to control diabetes, how to titrate diabetes. All these things can be done by online. Now, online is the order of the day. I think Sunil, Hello Diabetes, should take a course and educate. Kavita is also walking in. Please take that course for 15 days or 2 weeks, or 3 weeks, for young girls, 10 plus 10 or plus 2 girls, and teach them, educate them how to take insulin, how to take diet, the myths and misconception. You give a certificate. Now, Makkar is running a course for medical people. You can run a course for non-medical people, like Daphne. Daphne is the dose adjustments for normal eating, and is very famous in UK. And then Desmond is the abbreviation for diabetic education and self-management for ongoing and newly diagnosed. It's an education course for non-medical people in UK and Western countries. Similar courses we must start, and I can suggest to people who are doing this, an education course, 15, even Saraswati can do it in Andhra Pradesh. And more and more people will educate, and the dietitians are here. You can take a course on what is best diet, what is our myths and misconceptions. So we must react, we must counteract whenever some myths and misconceptions are there, and then we have to have pedagogical dialogues with everybody. Send WhatsApp messages, send good things. WhatsApp can be a double-edged weapon. When they get a bad myths and misconception, your people, like Hello Diabetic or any other diabetologist, send frequently, every day, a good news about the health. Health news every day, WhatsApp group. You can send it to thousands of WhatsApp group or thousands of emails. And conclusion, for all myths and misconception, educate, educate, educate. Improve your communication skill. You should convince the patient. The quacks are better communicators. You convince the other people better. Convincing ability, perseverance and persistence. And team effort with support from government, knowledge, positive attitude can change false beliefs and bring good behavior. So, ladies and gentlemen, learning is the beginning of health. Learning is the beginning of wealth. Learning is the beginning of spirituality. Thank you for your patient understanding. And I thank the organizers, Sunil Gupta and Kavita and the family. It takes always family, his son also, because we don't know how far Sunil will call me. After his son also comes only, I must make sure he also calls me. Yesterday, I had spent more time with his son than Sunil Gupta. Thank you very much.
Thank you, sir. Thank you very much for that talk. And as a customer, we do not ask for any question and answer session. Thank you, sir. Thank you once again.
But we can certainly ensure, sir. Sir, we are already doing this. In the another hall, we have a program for type 1 diabetes. Like you suggested in summer, we do two kind of program. One is a program taking all these type 1 diabetic people and children to the camp, which is a residential camp, one night camp, and then we have 2 days workshop kind of thing. And then we have started in such venue, the full day conference, like a workshop on insulin therapy for type 1 diabetics and their caretaker. This we are doing since now 10 years. The earlier residential program which we are doing is for 21 years now. So every year we take these children out and then we do this work for educating them, empowering them. This is already on, sir. We also have a course which is called as National Diabetes Educators Program, where we create educators. And amongst educator, we are now involving type 1 diabetes children who are interested to become an educator and their mothers, not father. Rightly said. Mothers. So they have a better grasping power and communication skills. So we take mothers as educators. We try to train them also. And lastly, you said about the RSSDI course. So RSSDI has already started the course. It's already available online for educators as well as for the nutritionists. So it's there, sir. Thank you very much.
I hope I landed safely.
Yes, thank you.
Thank you, sir. May we now move forward for our next oration, Hello Diabetes Academy oration, Dr. Vijay S. Ajgaonkar oration. Our chairpersons are Dr. S.N. Deshmukh, sir, and Dr. Sunil Gupta, sir. I request them to please come to the dais. The captain is Dr. H.B. Chandalia, sir.
May I request Dr. S.N. Deshmukh, sir? Yeah. Sir, we have to join. Sir is going to join virtually. And, but before that, we'll have a tradition. Sir, good. I'll have to see here, right? Yeah. Sir, good morning to you, and we welcome you for this Hello Diabetes Academia. So virtually, but you have already sent Sonal here. Sonal, are you here around? Sonal is already there for the traditional oration award ceremony. So I feel I invite Sonal and myself and Dr. S.N. Deshmukh sir will come on the dais. Will give the oration virtually to sir and physically here to Sonal, who is daughter of Dr. H.B. Chandalia.
We are fortunate to have Sonal, Dr. Chandalia's daughter, here for accepting our oration. Citation.
This is an oration which has been awarded, this prestigious oration is awarded to Dr. Chandalia, who is going to virtually present here. And we are pleased to present this citation to Dr. Chandalia, which reads like, Diabetes Care Foundation of India, Nagpur, and Sunil's Diabetes Care and Research Center, Nagpur, is privileged to award late Dr. Vijay Ajgaonkar Hello Diabetes Oration 2022 to Dr. H.B. Chandalia, Director Endocrinology, Diabetes and Metabolism, Just Look Hospital, Mumbai, Director Diabetes Endocrine Nutrition Management and Research Center, Mumbai, past President and Patron, RSSDI, for the yeoman service towards the society and an exemplary delivery of oration on diabetes education, my journey over 50 years. During this conference at Hello Diabetes Academia 2022 International Conclave on 24th, 25th and 26th June 2022 at Nagpur, India, signed by Dr. Sunil Gupta, Managing Director of DCRC, and Dr. Kavita Gupta, Director, DCRC.
For you.
I request Dr. Chandaliya to start his oration, please. Thank you.
Yeah. Can you hear me all right? Can you hear me?
Very much.
You can hear me quite okay?
Yeah, yeah.
No, I can't hear you properly from that side. This, I'm audible, right?
Yes, you are very much audible, sir.
Okay, good. All right. Well, thank you very much, Dr. Sunil Gupta and Kavita, for inviting me to deliver this talk in honor of my dear colleague, Dr. Vijay Ajgaonkar. Dr. Vijay Ajgaonkar was my senior by about 8 to 10 years. And of course, he was heavily involved in treatment of diabetes before I started. The main quality I saw in him is really great meticulousness, good follow-up of patients, and of course, very ethical practice. And last of all, his thrust was towards the education of children and, running the JDF activities, Juvenile Diabetes Foundation activities, and the camps for youngsters were very well done with the help of some other colleagues like Dr. Irani and others. So with those words, I have good memories about Dr. Vijay Ajgaonkar, and we were of course colleague at the Raheja Hospital. Little story about that I'll tell you later on. See, so that went on, and I think I'll start with my talk. We always say to our patients that diabetic that knows most about his disease live the longest. Remember that in legal parlance, we say that if you do not know the law, you are in trouble. Similarly, we must teach our diabetics, if you don't know about your disease, you can be in difficulty, because after all, they meet the doctors or paramedics on some regular basis, but there are interval periods where they have to really themselves communicate to us what is happening to them. Now, I'll tell you the history. My main thrust, the topic has been given for me to recount the history of development of diabetes education in India. So this is my 55th year of practice back from US in 1971. So I would say at 50 years for sure, 51 years. And you see, I've seen this education developing, and of course, I've been very lucky in participating in this process to a great extent, and I'll tell you about that so that some of you may be inspired to join this movement of improving diabetes education in the country. Dr. S.S. Ajgaonkar, father of Dr. Vijay Ajgaonkar, was a great educator. When I came back from US, I came in touch with him. Inspiring person, very simple, high thinking, simple living Maharashtrian. Typical examples of the couple of generations ago, which is like Gokhale, Tilak, those kind of characters which you don't see these days. And he inspired me in educating patients. He ran regularly classes, once a month at the Diabetes Association of India. He was the founder, and it was somewhere at Fountain in Mumbai office, and here we run, and several times in a year he'll call me to address this education session for patients, and these were very knowledgeable patients, and education was given regularly to them. Dr. Vishwanathan Chennai also must have done a lot of education. I'm afraid that some of those exact events, I don't know when he started or what he did. Dr. Sen Gupta in Kolkata was a pioneer in educating in diabetics. Dr. Ahuja, who was our founder of RSSDI, along with, of course, some other respected colleagues like late Dr. O.P. Gupta and Dr. Vinod from Delhi. You see, Dr. Ahuja was a great researcher and academician. He was a little bit reluctant to go into area of patients. As a matter of fact, about 10 years after the formation of RSSDI, I think some of us had suggested we start a patient wing and patient education on the side. And Dr. Ahuja did not want the academics and the research to be diluted. That was the way he worked, you see, and you know the great contributions he made in that area, so that he was reluctant to start. And I think ultimately this was realized by RSSDI chapters. So I'll discuss that. RSSDI should be involved a lot more in patient education than what it is. And I think Dr. Bansi Sabu, the immediate past president, and the current group, Sanjay Agarwal and Dr. Vasant Kumar, they are very keen on expanding this area. We have Dr. Hari Vashta from Maulana Azad College from Delhi, also very much interested in diabetes education. I started appointing, at that time, there were no diabetes educators in 1975. So I started taking nutritionists and training them into some other aspects of diabetes in order to, you see, impart education to my patients. Very interestingly, I'll tell you that even after 10 years of that, for a short time, I was attached to a very large hospital, a private hospital. I can say the name, Bombay Hospital. And there was no dietitian in the whole hospital. Can you believe that? 1985 rather. And so I told the management when I got attached that I would like a dietitian to help me in the clinic and help my patients. They said, Dr. Saab, don't disturb our arrangement. Our kitchen has very pure ghee and very good food, and a dietitian will come and ruin the whole thing. These are their perception of diabetes education. They told me that you can hire one at your cost. So I did that, of course, because I needed one, and I knew the importance of education, and therefore I hired one, and I paid the salary for this hospital dietitian. I paid the salary, and this person helped me half of the time in my clinic and in helping my patients. So this was the state of affairs in 1985. The diabetic education was led by some of our colleagues. We approached them, Dr. Shobha ODP at SNDT, see, and our clinic, you see, almost about 15 years ago, we approached them, and it took a year or two to start a new course on diabetes. This was the only university-based course. You see, the educators training has been all very tight in the country. There are a few weekend training, and then you give a certificate. All that was being done, and many pharma industry will say that we educated 1,000 people. What they had done was 2 hours of education to all of them. See? So that compare that to some of the education programs that I'll show you. You see, which we have developed, and this was one university-based program. And many of my educators, including Sonal and my educator at Jaslok Hospital. And I must tell you that Jaslok Hospital, I had the privilege of having a diabetes educator 15 years ago. And regularly these services are on, and it has been a great asset as the management realized. See, and of course, this university-based course went on for quite some time. Unfortunately, there are not many takers, so currently it is again slack. But I think what I try to urge is, please, if you really want to impart education, do it through some university. So there is some monitoring is required for the quality of education. So for you to give a certificate of training so that legally you are safe, but still, people flaunt it outside, you see, is not a very good practice. So we are different from that most of the time, and we insisted on the quality education. In Mumbai, we started some education center all along at education activity. Once a month, for example, all our patients who we have seen in previous week and many other before that, we call them for group education. And it went on for a very long time, Except during COVID, it got suspended, and we plan to restart that. See, I must tell you that it is difficult to get patients who really want to be educated. This is also very important, I must tell you. See, sometimes we were very, very passionate about it, but our patients sometimes at these sessions, after trying about 50 people, about 10 or 12 will be present. But I'm not disappointed, because I attended some education sessions at Joslin in US when I was training with my professor, and for a while, he made me work at Joslin, you see, just to get a different flavor. And I attended one session which are done by the junior Joslin, and there were about 10 people. So I think this is world over, So this is very important. How to really get them to the classroom, how to make them learn, how to motivate is another big story. I think we'll keep applying our mind towards that. We had a lot of exhibitions in Mumbai, and there were the 2 times we did a Nehru Center, one at Somaya background. These are very interesting. I'll tell you details of that because some of you may like to emulate this example. This is quoted even now in the media because these are very big events, where we had occupied something like the 20,000 square foot area, the whole floor of the center, and the various activity which I'll show you. So that kind of education, sometimes we can mass education, at least we did at each of these events, about 3,000 people almost going through a almost complete all-round education, 3,000 people in 3 days' time. So this was very interesting. I'll tell you about that. Many people were engaged in similar activities, and I must acknowledge them. And many of them I'm not even aware. So I'm only talking to some, those are in close touch with me, and I found them very, very passionate about education. So Basu's group was on diabetes awareness, and huge organization running well in Kolkata. And they have done our meetings of diabetes as Educators Association, and we have interacted on their platform, Diabetes Awareness in You. Dr. Sunil Gupta and his wife Kavita are very, very passionate educators. I have attended many sessions while visiting him during this today in this session, whether he has kept patient education or not, but very largely attended. I was surprised the way he could attract people, and very, very interactive kind of program, and he still continues to be very active. So this is, I must say, he should keep this up. This is a wonderful thing to do. Very interestingly, Vijay Panikar, my former associate, of course, my esteemed colleague now, you see, he had developed a very nice musical program. It was wonderful, it was really very, very, I was fascinated looking at that, striking a balance between state control and, and a reasonable control and tackling the psychological problems in the patient in a beautiful way. So this was very interesting experiment, some skit, beautifully done. You see, educational programs are now on in the country in a big way. Educators are employed in all these corporate hospitals. Some of them are something like a group of 10 educators. And we know one leader, is one of our executive members like Shubda Imbeli, is probably about 10 educators working with her. And many hospitals now employ them. And I think this is a very, very welcome change. We started a magazine for diabetic patients, a quarterly magazine almost 24 years ago, without interruption except during COVID again. We could not manage during COVID. And quarterly magazine and Diabetes Today with about 25, 30 pages of material. Very interestingly, it was bilingual. Same articles done in English and Hindi. Halfway. You see, half of it in English, half in Hindi. So this suited our people in the western part of India very well. And I must emphasize that this education of patients had to be in their languages. So in the last AD, Associate of Diabetes Educator, which I started in the last annual meeting, done from Chennai by Dr. Meenakshi Parasa, one of the leading educators there. And I had told them to do one session on myths and facts in diabetes in 3 or 4 languages, same session. You see, successively in 4 languages, I told them to do, and they did it very successfully. Remember that we have to master several languages. All children are capable of mastering 3 languages now. World over it is known. And so I don't think we should restrict to one language like either Hindi or English or Tamil or Telugu. We must have 3 languages controlled. And that is required for a good communicator. So this is now still being run by us. We will now restart. COVID is receding, hopefully, and we restart our magazine now. And of course, you see, we are managing this from our clinic, but it is a trust activity, so that we have nothing to do with finances of any of these organizations. See, except that we raise money for them and we supervise the expenditure. Association of Diabetes Educator was established by me, you see, in 2010, and is flourishing. Now we are close to 1,000 life members, and is doing very well. We are at regular academic meetings, annual meetings. We have also semi-annual or interim meetings, smaller size, and they are going very well. Most of the time, we have done 2 meetings a year, and we have started a Journal of Diabetes Education. I'm editing with Sonal now, and many other people helping us. And this journal is concentrate on giving articles which are suitable for the educators. So we are educating the educators, and this process is very much our domain, and we should do this. This is the journal, and it is going on regularly, except again some short interruption in COVID, but we have revived again, and we are on again. This and I think the journal is doing quite well, but obviously it needs to be developed on a very large scale. This was the exact plan of that mega scale education at Nehru Center in Mumbai, which is very central place. and module of 4 for 4 hours. If it's 500 to 800 people will attend every day. So in 3 days, 4-hour sessions were attended by about 2,500 people. We have records to prove that. So this was massive scale. Done, all sessions were done in Hindi and English, bilingual, and of course there were a lot of exhibition with 100 standees there, exhibition, checkups. So these sort of events also do stimulate awareness of diabetes, and patients get educated on a mass scale and get inspired. These were the 4 modules, 1 module for an hour each, Hindi, English, half hour each. So this is how it was done. You see, we now run a diabetes educators course. This is a very interesting one. You see, this is a electronic course. It is a internet-based course. It's a 6 months online diabetes educators course. We have course material running into our 600 pages, a lot of audio visuals available there for students who take this course. Most importantly, the hands-on training is mandatory in this course, which is 300 hours. We make sure it is 300 hours, as strictly as the universities would do, or people in other countries do. And that means roughly 3 months there to work somewhere half day. And the most important is they work with a mentor in their own city. So as soon as they identify whichever city they are in, a good diabetes practitioner, we check and get some detail about him, that him or her, whether the basic educational facility is there, there is a certain workload there, there's some type 1 as well as some pregnancy with diabetes are required to train them. So all that we check, and then we immediately invite him as a mentor, and we tell the, and in fact, this is also a trust activity, and it is very small fees. And out of that, really more than half the fees is paid to the mentor, because I don't think we require a lot of fund collection to run this organization. We did it initially when we set up this use website to educate them. And I think it is auto question and auto answers, and 70% is passing, so that many of them sometimes have to take it a couple of times, because the questions are very, very advanced and really truly testing them. And this is all automated, and they get their results automatically, like the examination do nowadays in other countries. Another interesting is the education thing was the HOPE project. Many of you might be familiar with it. We ran it in the 2 years, 2009 and 10. Sonal was leading the team with Salome Benjamin, Niti Desai, and Kavita was involved. Kavita was involved very much, and she'll come to Mumbai and will be helping us, you see. And this was a very good course run from the International Diabetes Federation. We participated. Overall, in India, they trained 3,000 educators. So these are some of the well-trained educators. There were no real hands-on, but virtual hands-on were there. There were workshops and examples where they were almost like treating patients or talking to patients, but still I think it lacked what we have developed now, the e-based course where there are mentors locally, and they truly work there in the center for 300 hours. So type 1 diabetes require a different kind of education, I must tell you, very different, you see. And they require intensive education on insulin therapy. They have a lot of exercises, they have their sports activity, they have peer interaction, and there's a lot of psychological issues. So I think you have to really develop modules to teach them separately. You see, because the person who has the disease is different. Like William Osler said, you have to worry not about what disease a person, but which is this person who has that disease. And of course, there are growth issues. I have not seen many diabetologists knowing how to assess growth. Fortunately, we have heavy practice of endocrinology as well. So we have very good data on their growth, and we publish some of the papers on that. And of course, group education, health camps, which is, I think I told you, great Dr. Asgamkar conducted, are wonderful. See, and of course, pump therapy is also important in type 1 diabetic. And I want many of you to learn that, and your educators to learn pump therapy. The first workshop in India on pump therapy was organized by me, 1983, in Delhi, in Taj Palace Hotel. And I had very illustrious faculty, Dr. Joshi from US. Mecklenburg was the main pump user at that time. His article appeared in NEJM just a year ago. So we invited him, Dr. Pfeiffer from Germany, Dinesh Kumar from Delhi, Vishwanathan, Dr. Vishwanathan was there, Dr. Lily John from Vellore was there. And I think we conducted this workshop very well. And remember, when we start pump therapy, we have more than 60 people on pump. Some of my patients are in 30 years of pumping. So some of you see some of the younger ones prescribing in large numbers. But they sometimes started pump patient does it for a short while and quits. I have these people pumping for up to 30 years, many more 10, 20 years, many of them. You see, and I delivered 12 type 1 diabetics. If we, you see on pump therapy because they were otherwise difficult to control. So this is, you must understand, and educating patients on pump, I think our educators, we are trying to train them in that, and I think this is extremely important. You see, RSSDI is a very big body, very big body. Beautifully run now, activity. I'm so pleased to see the way it is spreading its activity currently in the last 2-3 years with very, very able and passionate and very hard-working office bearers, starting from Manjit Sabu and Sanjay Agarwal, wonderful secretary, and of course the successive president, including the new one, Hussain Kumar. And all this is done. But the main teaching of patients, you see, in education, RSDI now spreading its wing to go into that. And now they are running beautiful sessions, you see, with Puri Chawla helping and media. And I think beautifully done sessions where I talked several times and a very large number connected. And of course, our state chapters, which that I was the one who made the constitution of the state chapters, and first chapter in Maharashtra was started by me. And the state chapters have taken the patient education in a big way. And I think we can probably work through them and enhance this educational activity. So I think this may be a very good way of doing it. And then that way we galvanize all our fellow diabetologists as well as the health workers, working with them, the educators, dietitians, nurses working with them. See, so I think this should go that. I must now mention that educating in diabetes, this is a very interesting aspect which has been occupying my mind for the last several years. And I've been addressing specific lectures on that. Our culture and, is a different culture. You see, Asian culture itself is different, and India is very, very distinctively, different. You see, we are poorly informed, myths and understanding. Right now, I saw Dr. Mugnathan talking about some of them. The patients have galore, all kinds of misunderstandings. You see, they do not believe in continuity of care. Very poor. Main thing lacking in diabetes care, if some of you show me 500,000 patients you've seen for 5 years or 10 years regularly, it will thrill me. I have medical records of 50 years on my patients. I do have some people coming to me for 40 years now regularly. So, this continuity of care, not been established in our country, and patients don't easily cooperate for that. You see, they're highly suspicious. This is cultural. Not that they are bad people or they have something wrong with them. It's our culture to suspect the next person of motivation or some different, and therefore they don't accept treatment very readily. Although they will be very, very polite with you, sometimes they touch your feet. But remember, that in their mind of mine, if you see, they don't accept treatments very easily. They don't accept continuity. So please, our educators have to learn how to counter these tendencies our patients have. Counter them firmly, but counter them with very great sympathy or empathy. And you have learned to communicate how to overcome this. And of course, you see, the cost of care is on the patient, so that itself deters also from a regular follow-up. And remember, in Indian culture, the doctors of those times, Vedaraj, are considered brothers of Yamraj. You see, so sometimes they're very skeptically received by us culturally. It's a cultural defect. Even high education has not solved this defect easily. I had to counter it in PhDs. Understanding of disease and regular follow-up. I had to do in big MBAs, and also they were understanding everything wrong. You see, so I think this is very, very important, and how to probably assimilate ideas about our other ancient practices. You see, systems. There's some like very, very mild impaired glucose tolerance test now. You see, RSDI is finishing a study where I was one of the initiators, and that study is getting over, where methi powder in yoga is being tested. So some of those can be applied in those situations. I think we have to place those modalities of treatment in its rightful place, but still tell them what they can't do, because in their training, they are never shown what they can't do. In our medical training, we are always told what we can't do. In other training, they are never told what they can't do. So they almost claim they can do everything. So I think we should give it a rightful place and probably accept it but very, very carefully in this regard. I think as my time is up, I'll probably stop here. I must tell you, you might say that people are still illiterate, semi-literate, but this is by paper in diabetes care long ago when diabetes care just started. You see from in US, and this was work done in Mumbai, in Gandhi Medical College, and illiterate, semi-literates we taught. That time there was no A1C came in 1980. I introduced that in India in 1980. And that time there were only blood glucoses and their knowledge we tested so semi-literate, illiterate can be taught. Illiterate does not mean a person is unwise. A person can be very wise, and a very well-educated person can be very unwise. So wisdom and knowledge don't go together. So anyway, please. So I think I'll stop here because there are more slides, but as time is up. Thank you very much for this, giving me this opportunity to address this issue. And I hope I have given you some glimpse of what is happening in our country, how it has developed, and how it has developed in the context of our work in Western India. I know a little bit about other parts of India, but sometimes we don't have accurate data from other parts because our communications sometimes are not as good between us, and we usually don't join hand in the big national scale, which is fine because it's a big country and we all can do tremendous work and there are a lot of opportunities for us to do. So thank you very much again. And herewith, I think I end my lecture. I don't know whether they permit any questions in this, but whatever the organizers want. Thank you.
Thank you very much, sir, for a very informative oration here. And this also underlines that how people go.
The broadcast is poor from there.
No, it was very much audible here.
Sir, we can see you and you are very much audible and we had wonderful session with you. Many of us got encouragement. How should we go ahead with education, the importance of education, where do we need to do it, how we have done, how you have done in those days, almost 50 years from now. I feel this is a very encouraging lectures for all of us and hopefully all of us will take some very positive messages from you. Thank you very much for accepting this oration.
Thank you.
We are really feeling honored for it. Thank you, sir. Thank you.
Thank you. Goodbye.
Over to MOC.
Thank you so much, respected HB Chandalia, sir. We are highly motivated by your speech on education and the 50 years of your journey. Thank you so much, Chairperson, sirs. Now we move on to the next session, that is 100 years of MNT. For this session, I would like to invite Dr. Renuka Mende ma'am and Dr. Shakti Sharma ma'am to the stage, the chairpersons of the session. The talk is going to be delivered by pilot Dr. Vijay Neglur sir from Thane.
Before we move to the next session, we would like to felicitate our reporter, Dr. Pratibha Dingra, ma'am. So, can I have Dr. Sunil Gupta? If he's not there, I'll take the opportunity and the pleasure to felicitate ma'am.
Welcome, chairpersons. We can start.
Yeah, please. Over to you.
Very much. It's okay. Real introduction is after lecture.
So we'll take the opportunity to introduce you, sir. Thank you so much. Can we go to the previous slide, please? Yeah, we have the opportunity to introduce Dr. Vijay Neglur, sir. He's MBBS MD in General Medicine, Fellowship in Diabetes from UK. Dr. Vijay Neglur is a co-founder and medical director at Dr. Neglur's Diabetes and Thyroid Specialties Center, Thane. He is an Honorable Associate Professor of Medicine since past 20 years at Rajiv Gandhi Medical College and Shivaji Hospital, Kalwa, and has served as an MBBS examiner and convener as MUHS. Currently, sir is a leading teacher of Public Health Foundation of India and teaches on a variety of subjects like diabetes management, thyroid management, pregnancy, in diabetes and cardiology in diabetes. He is an advisory board of various national and international pharmaceutical companies. Sir has earned the title of Syndrome Man and the Gentle Giant of Diabetes by his students and colleagues on account of his impressive diagnosis and treatment. So we are privileged today to have you on today's session, and it's an honor to be here today. We welcome you, sir.
Thank you. Thank you very much for your kind words of introduction. And before I begin my talk, I congratulate Sunil Gupta and Kavita Gupta for making such a wonderful program. And once again, thank you very much for the kind invitation. So my talk is to speak on 100 years of MNT. And the word MNT was introduced for the first time in 1994 by the American Diabetic Association to assess the status of nutrition and also to find out changes that can be adopted by the patient in nutrition so the patient can bring down some reduction of weight and can get the A1C to the goal. So that was the idea of starting medical nutrition therapy way back in 1994. So we have seen this evolution where the man who was a Paleolithic man has now turned into an agricultural revolution where the food became abundant, and with that the patient further became lazy and started eating more and more when there was industrial revolution, and therefore bringing about the explosion of non-communicable diseases. But before you get deep into that, the reason why the patients or the people started eating more and became weight obese because of this big change in the patient's size of the brain. If we look at hominid and to the cranial cavity or the brain size has increased threefold. What was 400 grams brain has become 1800 grams brain. And this is also what is called encephalization index, which is the ratio of the brain mass versus the body mass, which tells us that in humans it's 4.8 versus in the non-human anthropoid it is 1.9. That means the brain size has grown so large. And what could have happened because of this? And this is what is called as the human brain is energetically expensive. And what we know is the human brain requires 11.2 watts per kilogram easy energy versus the rest of the body which requires just 1 watt per kilogram body weight. And to adopt this policy, what we should do? We should either increase BMR, which again is not a good proposition, or reduce the energy consumption for other part of the body so brain gets adequate nutrition, and finally reduce from the 4 feet walking to just bipedal walking. That's exactly why the human being has become erect, because instead of walking on 4 legs, the energy consumption by walking on 2 legs is far less. So that was a very important concept by Ali Lilly, who gave this concept of the human brain being energetically expensive. And that was what was called as the expensive tissue hypothesis, where she has shown very elegantly that the gut size of the primates to the human body, can see in the graph here to the left to right of yours, is reduced significantly by 1 kilogram. For the expense of the brain, the size of the brain has increased threefold higher. And that is because that the brain required higher nutrition and therefore the compromise done by the GI tract. And therefore what happened because of that is what is called as a cusinivore. When you ask, what are you, whether it's a herbivore, whether a carnivore, answer is cusinivore. This was a very important concept which was first led by John Berners from Australia. And what he said was that the men started cooking food. And by cooking food, they started pre-digesting food earlier. And therefore, the palatability, the texture, the digestibility, all that increased to suit the size of the gut. You can see the gut, the small intestine, which was reduced significantly in human body, could absorb 67% of energy. That 14% of energy only came from the hindgut. This was a very important concept, and that has changed the entire attitude of human being to have consumption of more and more food. This is the story of a truck driver who was arrested at the border of northern part of the Europe. And the reason was he was smuggling butter. And that was a crime at that time. That's why he was arrested for that particular reason. And why this happened is because of Dr. Ansel Keys, who was actually not a doctor, but did PhD in oceanography and did BA in economics. And he was the education, he had no education in nutrition or heart disease. And he was said that the consumption of the fat increases the calories and therefore you get increased amount of ischemic heart disease. And therefore he looked at the 6-country data, so 22 countries, and cheated the world that the consumption of fat increases the coronary artery disease, and therefore he forced the organization to reduce the calories just by 15%, 5%, and allowed to use soft margarine instead of butter. And he was America's expert on the diet and health, and his cover page of Time magazine talks about it, and that's how exactly everything changed. And what happened because of that? The consumption of margarine increased, the people became overweight, they started eating more and more carbohydrate, there was an increased amount of the death because of heart disease, and you can see even the children becoming obese, and that increased the girth of the nation, and therefore people became more and more obese. At that point of time, in 2005, in a place called Sweden, which has just 9 million population, has a distinct feature of having a Nobel Prize being distributed there. You can see the ABBA band, which is a very famous band from Sweden. And then they first adopted this low-carb, high-fat diet. And it was also taken note by Lancet and saying that fat diets in the Sweden of all places. And so these people adopted this. And the person behind this is this lady, Annika Dahlqvist, who was actually a primary healthcare doctor in Sweden, and she realized that there is increased incidence of the epidemic of heart disease, and there's obesity, and the consumption of butter is going down and down. Therefore, she met the administration, she met the people in government, and could convince them. And so much so, there were advertisements in the paper that who buys Audi car gets 2 packs of butter free. And that's how the promotion of consumption of butter, and that they said was a good diet for people to eat. And in 2015, the US Dietary Guidelines says you lift the ban on butter, and he said, demon on the plate is not the fat, carbohydrate. And that's how the entire term changed from misinformation, exoneration of consumption of fat rather than carbohydrate. And in India, in 1965, we saw Green Revolution under the leadership of Swaminathan, who were in 65, we had incidence of diabetes of 1 to 4%. And when we had this end of the revolution, we had 10% of diabetes coming up in India. And therefore, because of the increased consumption of carbohydrate, we are all aware of this study, START study, where we see whether east, west, north, or south, we have a high carbohydrate consumption. And as per the ICMR, they played, all of us here knowing there are many dietitians here well versed with this. And therefore, we know that Indians continue more and more carbohydrate. And that carbohydrate consumption is classically a diabetic diet. And this is exactly what is the cardiometabolic phase of India, which is a macho man. Macho, MA stands for the middle age and the middle of fat that is increasing. And that's how this is the highly atherogenic dyslipidemia because of the central obesity. Lancet 2017 had this very interesting paper called Pure Trial. It looked at 135,000 population in 20 countries using the food frequency questionnaires. And what they found was that if you see the quintile of the carb content, with every quintile increase in the carb content, you can see the incidence of increased myocardial infarction to the tune of 27%. And if we look at the fat, on the contrary, at every quintile consumption of the fat, there was a decrease in the myocardial infarction by 22%. So therefore, the fat is no more a cause for the increased incidence of coronary artery disease. And if we look at the adjusted confidence interval of ApoB, ApoA ratio, and if you can see the carbohydrates are showing trend towards increase, where the sat fat is showing trend towards a decreased amount of consumption of the fat responsible for less cardiovascular event. And if you look at the fat of any type, where the energy got from total fat content or from the saturated fat or a monounsaturated fatty acid or a polyunsaturated fatty acid, all of them are good, very clean. But if you look at carbs, on the contrary, the carbs really contributed heavily for a coronary artery disease. So therefore, the high carb content was associated with adverse impact on the total mortality, while fats, including sat fat and unsaturated fat, were associated with lower risk of total mortality. And therefore, whether this paper forces the global dietary guidelines should be changed looking at this particular study. And this was quoted as the most impact paper in the year 2017. And so also consumption of white rice. We know in India we consume somewhere about 600 grams of rice, and that consumption of rice is responsible for 20% increase in incidence in diabetes in people who consume rice to the tune of 600 grams. And this is what we know, that India has this kind of a diet now with the modern era, and especially during the lockdown period where the free home services was available, and if the delivery comes half an hour later, you have to pay only 50% because the fellow came late to deliver the food at your doorstep because of some kind of a traffic problem. So therefore, this is what we see that the modern India is eating. And this is the snacks that most of us eat in the afternoon time or in the morning time, and which has a high fat, high sugar, high sodium, and of course, this was labeled as what was called as the HFSS diet by WHO, and this exactly are the best example that we can see here. And what's disturbing more than that is that there's certain authorities like Coca-Cola have funded scientists to deflect blame on obesity from the sugary drinks. And that is the sad part of the story, that these industries have bought even these scientists, and they have been able to change their minds so that they publicly say that these do not contribute to adverse cardiovascular event. Look at the EASD. This is the EASD picture that I've taken when I attended the meeting, and I took that vegetarian pack, and it shows what? It shows that chips, bananas, and the candy, and you can see the amount of vegetable between the sandwich. It's so small in quantity. So even some of these organizations also are promoting a kind of a diet which is extremely diabetogenic. And of course, we had witnessed this lockdown for a period of 2 years, and we see what was the impact of lockdown. And because the people staying in the home, there are no kind of activities, and a lot of plenty food was available. Many started having a lot of cooking experience at home, and therefore they started building more and more weight, and then these sugar controls went very bad. Therefore, what we have done is from malnutrition to malnutrition. So that's a change that we see in this country. This is a fantastic editorial in Diabetology on the diet in diabetes, which talks about diet, delusion, and diabetes. And we all know that the Allen was the first man who really literally starved the patients of diabetes. He gave us 10 to 20 grams of carbohydrate and was allowing them to go into mild ketosis, and he would definitely not give them any kind of carbohydrate. From that, the discovery of insulin started having high carb diet. And therefore, this was again, even when the dietary guidelines was told to Frederick Banting, Banting said this looks all complicated and confused. And if I get diabetes, will rather increase the dose of insulin and eat what I want. This is what Frederick Banting has said. And then we saw again a swing towards low carbohydrate, and William Dogady, who says that you should consume less carbohydrate. Then again, they said high carbohydrate, that's Kelly West diet. Then again, they said normal diet by Michael Berger. Then we can say that the pre-insulin diet, again come back to the Atkins diet, which was Ellison was given for the first time. The same kind of diet was reintroduced again at this point of time. And there was a lot of confusion, and therefore this diet delusion and diabetes was a correct app for this. And finally, the rich man's tapeworm is what is called as the nutrient blockers like AGIs or the lipase inhibitors, and the complex carbohydrates and the fibers were introduced in the diet. Therefore, it changed a lot of sea changes, so that again, leaving people confused. We all know the fat diet became a big story again, and this is the Banting William again, but he was undertaker, not a doctor, and he himself started this fat diet. And they typically do not focus on long-term weight loss, but they usually focus on, and they're usually not very healthy. And what you see, any of the diet you take, you lose weight for a short while, and you regain weight at the end of 1 year. So therefore, they do not sustain for a long time. Then we have this intermittent fasting, where you fast for 2 days or 3 days, or you take 3 days very low calorie diet and so on and so forth. They improve the insulin sensitivity, they reduce hepatic steatosis, they improve glycemic control, and the weight reduction is quite good. And the plausible explanation is they increase the amount of ATP production, they improve the mitochondrial biogenesis, they also improve the autophagy, and therefore have a better impact on the patient's diabetes control. This was again very elegant study presented in the American Diabetic Association, where the sequencing the food, how it's important. The study which looked at first you give carbohydrate, then you give non-carbohydrate diet to the same patient, which is same caloric, isocaloric. And on day 2, the patient comes here. First takes the leafy vegetables and then takes carbohydrate. What difference it makes? You can see here there is a 60% drop in the postprandial blood sugar control, and therefore the patient couldn't get control very well by just changing the sequence of eating pattern. This is again eating 2 large meals a day, a breakfast and lunch, and at 6 multiple meals. How it's important? What is more important? Whether it's 2 meals only or whether it's 6 meals. This is a study from Czechoslovakia presented in Dietary again in the year 2014. It looked at multiple parameters besides the blood sugar control. They looked at the hepatic fat content. They also looked at the resting energy expenditure. And it said, I'll take another 1 minute or so, 1 or 2 minutes, and finish off. And what it showed was actually, this slide showed that there is a benefit in having 2 meals a day. There was in between a Dikshit diet, which came as a very popular diet. But mind you, this is the calorie restricted diet, where the patient had only breakfast and lunch. There was no dinner at all. There was a time restricted eating. And this study was a very short duration trial. And most of the meals were provided to the patient, only half of the people. And the possibility of reduced energy intake in the B2 regimen, because of the participants were given that kind of food, the dropout was pretty high. And of course, some of the patients also took oral hypoglycemic agents because they wanted to avoid insulin. So therefore, this study is not a good quality study. I think all of us know about the DIRECT trial. People talk about reversal of diabetes. Roy Taylor became overnight famous because of this trial, which looked at 298 patients with the restriction of calories, and he could get the weight loss to a tune of 15 kilograms. And what did he say? That rapid weight loss keeps the promise of type 2 diabetes remission for a period of 2 years. And he can show it convincingly that 70% of the patients who maintained the weight loss for more than 15 kilograms remained in the remission for 24 months. Therefore, the cure of diabetes became an option. With all this confusion, people stepped down, and this was the authoritative review, which looked at the dietary policy priorities for cardiovascular disease, diabetes, and obesity, which is a very comprehensive, which classifies nutrition into those who give benefit versus those who do harm to patients. And therefore, the entire focus now has changed from foods instead of nutrients, from meal patterns rather than the single nutrient which you change, and the mechanisms of the health benefits. For example, we do a lot of omics studies, microbiota, functional imaging, and the gene and diet interaction. So therefore, there's again a big change in looking at diet as a nutrition and a kind of a science which can translate into the benefit to the patient in getting the weight loss, also reduction of A1C. The recommendation from the American Diabetic Association 2021 says that you take 45 to 55% of carbs, 14 grams of fiber per 1,000 kilocalories, which roughly translates to 40 grams of fiber, 15 to 20% of protein, and less than 30% of total fat. And the current recommendations are based on the evidence regarding the effects of the diet in reducing the body weight and the cardiovascular risk factors. However, this is not one size fits all. The patients who have got chronic kidney disease may not restrict calories, and therefore the changes can be different to prevent hypoglycemia, ketoacidosis, kidney disease, and so on and so forth. So a lot of rooms are kept for the change in patients of diet. So to take home message, what I said in the last 25 minutes, during the Stone Age, the humans used and consumed meat, fish, insects, eggs, fruits, and berries, nuts, and amount of carbohydrate consumption was limited. As they discovered fire and learned the agricultural techniques, carbohydrate content gradually increased. And before discovery of insulin, stringent diet was the only way to deal with the diabetes after insulin discovery. Also, physicians focused on diet therapy as the adjunct therapy, which gradually evolved over time. After Green Revolution in India and industrialization, carb content increased significantly. And though the guidelines suggest to restrict carbs to 45 to 55%, the macronutrient distribution depends on the individual circumstances, and each patient should receive individualized dietary counseling to optimize the blood glucose control. With that, I thank you very much for the patient listening.
Thank you so much, sir, for the wonderful lucid evidence-based presentation. In the beginning, you have used the word cuisivores. So I would like to just add to that, because of introduction of many cuisines, we had landed with nutrition transition, because people and the youngster always talk about, have you tried this cuisine? Have you tried that? So there is a nutrition transition. So we really need to address that and revert back to our traditional sustainable eating pattern. And the similar guidelines have been given by even, NIN and ICMR. So over to Shakti.
Thank you so much, sir, for the wonderful session. And I think these 20 minutes actually brought the 100 years of MNT to us.
Thank you.
Thank you for this wonderful
It's
session.
difficult to compress 100 years in 20 minutes.
I invite Kavita Gupta ma'am to felicitate the...
I request Neglur sir and our organizing secretary, Dr. Kavita Gupta ma'am, to please felicitate our chairperson. Actually, thank you, Chairperson Renuka ma'am and Shakti ma'am, for chairing the session. Thank you, Neglur sir, for giving the century perspective of MMT. Thank you. So now I will request our next session navigators, Professor Nilima Joshi ma'am, Dr. Kavita Bakshi ma'am, and Ms. Sonal Modi, to please come on the dais and chair the session. This session will be a duologue journey of micronutrient. So the next dialogue is on carbs, the good and the bad. The pilots are Dr. Kavita Gupta and Ms. Cheryl Salis. I request them to join the dais and hand over the podium to chairpersons.
Thank you. Yeah, so a very good morning to everyone. And at the outset, I would like to thank Dr. Sunil Gupta and Dr. Kavita Gupta for giving us this opportunity, and to start with the journey of macronutrients. As we all are here at Hippocrates terminal, I would like to remember his quote that let food be thy medicine. So with this, we start journey of macronutrients, and I call upon Dr. Kavita Gupta and Dr. Ms. Cheryl Salis for the same. Cheryl, she's a registered dietitian, certified diabetes educator, insulin pump specialist, certified sports nutritionist, and many more. So, and actually she doesn't need any introduction. And as in Marathi we say, ki murti lahan pan kirti mahan. So she is one kind of that. And our dear own Dr. Kavita Gupta, she doesn't need any introduction at all. So I welcome both of them to take it over.
So thank you so much. And again, I take this opportunity 1 minute to welcome each one of you, especially all my very dear friends and all the people here from Indian Dietetic Association Nagpur chapter. So we are on board for the flight of Hello Diabetes Academia at Hippocrates Terminal, and we are going to soon be boarding the journey of carbohydrates. Well, let me tell you, in fact, my 100% work is done because Naglur sir actually took us through the full journey so well. So I think we really have no words and nothing more much to speak upon. But however, we all know that long back that diabetes has been always considered as a disease of carbohydrate metabolism. However, the definition now has changed, and it was long back in 6th century who our Indian physician Shushruta already actually he identified diabetes as madhumeha and sweet urine, and we all know that at that era, the first thing what they started was starvation diets. And literally, sir, yesterday there was a wonderful lecture of Dr. Sundar Mudliya, sir, and he said that during that period, when there was a discovery of insulin before 1921, they were put on very low carbohydrates. That's only 10% of the carbohydrates, and I think that very much refers to the keto diet, I think what they are taking. And even in like the 20s and 30s, again, there was, there was a change of the people then switched over to high carbohydrates. Then again to in 1980s, it went to low fat and high carbohydrate. So basically it's a pendulum which has been swinging from high carbs to low carbs and again, to moderate carbs now. So, so what are the actually Indians taking? We all know that India is a carboholic country, and whatever reports, the What India Eats report, the Eat Lancet Commission report, they all have said that India diets are typically rich in carbohydrates, that almost reach to 70%. So that's really pretty high. And whichever part of India you go, the diet is really rich in carbs. And why this carbohydrate is the main culprit? I think sir has very beautifully said it's the main villain. And even the starch study has already focused, the higher the amount of carbohydrates, higher is the postprandial blood glucose levels. Moreover, it's the higher amount of carbohydrates, it also decreases the insulin sensitivity, it increases the fasting triglycerides levels, and it also reduces the HDL cholesterol levels. So, let me ask my good co-pilot, are all the carbs same? Because that really is very, very confusing, especially to all my patients. And I want all the diabetes educators and the nutritionists here to please stay glued because we are going to really discuss on very important aspects.
So thank you so much. And people say, if I'm eating carbs, what does it matter if I eat noodles versus eating a chapati? They're all carbs the same. And we know that, and today, thanks to CGMS and blood glucose monitoring, we really know the impact of different kinds of carbs on the glucose levels. And therefore, all carbs are not the same. And we have the good carbs and we have the bad carbs. So then definitely we have to consume more of the good carbs because it also gives us the most essential dietary fiber. And we know the importance of soluble fiber and insoluble fiber because we are increasingly seeing a very increasing incidence of metabolic syndrome in our country. So we have a high population with pre-diabetes, dyslipidemia, and hypertension, along with all other conditions such as cancer, etc. And therefore, taking good carbs, especially, intake of good quality carbs with good amount of fiber is extremely essential. And if you look at our Indian diets, traditional Indian diets, they do provide us with all the good carbs, whether it's lentils, whether it's your fruits, whether it's your vegetables, and whether it's your whole grain cereals, your millets, all of them provide you with the good carbs. And therefore, when people say that, carbs are a villain and in diabetes we should avoid carbs, The answer is no, because carbs are extremely important. And what we're looking at is sustenance. People can go on a low carb diet, but what we don't achieve is sustainability. And we have to look at a sustainable, economical, easy to do diet. And therefore, good carbs are definitely to be included. We're also talking about gut health today and prebiotics again, coming from your good carbs and bad carbs. And we definitely see that when it comes to your, on your CGMS, the blood glucose spikes. The moment you eat foods which are refined, you will immediately see a sharp spike in blood glucose. So people who think that brown bread is better than white bread, we see the same response. And today, a lot of our grains are processed and polished, and we do see an impact of blood glucose, a very sharp spike on the glucose levels just by eating more of the refined carbs. And therefore, the message that we have to give our patients is that choose unpolished whole grain cereals, millets, and that is very, very important to ensure that you get the good glycemic control. Now, this is something I think which Neglur sir has already alluded on, and I'm just going to talk about it because today you have the sugar-free market which is booming, and people will not have sugar thinking that sugar is a villain, and then they will have jaggery and honey and mithais made out of it by the kilo. Even when we have to gift somebody who has diabetes, we will give them sweets made out of jaggery and honey. But if you look at the carbs, you look at the calories, they're almost similar. And in fact, if you look at the glycemic index also, in fact, jaggery, from the papers that I found out, the glycemic index of jaggery is 87 and the glycemic index of honey is 62. And therefore, all three need to be taken in moderation and the same principles need to be applied. So they're all equal. So portion control is very important. And I always tell my patients, and I'm sure all of us do, that eat the real thing because then you will just eat limited amounts. The moment diet is written on the packet, you eat unlimited because you think that it's diet and I can eat as much as I want. So again, when we're looking at good carbs, very important, especially when it comes to diabetes, is lentil carbs. And we all know the benefits of lentil carbs. And if you look at the sources of lentil carbs, they're all present in your regular foods that you eat at home. You don't really need to buy expensive foods from the market. So it's your legumes, your chickpeas, your kidney beans, your soaked pulses, oats. And again, very important when it comes to oats, because people go out, they buy oats, and then they wonder why is there a spike in glucose level. So basically, they're buying your refined oats or they are buying the instant oats. So very important message that we have to give our patients is that you either buy steel cut oats or rolled oats because that has got the fiber and the beta glucan. Again, barley is something which was consumed in India ages ago. Even in Ayurveda, there's a mention of barley. And we see an amazing glycemic control, especially when they incorporate barley. So these are all sources of lentil carb. They're slowly digested. They form like a viscous they have viscous fiber in them, and therefore the release of glucose is very, very slow, and that's why it's called lentil, just like we have lentil insulins. And then resistant starch. I think resistant starch is so much of talk going on resistant starch. There's so much of studies going on resistant starch because they resist digestion in the small intestine and they act like fiber. They have prebiotic benefits. And again, if you look at the sources of resistant starch, they are easily available in all your Indian food preparations, your whole grain cereals, legumes, nuts, seeds, and starchy vegetables. And the best part is, if you're looking at RS3, if you're going to cook and cool foods, for example, you cook a potato, you keep it overnight in the fridge, and then you cool it, and then you reheat it at low temperatures, a resistant starch remains, and the glycemic spike is much blunted. So therefore, RS is very important. And yes, there are studies done in India by Dr. Anup Mishra, by Dr. Mohan, that yes, when you consume a lot of refined grains, it directly has an impact on your blood glucose levels, but also on insulin resistance, hypertriglyceridemia, etc. And therefore, very important is to use, and the good carbs and the bad carbs need to be moderated. And in fact, we tell them to just use it once in a way, not a regular feature on our Indian diet. So let's understand the story of numbers. So we have glycemic index and glycemic load. And now over to you, Kavita, to explain about the glycemic index and glycemic.
Another important aspect whenever we are talking about carbohydrates, it's again glycemic index and glycemic load. So it was way back in 1981 that, when Dr. Jenkins, he evaluated, he brought into picture about the picture of glycemic index. So here that's a beautiful graph which shows us that is the impact of the different carbohydrates. How does it impact your blood glucose? So we can see that the pink graph, when you're going to consume a simple sugar, there is a a steep spike in the blood glucose as compared to the soluble fiber, which is the orange one here we can see. So that is the effect of the different types of carbohydrates on your blood glucose. And the glycemic index, we all know, lower the glycemic index foods, that less than 55, better is that food, and it will not spike your postprandial blood glucose. And these are the different, the glycemic index of the various foods. We know that, yes, we all know that all the cereals have a, especially the white rice, the cornflakes have a higher amount of glycemic index as compared to the green leafy vegetables or the legumes or even few fruits which have a low glycemic index. Another picture which came to the mind in 1977, the concept of glycemic load, which was introduced by Salmeron at Harvard University, and it actually takes into account the quantity of the carbohydrate. So the quantity of the carbohydrate content is also again very, very important. And this is a formula I think we all know, the carbohydrate content into the glycemic index divided by 100. We all know again that the glycemic load again should be less than 10. So all the foods which have a glycemic load less than 10, they are good and more user-friendly for the patients or the people with diabetes. So these are few examples which you can quickly see. That the apple, we know that the glycemic index is around 40. The carb content of one apple can be 15 grams, it depends. And the glycemic load therein is around 6. So it has a low glycemic load of that particular food is 6. Similarly, the watermelon, we see the glycemic load of watermelon is high though, but the carbohydrate content of the watermelon is around 6 grams. And when you just see the glycemic load of the watermelon, it's around only 4. So it's safe enough to consume watermelon, especially for the patients who are, who will always see the glycemic load. So we need to see both the aspects. We also need to see the glycemic index, and we also need to see the glycemic load of that particular food. Even the chocolate candy, you can see that the glycemic load is high. Though the GI is low, but the glycemic load is high. So thereby it will also impact the blood glucose levels. And this is a wonderful study by Dr. V. Mohan, which has shown that what will be the effect of the dietary, the amount of the carbohydrates, the high glycemic index, and the high glycemic load food, how it increases the risk of type 2 diabetes. And this is the reference value you can see. And as the odds ratio increases, you can see that the risk increases. However, when you see about the fiber, the dietary fiber is inversely associated with diabetes. And this again is a wonderful study which says that the low glycemic index and the medium glycemic load foods would not only reduce your blood glucose, but also will reduce your A1C, your triglycerides, your cholesterol, and HDL levels. It will increase. So that is why we know that taking a low glycemic index and a low glycemic load food would naturally impact on the blood glucose level. So, and this is a wonderful plate. I think sir has also showed that how we can reduce the amount of your starchy, we need to add, so half of your plate should be added with non-starchy vegetables, 1/4 with your proteins, and 1/4 with your grains. So this is the way you can actually incorporate low glycemic index and low glycemic load foods. So I think over to Cheryl.
Yeah, so we're looking at setting carb goals. So it's not a one size fits all. We definitely have to look at the quantity, the quality, and most important is diet diversity and nutrient density. So very, very important is to choose foods with low glycemic index and glycemic load, and making sure that, for people with insulin, especially, because they think that you have to eat carbs and eat 5 times a day, like sir said. And usually you will see people eating a packet of biscuits or a bhujia packet or something which is very carb rich as in between snacks. And today we say that only your meal meals should have carbs. Again, moderation of carbs is important. And the mid-meal snacks, unless you are on an insulin which requires a mid-meal snack having carbohydrate, you can go on or choose low carb good fat options. Again, in type 1 diabetes, people on CSII, we follow carb counting. So insulin to carb ratio becomes very important to prevent hyperglycemia as well as hypoglycemia. So again, we're looking at fructose. And now let's hear from Kavita about fructose, because that is something which people think that, okay, glucose is bad, but fructose you can take as much as you want. So let's see what Kavita has to say.
Fructose is the main villain now, and though we know that it is available in many fruit juices and even in honey. And let me tell you that though fructose, whenever it is metabolized, it is more slowly than sucrose, but again, it is a more lipogenic than glucose. So that is very, very important for us to understand that. And the recommended values of fructose is around 25 to 40 grams per day. And whatever there are fructose sources like in fruits, it's available. But again, the RDA says that it should be around 250 grams can be. Add something.
So basically the culprit actually when you're looking at fructose, even if you look at your packets, whether it's your fruit juices, even however real they claim they are, it's got high fructose corn syrup, and high fructose corn syrup is actually a villain because that causes your hyperuricemia, your hypertriglyceridemia, and therefore we have to teach our patients to read the ingredients in the food labels and look at if there is high fructose corn syrup, and definitely avoid foods which have got HFCS. So that is something that we would definitely look at. Again, mango. Like Sir said, you know, people on WhatsApp, we are woken up with messages in the morning from friends, family, and patients saying that, okay, can I eat 5 fruits a day, or I can eat unlimited mango a day and my sugars will not go high? You look at this experiment that the doctor has done, and these are the kind of WhatsApp that we get. They do not understand that when they put fructose on glucose, you know, on your blood, the glucometer is going to check your glucose and not fructose. And therefore, obviously, you're not going to get your readings. And then on social media, people use this platform to talk about it. So let's look at mango. So if you have so many varieties of mango in our country, and the glycemic index of mango is between 51 to 60. If you look at the glycemic load of mango, it's between 7 to 9. But very important when it comes to mango is to eat it as an in-between snack before a workout. Very important is that the glucose levels need to be in control. If you're having uncontrolled glucose levels, it doesn't mean you can eat unlimited mangoes, and definitely is to eat it seasonal. So when it's in season, slightly unripe, what fits the fist, and as mid-meal snacks, again, keeping in mind what is the pre-meal blood glucose levels. With meals, we see a sharp spike in glucose, and most of us will eat the mango with meals, either as an amras or a juice or a mango. You know, they will just have mango pieces. Similarly with coconut water, you know, a lot of patients ask us about coconut water. And again, here is our take. Even if you look at coconut water, the glycemic index and the glycemic load is low, but very important is that it's no fiber. When you eat fruit, you get the fiber. So coconut water doesn't give you the fiber. So if our patients want to have coconut water, we always tell them to have it either with the malai or with chia seeds or with nuts, and have it in moderation. Very important again is that the glucose levels need to be controlled. And this is our patient. I mean, this is a message I received because I wanted to see the impact. And if you look at it, if you are educating them in how to take it, how much to take, what is the glucose levels before, you do get a good glucose control. So very important. It is not again a one size fits all approach. And just the last couple of slides.
So again, we know that all the recommendations, whether it is RSSDI, ADA or ICMR, it always recommends that the carbohydrate value should be around 45 to 60%. And again, it should be more of fiber. And whenever it comes to sugar, so we need to avoid all the simple carbs and avoid high fructose corn syrup. I think that's a very important message for all the people here.
I think this is just the last one, is because this is something that we are often asked, to keto or not to keto. And today everybody is purporting keto. So how many say not to keto? Okay, so I think everybody, all the dietitians definitely say not to keto because it's not sustainable. You have a lot of side effects, and we're a carb-loving country. We're eating 65 to 70%, and now we're saying eat only 5% carbs. Very, very difficult to implement, very difficult to sustain, and we know all the kind of side effects that happen with it. If the person has to be doing it, it has to be monitored under strict supervision for a short period of time, looking at supplementing with the essential supplements because nutritional deficiencies can arise. We do not know what is the long-term impact of this kind of diet. I've reviewed 72 papers on ketogenic diet, and if you see, most of them are not more than 6 months. Okay, so we really don't know what is the long-term impact. People eat unlimited amount of fat. It's butter on butter and ghee on ghee, and unlimited amount of non-veg foods creates a very acidic environment in the body, leaching of calcium, leading to long-term, we can look at osteoporosis. Another thing is if somebody's got high uric acid, it actually goes and causes the uric acid levels to go higher. So very, very important is to look at your patients, do the baseline, and again, do it for a short period of time. And this is what even the Sara settlement study, this is a very, very, it's a cohort which was done. And this clearly shows that very high carbs and very low carbs is not good. And what we have seen in our clinical practice is that going up to 45 to 50% of calories coming from carbs, good carbs does the trick. We really don't need to go to 20 grams of carbs, and obviously high carb diets is bad. So to summarize, that it's not a one-size-fits-all approach. We have to look at carbohydrates are not a villain, they are important, but important to incorporate good carbs coming more from your legumes, your unpolished millets, and looking at the quality as well as quantity, and moderation is key. And like I said, 45 to 50% of calories coming from carbs is what we are able to achieve good glycemic control. So thank you so much for your patient hearing. So this was a story of carbs.
Yeah, thank you so much, Cheryl.
So we
and,
both are signing off from here, and we had a safe landing, suppose.
for a wonderful presentation and clearing the myths about sugar and jaggery and good carbs and bad carbs. And the key message is portion control and moderation is the key message. So thank you so much. Yeah. Now I give it over to.
Just comment, just few. You want the comments now on carbohydrate? Okay.
At the end of the session.
We will have felicitation of carbs, protein and fat together at the end.
We have our pilot speakers, Ms. Shilpa Joshi and Ms. Shubhada Vinod. Can you please come on the stage and start with the session? Over to the chairpersons for the next session.
At the outset, I am thankful to the commanders of this ship, Dr. Sunil Gupta and Kavita Gupta, for giving me an opportunity to navigate this huge ship of education and knowledge. In the next journey of micronutrients, moving further, our next destination is proteins. Proteins are the building blocks of our body. Protein toxicity can cause serious health problems, and there are numerous brands of protein powders in the market, and how to choose them, which are the best ones, are the questions or queries in our mind. To guide us further and to make this voyage successful, we have with us eminent dietitians, Mrs. Shilpa Joshi and Mrs. Shubhada Bhanot. Let me introduce Shilpa. I think there is no need to introduce, she is saying no. So moving further, I welcome you, ma'am. Please I request you to start the session ahead.
So, good afternoon, everybody. At the outset, on both our behalves, I want to thank Dr. Sunil Gupta and Kavita for having us here. And today we are going to talk about proteins, the use and misuse, me and Shubhada Bhanot with me. So, there is recommendation, there is research, and then there is real world. So we read recommendations and research, but when we sit in our clinics, what we have to do is we have to actually apply them to the real world. So therefore, what we did is we are presenting you with one person. I'm sure all of you sitting here have seen these kind of people coming to your clinic, and we are going to talk about how are you going to recommend protein in this person. So this is a 32-year-old man who is newly diagnosed with type 2 diabetes. He is 172 centimeters tall, 85 kilograms in weight with a BMI of 28.8 kg per meter square. His fasting blood glucose is 165 milligrams per deciliter. A1C is 8.2. He has a family history of diabetes. Both parents have diabetes. He is symptomatic. He has polyphagia, polyuria, polydipsia. His serum cholesterol is 220. LDL is 140. Triglycerides is 153. His uric acid is 7. Creatinine of 0.06. And he works in MNC. And look at what he eats. This is his meal recall. And I'm sure all of you, I wouldn't even say 95 or 98% of you, all of you will agree with what he eats, because this is what most of our patients and probably even we eat on a very busy day. So he skips his breakfast. I will have tea and biscuits once he reaches office at around 11 a.m. Lunch at office, rice, roti, paratha, noodles with dal, paneer, mushroom, chicken, and a sweet dish. This is something he gets at his work. Evening tea with a fried snack, whatever is available in his work canteen, or packaged food. And for dinner, he mostly orders in, because he and his wife both are working. If maids don't show up, they're typically ordering in. And if it is cooked at home, it's aloo ki sabzi with dal roti, because it's quick, and probably a scoop of ice cream after that. And of course, on weekends, he's going to have a couple of drinks with his friends. So this is the scenario that we are talking about. Now, looking at this diet, Shubha, what do you think? What are you going to recommend to this patient?
Thank you, Shilpa, for explaining the case so nicely. So today, as we know, we're talking about proteins, their use and misuse. So the minute we talk about proteins, we all know that they're building blocks for our body, and they're very important macronutrients. We know that they're made of amino acids, and 20 amino acids are found in plants and animal groups. And the sequence and the number of amino acids, they determine how the protein folds and how the shape of the protein, and that defines the function of the protein in our body. And our body is made up of thousands of proteins, and that determines, and then the protein functions comes in our body. And proteins, these thousands of proteins in the body, they do a lot of functions in our body. They form the structure of the cells, the hormones, the enzymes, they work for fluid balance. Having so many functions also, the content of protein in the diet of an Indian is very, very poor. And remind you, the way our body stores carbohydrates and fats, the body does not store the protein in that way. So the consumption of essential amino acids in our body is very, very important on a daily basis. So when we talk about the protein in Indian diet, 9 out of 10 people, they consume inadequate amounts of protein in India. Protein deficiency among Indians stands at more than 80%. Now, ADA recommends that when you're prescribing protein, when you are recommending proteins, you have to take a individualized decision, and that will be based on the factors, which will be on the metabolic condition of the patient. It will be according to the age, the sex, the physical activity, the biochemical parameters, and definitely the food preferences. The current recommendations for protein are very wide, 10 to 35%. The 35% recommendation is from the Institute of Medicine. Now, in India, we don't use this 35%. Maximum what we do reach is 15%. And these variations were set by the difference for accounting for carbohydrates and fat need of the person. The National Kidney Foundation recommends 0.8 grams protein per kg ideal body weight. And people with diabetes, when they reach the chronic kidney disease, sometimes we bring it down to even 0.6 in the third and the fourth stage. Now, the ingested protein, it does influence the insulin response without influencing the glucose response. So when we are eating a carbohydrate source, which is very rich in protein, we should not use it to prevent hypoglycemia. And we do that. We do sometimes give a high protein and a high carbohydrate snack at the bedtime, thinking it will prevent hypoglycemia. It does not work that way. And we see a rise in blood sugar levels 3 to 5 hours later after a significant protein is given in a meal. And when I say significant, it is more than 21 grams of protein in one meal. Now, these are the recommendations which we normally follow in our patients, which are by RSSDI, by ADA, and by ICMR. As I said, if you're able to reach a goal of 15% calories from proteins, we have done our job. And easier is 0.8 grams per kg idle body weight. ICMR actually recommends certain preferred sources, which are from the vegetable sources, low-fat milk, products, fish, and lean meat. If you remember the case had high uric acid. Now, what happens in our clinics is that many dietitians, the minute they see uric acid, or even the patients after reading Google, the minute they see high uric acid, they remove all the protein sources from the diet, which is not correct. So specifically here, I've shown this food pyramid for the gout patients. If the patient is overweight, the first thing is to make the patient lose weight and not restrict protein. Keep the patient hydrated. Remove alcohol. Reduce fat. Make sure the patient is not eating fish and red meat. Don't remove eggs. Don't remove milk. Don't remove legumes and pulses. They will not increase lot of uric acid. Purines have to be restricted, not proteins. So what happens, an overweight patient comes in, the patient stops eating legumes, the patient stops eating pulses, all proteins, starts eating a lot of carbohydrate, the weight doesn't go down, and we don't get good results when it comes to uric acid also. Please do not restrict protein, even if the patient's uric acid is high. So now this patient, after consulting the dietitian, the educator, getting good training, starts going to gym. And when he goes to the gym, he comes to Shilpa and says, okay, now what? I'm trying to lose weight and I want to use supplements. Can this patient use supplements? What are the recommendations? And what happens to people with diabetes when they do exercise? Can we have the answer here?
Okay, so now this person on his way to good health and lifestyle modification, newly diagnosed and hence full of hope and energy and optimism, goes to a gym and decides that he is going to sort of not only do basic exercises, but also weight training, the whole gamut. So now let's look at it. The first thing is it's very important that he gets his medications adjusted when he starts exercising. If, whatever the medications are taken, he'll have to see that there is no hypoglycemia induced because of exercise so that he will keep exercising. Otherwise, one bout of hypoglycemia and then people get very scared to exercise. Now, these are macronutrient composition in meals before, during, and after physical activity in athletes with diabetes. So it's very important that they have something before, during, if it's a long stretch of exercise, and after exercise. So typically a full meal, 2.5 to 4 hours before exercise, and that meal should be, carbohydrate should be about medium amount of it, so about 50% with a low GI emphasis, moderate protein, and a low fat content, and it is very important that their glycemia is monitored. During exercise, about a 30 to 60 gram in liquid form of gel or hypotonic drink or energy bar, only if they are doing real kind of exercises, going to gym and trying to maintain their blood glucose. About a gram to 1.5 grams of carbohydrate per kg in order to restore muscle glycogen, that is after exercise, and about 10 to 20 grams of protein for the repair, construction of the muscle tissue. Now, this is very important to understand that protein intake in athletes is very important, and it should provide maximum about 15% of the total energy intake. The best intake should not ideally exceed 0.8 to a gram per kg body weight. protein addition in athletes with type 2 diabetes may influence an increase in postprandial insulin response, exactly like Shubhda had said, without increasing glucose concentration. So therefore, when adequate carbohydrate is delivered, adding protein to carbohydrate does not appear to improve endurance performance over a course of few days or few weeks. Adding protein during or after an intensive bout of endurance exercise may suppress rise in plasma protein linked to myofibrillary damage, and therefore the soreness that this patient is going to get after the exercise will be reduced if protein is given in the food after the exercise. When resistance training program and a hypoenergetic diet is given, an elevated daily intake of protein can promote greater loss of fat mass, overall improvements in body composition. Now, after this exercise, he probably met a lot of people in gym who were on keto diets. So therefore, he decided that he might want to give a try to one of these keto diets, and therefore he went back to Shubhda and he asked her what can he do about keto diets. Sorry.
Yeah, so we had a little bit of introduction of keto diets in Cheryl's talk and Kavita Ji's talk. So dietary proteins influence body weight by affecting 4 targets of body weight. Satiety. When we eat proteins, the satiety is managed because when we eat proteins, they influence the hormones of the gut, the GLP-1 and the GIP, and they also suppress ghrelin, which is the hunger hormone. The increased thermogenesis there, the metabolic rate increases because the digestion of protein, which we read as the specific dynamic of action of food, is more. And the protein ingestion results in higher ratings of satiety than the equally caloric amounts of carbohydrates or fat. The diet-induced thermogenesis is higher for protein than any other for macronutrients, and the increase in energy expenditure is caused by protein and urea synthesis and by gluconeogenesis. The effect is higher when we have animal protein because it has essential amino acids, and specifically diet-induced thermogenesis increased after protein ingestion by 20 to 30%, but only by 5 to 10% when we have carbohydrates, and 0 to 5% after ingestion of fat. Definitely dietary protein was seen to give you more weight loss. So when we have ketogenic diets, the intake of carbohydrates is substantially reduced to less than 5%, and fat is increased and protein is increased. So the protein content in ketogenic diets comes out to 1.2 grams per kg of protein per day, which is in the range of moderately high protein diets. Now, for patients with existing kidney disease, the diets high in protein intake may accelerate progression of kidney disease. For individuals who are without kidney disease, there is not enough data, but several prospective studies have shown that animal protein, which is very high in ketogenic diets, may increase the risk of developing CKD. Now, animal proteins in ketogenic can also lead to kidney stones, as Cheryl also talked about the health implications of ketogenic diets. Now, this can happen because there's too much salt, the urine becomes acidic, there is not enough fruits and vegetables, there is not enough citrate in the urine, too much fat, and there is not enough calcium in the diet. This leads to kidney stones. Now, it's not only the protein, it is also the fat in the ketogenic diet. Now, there's higher risk of albuminuria among study participants. It had higher animal fat, then the lower animal fat content was lower in animal fat. And in another study, high saturated fat intake was associated with increased risk of albuminuria and increased GFR. Now, this patient, after continuous of following different types of diet and with prolonged bad sugar control and losing weight, gaining weight, after 15 years, ends up with diabetes, kidney disease. He lost weight because of loss of appetite. Serum creatinine was high, potassium was high, and the minute he read Google, stopped all non-veg, eggs, milk products, pulses, legumes, and the only protein he was getting was from moong dal, and some cereals. And then he again goes to Shilpa, what should I do with diabetes kidney? What are the recommendations? What protein should I have?
So we thought we'll finish it really early, but doesn't look like. So this is how high proteins diet actually affect the glomerular filtration rate. High protein intake actually causes vasodilation in the afferent arteriole that increases intraglomerular pressure, which increases the GFR, and that becomes a problem. So therefore, if you look at this, if there is a high protein diet, there is dilated afferent arterioles, which increases intraglomerular pressure, damages the glomerular structure, and then there is loss of more nephrons over a period of time, and there is increased glomerular pressure. So therefore, protein does impact kidney disease, and there is data to show that there is hyperfiltration with high protein consumption, and hyperfiltration will also lead to increased risk of proteinuria. So there is data which shows linking high protein diets with proteinuria. It is inconsistent, but the finding was very, very consistent among individuals who had hypertension and diabetes, and our patient had both of them. Now also when dietary proteins are consumed, there is high amount of phosphorus which is consumed, and again it has been shown that dietary phosphate load increases expression of fibroblast growth factor 23. And this is associated with vascular calcification among patients with CKD and left ventricular hypertrophy. This will lead to higher progression of the kidney disease. Now again, what is the recommendation? So initially the recommendations was that a low protein diet of 0.6 to 0.8 gram per kg per day were advised in the patients with CKD. But now it has shown that long-term low protein diets, which are lower than 0.8 gram per kg body weight, do not result in delayed progression of CKD, but they are strongly related with the risk of elevated sarcopenia, and therefore about 0.8 gram per kg per day of protein should be given to persons with kidney disease, but not more than that. And it is very important that at a lower level of creatinine, there should not be too much restriction on protein for the risk of sarcopenia. Now, always the question is whether veg protein or non-veg protein. So again, it is shown that animal protein increases hyperfiltration, albuminuria, and kidney failure, and vegetarian protein or protein from vegetable sources are much better in protecting kidney issues. So with this, we come to some take-home messages.
So the first important thing is, before you make any recommendations for a person with diabetes, determine the protein intake before recommending. So we cannot just say, okay, start taking 0.8 or 1 or 1.2. First, determine how much protein the person is taking and increase protein gradually. So if a person is taking 0.3 grams per kg body weight, you cannot suddenly make it 0.8. So please increase protein gradually. Emphasize on protein intake in each meal. So you cannot have one huge protein meal and then do not have protein in the day. So each meal, there should be some protein. Like we emphasize on carbohydrate consistency, you have to emphasize on protein consistency also. Definitely meet the protein requirement over a period of time. Include high biological value protein, which means definitely have lean protein in the meals. You can have it from animal sources also. You can have it from vegetarian sources also. As ma'am said, vegetarian sources are also very good sources. Even if they have the limiting amino acid, you can complement it with you can complement rice with legumes or dals and make it a complete protein. Start the meal with protein and fiber. It will help the patient have better postprandial control. The spike of the glucose will be blunted. Before restricting protein in CKD, determine the intake. Again, I'm saying, please, before you restrict any protein, please make sure the patient is eating enough protein. Most of the Indians do not eat enough protein. So even in chronic kidney disease, we do not need to restrict protein. Ma'am, some more messages from you?
Also that the type of protein matters, especially in a person with complications like nephropathy. Vegetarian protein is shown to be better than animal protein, but remember that there are glucoregulatory properties of protein, and all animal proteins are not same. And it is shown that higher intake of dairy products, that is products coming from milk, yogurt, cheese or whey protein have shown to be beneficial in relationship with glucose regulation as compared to animal protein which is coming from meat. Protein supplements are essential to bridge gaps, especially in food-based consumption and needs, especially in individuals who exercise and who are on weight loss. And therefore, there is a role of protein supplementation, meal replacements, so on and so forth. And like Shubhda said, proteins have a high satiety value. So they are very good ammunition to have. So use them judiciously. Thank you so much for a patient hearing.
Okay, going to take the comments for carbohydrate, protein. I'd just like to make a few comments which are for both the sessions. One is that when we consider fructose sugar, as already mentioned, in the metabolism, fructose being a slow sugar, finally does get converted to glucose. Please remember that it does get converted to glucose a little slower. So the best recommendation in such a condition for a diabetic would usually be that about 2 fruits a day. We're trying to make sure that the hidden sugars from where fructose could get creep in are not included. But yes, about 2 fruits, up to 2 fruits a day is quite fine for a diabetic as a recommendation, because that much fructose would be metabolized fine by the body. The other thing to remember with carbohydrates, both the talks have been fantastic and given you an overview with the guidelines. But with carbohydrates, we also need to remember that it is the cooking method. Please keep in mind that all these macronutrients interact with each other. So it's the cooking method that is more relevant to carbohydrates, because that's part of our staple cereals. Our cereals, some of the pulses and the millets. All of them are used daily. So I would say that somewhere down the line, we go back to picking up some of the judicious aspects of the traditional foods and cereals and pulses and millets that we used, and a combination of those as part of the daily carbohydrate intake for a diabetic. Additionally, coconut water, which Cheryl brought out. Now, we found very strangely in hospitalized patients in the, when they're recuperating, coconut water has always been the drink for, recuperation. Funnily enough, even on a person who's well controlled on insulin, because of perioperative, preoperative, post-operative, the sugars have shot up to 600. So even though the load, GI, everything is fine, there's something happening there. There is no documentation on this anywhere that we have not found that. It is most likely, if you go into the metabolism, that it is the sodium-potassium channel. Something makes that coconut water being potassium rich, it just speeds into the body and raises the sugar. This is food for thought, food for maybe, young budding nutritionists to consider this and even do research on it and figure out, because it's a very important integral food in our country. So this is covering your carbohydrates. I'm just going to make some quick comments on protein. So in part of the protein, whether it is for a diabetic or a diabetic with kidney, any CKD, etc., you opt for, in all this combination, you keep the protein neutral. The bottom line guideline is the protein is neutral with all the combinations that Shilpa and Shubhda mentioned to you. But additionally, remember that in the animal protein, just to bring out a very small point, that the egg white protein is pretty neutral and is least damaging to the kidney. The microalbuminuria you will not see. The basement membrane will be least damaged compared to the lean meat protein also, in the discerning of which kind of animal protein to take. Another important point that they brought out was post-exercise. You have to remember that in a diabetic, there can be hypoglycemia or lowering of blood sugar up to 12 hours post-exercise. So you need to cover that period also with the carb. You're not only trying to load the protein and the muscle recovery, but the carb intake has to continue, and a combination of that up to 12 hours, the sugars can dip. They might even face a mild hypo, even a type 2. It's not only a type 1, even a type 2 from whatever medication they're taking. Another, they're just minute points that I want to, to string the guidelines. Dialysis, like Shubhda mentioned, that you don't need to restrict the protein. So it is in CKD, a diabetic with kidney disease on dialysis, there are newer recommendations where the protein is not decreased. So they're always obviously losing protein. You need to reconsider those, and those recommendations are present now. The thinking has slightly changed from that 0.6 to 0.8 to being almost up to 1 only in a patient with dialysis. So please note that. Some of these things, and to just string it, that the next talk will be on the fat, the duologue. But I just wanted to bring out that please don't consider these macronutrients in isolation. They interact with each other. So a carbohydrate with a protein will blunt a glycemic response. A carbohydrate with the fat combination will also blunt. So it's actually a combination of the foods which you're planning in the daily diet which needs to be taken into consideration. And you can achieve that. That is possible to bring that blunted response with this combination.
Thank you, Shilpa ma'am, and thank you, Shubhada ma'am, for this wonderful session. We move ahead. Yeah.
Our protein pilots, Dr. Carb pilot and Shilpa Joshi ma'am, Shubda, Cyril, and Dr. Kavita Gupta. I request our chairperson to felicitate our carb pilot and protein pilots. I also request our speaker and chairperson to felicitate the chairperson Sonal Modi, because she has a flight, so she will leave. Please join for a group photo. The food pyramid is ready. Audience, do you have any questions on carbs and proteins? Because they are leaving, keeping behind fat only.
Hello.
I just wanted to add what Sonal had said about coconut water. So in fact, we were really curious because that is a point of controversy. When we are talking about coconut water, in fact, out of curiosity, we also did an AGP. So, and that was with my own brother, and I happened to get that AGP results, and fortunately, we didn't see a big spike. It was just below 200 after having, 150 to 200 ml of coconut water. So it can be patient intra variations as well. So it may differ from patient to patient. It also is very important that we need to see the blood sugars. Yes, it can be, I'm very sure it can be in the hospital because, the patient may be on steroids or on other conditions. So definitely it does matter. So again, as everything, even coconut water is going to be always a point of controversy.
In this journey of micronutrients, moving further, our next destination is fats. Are fats the enemy? What is a friendly fat? What does my plate say about fat? To answer all these questions and queries, we have with us Dr. Meenakshi Bajaj and Mrs. Neeti Desai. I think there is no need to introduce them. They are very popular and famous dietitians. I request ma'am to take it ahead.
A very good afternoon to one and all.
grateful to Dr. Sunil Gupta sir, Dr. Kavita Gupta and entire team for the opportunity to be part of this program. And today myself and Niti ma'am will be having a small dialogue on fats. शादी के लड्डू जो खाता है वो भी रोता है और जो नहीं खाता है वो भी रोता है. So is it that we should stop fats or take less fats or more fats as in keto? I think we have Niti ma'am to talk to us a little bit on this.
A very good afternoon to one and all. I would like to thank Dr. Gupta on the outset. Since we are our destination is fats, I am expecting a turbulent flight. So please keep your seat belts tightened. There have been a lot of ups and downs when fats have been considered a part of the nutrition regimen. Right. So why bother about fats in diabetes? That's the common question that is asked because diabetes is all about carbs, as we kind of have been hearing. But we also know that diabetes is associated with 3 to 4-fold increase in the risk of CHD, CVD, and in fact, most diabetics have one or the other lipid abnormalities, as we see in practice. Are we looking at a no-fat diet? No, it is a low-fat diet that we are looking at. And we need to consider both the components, the quantity of fat and the quality of fat. Both are as important. It is not only the quantity that matters. At the same time, we only don't have to get entangled between SFA, MUFA, and PUFA. So our Indian RDAs, in fact, peg fat to be less than 35%. So the total daily caloric intake from fat should be less than 35%, and this includes both invisible and visible fat as well. So here are the recommendations from different agencies, from ICMR, RSSDI, AHA, but as we said, we are looking at around less than 30 to 35% calories coming from fat. And if we look at the NIN guidelines, this translates into around, say, 20, 25, 30 calories of visible fat in our diet, depending on the level of physical activity. So on a very, very simple, laymannish terms, what we need to tell our patients is that you must use half a kilo, half a liter of fat per person per month. That is the simplest message we can give. This is about quantity. Now, Meenakshi, can you take us through the quality of fats?
When we are talking about the quality of fats, obviously we are aware there are the good fats and the bad fats. Why are we saying there are bad fats? Because as we had our previous speakers talking to us, keto diet. Most unfortunately, most of the keto diets land up with animal-based keto diet. And very rarely, or a small sect only takes the plant-based keto diet. Why I'm talking of keto diet here is, the reason being when you consume a lot of animal fat. Animal fat, when I talk of red meat, I talk of dairy, I talk of clarified butter, I talk of egg yolk, all of this are in common contain saturated fat. And we have more and enough evidence as per the AHA presidential commentary guidelines, which recommends 2018, which recommends that saturated fat does increase the LDL cholesterol, which in turn increases the risk of CVD as well as CHD and all-cause mortality. So that's about the bad fats. Obviously, we need to remember about the lard, the tallow, the different types of fats. You have the cow fat, the leaf fat, so many other different forms of animal-based fat. Apart from that, we also have the tropical oils, the palm oil, the palm kernel oil, the coconut oil, which is also a source of saturated fat, which ranges from 71% to as high as 91%. So this has to be borne in mind, which I already mentioned to you, that it raises the LDL cholesterol. That's the bad fats. What are the good fats? The good fats are the majorly the tree nuts. That is the almonds, or it could be the pistachios, or it could be the walnuts. We can also talk of the flax seeds, the mustard seeds, the fenugreek seeds. All these also, they may contain some amount of, a very small quantity, but some amount of good fats. So when we talk of fats, how do we, distribute them in terms of good and bad? One important thing is, one component of fat is the fatty acids, that the saturated mono, poly, and trans fats. The other one is the non-glyceride component. They are the ones which contain the tocotrienols, the phytosterols, the oryzanols. All of them are the ones which have antioxidant, immunonutrient, anti-inflammatory activities, which in turn give it the name good fats. Now we have with us, when we talk to our children or to the younger generation, what do we tell them? हमारे ज़माने में तो ऐसे होता था, हमारे दादाजी ऐसे करते थे, हमारी माताजी ऐसे बोलती थी. So when it comes to fats also, there is a beautiful history, and I'll ask Niti ma'am to illustrate this little history across.
Since the whole session is on the history of nutrients, and Dr. Neglur took us through it so beautifully, so in a very brief version for the fat, we started off 40 years ago where we said that you use fat very sparingly, and in fact the fat should be replaced with carbs. That's what we heard from Dr. Neglur as well. And the fats were replaced with refined carbs. Things didn't work out. Then there was a distinction between healthy and unhealthy fats. The fats were split up. Come down to 2005, there was a cap on the total fat intake now from 20 to 35%, and more was talked about PUFA and MUFA. 2010, the saturated fat content was capped at less than 7% of the total energy requirement. And the latest guidelines are telling us that dietary saturated fat definitely needs to be restricted, and they need to be replaced with PUFA and MUFA. There is some more emphasis again on PUFA. I don't know whether we are going back the full circle, but the jury is still out. So this is a very dynamic and, as I said, a turbulent flight when we are talking about fats. So initially, as I said, PUFA was considered most important. Then they realized that if you have a lot of PUFA, in fact, the total cholesterol goes down, but the HDL also goes down. And in fact, N6-PUFA is atherogenic. It is pro-inflammatory. So then the story came that, in fact, we need to worry about the optimum balance between N6 and N3-PUFA and not only talk about N6-PUFA. And the balance was considered very important. And the ideal ratio is pegged at 5 to 10:1 between N6 and N3. But what we are seeing in the Indian diet is that we are at a ratio of 20:1. So the N6 intake is very high. We need to look at augmenting our N3, omega-3 intake. And omega-3 also has multiple benefits for diabetics, as shown in this slide. But since we are a large country, we know that different types of oils are used in different parts of the country. Mustard oil up in the north, groundnut oil in the west, and sesame and coconut in the south. And here are the different fatty acid compositions of different oils. And as you can see, if at all, it's only the soybean which perhaps meets this N6, N3 ratio, closest 5 to 10:1. But then soybean is not acceptable to a lot of Indians because of the taste. So most of the traditional oils are not close to the NIN recommendations, and to achieve this desirable N6, N3 ratio of less than 10, NIN suggests that we either use a combination of oils or use blended oils. So for example, if one is using any of the groundnut, sesame, or rice bran oil, you need to use along with it either mustard, canola, or soybean to get the ratio right. The other easier trick is to rotate oil. So every time you can ask your patient to, every month that they buy oil or every 2 months, they can buy different oils. That's a simpler way of getting the ratio right. For the non-vegetarians, there is an option include the omega-3 rich fatty fish even twice a week, and you will meet your requirements. These are some of the common fish, Indian fish that we use for consumption, and they can be included on a weekly basis. Krill oil is the newer block on the market. Basically, the EPA and DHA from here is more bioavailable than from the fish. But then we have a lot of strict vegetarians who will refuse to forget fish oil, but even fish oil capsules or supplements. So then these are some of the rich sources of vegetarian omega-3. Beware, but this is alpha-linolenic acid and not EPA or DHA. A better version, vegetarian option, would be the algal oil. We get the capsules for this now, which are basically EPA and not ALA. These would be way, way better. Another common question I'm sure patients must be asking you, is olive oil the answer? Everybody is going and buying 2-liter and 5-liter cans of oil because they think if it's olive oil, they can use any amount. That is not the case. Olive oil has shown multiple benefits for diabetics and for other conditions as well. It is, of course, a healthy oil to use. And what has been seen is that extra virgin olive oil seems to have the most benefits. And this is where we need to know that this can be only used for cold use, like a salad dressing or with a multigrain bread. This cannot be heated because olive oil has a very low smoking point. There are, of course, other drawbacks also. Olive oil is imported, so you're increasing the carbon footprint. It is more expensive. So multiple issues. And in the same breath, I would also like to just mention about avocado. A lot of people are just going ahead and having lots of avocado. We have our simple MUFA-rich fats. We don't need to eat this expensive fruit. If we use the mustard oil, rice bran oil, have nuts in moderation, we're doing the same job. Avocado or olive oil are not the answer to all your health issues or for the diabetic patients. Nuts, excellent source of MUFA, PUFA, but the caveat here is they are extremely high in calories, as you can see them. The issue is the portion control, and as you can see in the chart, for 100 calories, pistachio is your best bet. You can have a lot more, get much fewer calories. Cold versus refined, again, a discussion that is always on. Only if you have kachi ghani ka tel available in your house straight from the ghani and you're going to use it in next 2 weeks, then go ahead with it. But if that kachi ghani is lying on a supermarket shelf for 1 month, 2 months, and it's going to lie in your shelf for 2 months, it's doing you more harm than good because the impurities are there. So that you need to keep in mind. Only a fresh kachi ghani oil has meaning. You talked about good fats, Meenakshi. Can you also run us through the bad boy of the fat?
So a little continuation of what Niti ma'am had to say. She said she had an excellent source with omega-3, omega-6 ratio. But when it comes to the patients with diabetes, we need to be a little worried because it's not very, very glycemic friendly. That's one thing with soy oil. And second thing is, when we talk of this kachi ghani oil, remember that all these cold pressed oils have a very low smoking temperature. And very beautifully, Niti ma'am said that when it comes to the extra virgin oil, which is a cold pressed oil, similarly, when it comes to the kachi ghani oil, is also not a refined oil. So it has a very, very low smoking temperature. So it has to be used similarly the way you use extra virgin olive oil. So when we come to the bad boy, that is the saturated fat. I already mentioned to you, the AHA guidelines very clearly tell us it raises the LDL, the TGL, as well as the lipoprotein A. There is a risk of type 2 DM, thrombogenicity, and cardiovascular risk. And the AHA guidelines very, very clearly tell us that if the patient is at risk, then the saturated fat should go less than 5 to 6%. Otherwise, the patient can consume as high as 10%. Now, when we come to this controversial topic, another controversial topic is coconut oil. We hear that Kerala is consuming a lot of coconut oil. Do we see so much of heart disease there? I think a research has to go specifically with Kerala, but remember that a lot of fish is also used, a lot of red rice is used, and there's a lot of physical activity. So basically the tradition, the pattern remains, but recommendations are based on a lot of scientific evidence wherein we have found that based on the systemic review, out of the 7 trials done, they found that all the 7 trials did show that there was a raise in the LDL cholesterol, that is 0.1. Out of them, 6 were statistically significant. The reason being that it has a very, very high saturated fatty acid content. So you cannot negate that part of it. Another important thing which I would want to say is 15 years ago, coconut oil was known as embarrassment of riches. Obviously, it has a big profile of fatty acids from lauric acid and stearic, palmitic, all of them. But 50% of it is lauric acid, and this 50% lauric acid does increase the LDL, also gives a small little increase in the HDL cholesterol. Always remember one more thing with coconut oil is it has a very high smoking temperature. Does that mean it can be used for frying? It can be used for frying, but remember, the source of saturated fat is not going to do any good to us. When it comes to rice bran oil, a little mention on that is 15% of absorption comes down. And in baking, if you replace all your butter, margarine, edible hydrogenated fat with rice bran oil, the absorption is much lower. So the AHA does say that a big no when it comes to coconut oil. And I cannot, end this session of fats without telling every paratha is looking for the ghee on it. So we have Niti ma'am to tell us something about the ghee on it.
On ghee, we can almost have a session, but for the want of time, I'm going to say that ghee should be used in moderation. We can use 1 teaspoon of ghee as part of your saturated fatty acid allowance, but you do not need to use ghee as the only cooking medium or start having 2 tablespoons of ghee first thing in the morning. We do not have any evidence for that. At the moment, the short chain fatty acids of ghee may behave a little differently, but we do not have enough evidence to advocate its use in huge amounts. Yeah, so even the AHA presidential advisory says that the differences in the different individual fatty acids are small and should not affect the dietary recommendations for saturated fat intake. The other bad boy.
Yeah, when it comes to trans fats, I think it's been all over. We've been hearing about trans fats. We need to remember that they are also unsaturated fatty acids, either coming from PUFA or coming from MUFA. But only little thing is they have 1 double bond at the trans configuration, and 2 types of fatty acids are here. One is the ruminant fats, and then is the industrial fats, whether it's ruminant, whether it's industrial. All this while ago, I think till 2017, the fact known was you can use ruminant fats, trans fats, they wouldn't do as much harm. No, they do equal harm. That's the 2018 guidelines very clearly tell us that whether it's the industrial fat or the ruminant fat coming from dairy and red meat, you find that they do raise the LDL cholesterol, the TGL, the lipoproteins, and are at risk of CVD and all-cause mortality. So when it comes to trans fats, we know that an increase of 2% of trans fat does increase the risk of CHD by 23%. And whether it's the Nurses' Health Study, ATBC study, Uramic study, transfer study, all these studies do tell us the risk of CHD, type 2 DM, breast cancer, colon cancer, most versus if the pregnant woman is going to consume the shortenings, the baked foods, the margarines, the commercially processed foods, this is going to cross the placenta and going to increase the length of the pregnancy. And in children, it increases asthma and eczema. According to FSSAI, Government of India, trans fat, rewind heart attack is the logo which has been promoted to tell by 2022, we are going to have less than 2% of trans fats in the processed foods. So what is butter versus margarine? I think we had a very lucid talk by Negalur sir talking to us about butter and margarine. But remember, whether it's butter or margarine, both contain saturated fat. Only few types of margarine, though it is replacing vegetable oils, people forget that it also contains the trans fats, which has never been mentioned previously when they had started promoting margarine against butter. Yes, there are few margarine available, which are prepared purely from vegetable oil and not hydrogenated. So whether it is butter or margarine, remember to identify the right sort of margarine and the presence of edible hydrogenic fat and then choose on it. So we have, I think the last little bit will be, okay. So we'll just, because of paucity of time, we'll just go with the good practice guidelines. Use an antioxidant fortified oil. Also, if you can choose on vitamin D fortified oil, nothing like it. Deep fry at the right temperature. Choose refined oils because they have a higher smoking temperature when compared to those which have a low smoking temperature, which are the kachigani oils. Do not use the oil for refrying. If you're going to use the refried oil, you're going to increase the source of trans fats. Clean the fryer after every use. Do not use iron pans, use steel pans. Filter the oil after frying. The longer period of oil you're frying or you're heating, the higher the temperature it is raising, the trans fats are going to increase. And don't think when the pan is having very little used oil, add some fresh oil, you're going to worsen the state of oil. RUCO is another beautiful movement started by FSSAI Government of India, according to which reused oil, which contains more than 25 total polar compounds, which once again increase CHD mortality and trans fats, are being given away to the industry for biodiesel formation. And we have the last key messages. Because of paucity of time, we have to rush through. Minimal intake of visible fats, oils, butter, ghee, margarine for Indian adults range between 20 to 40 grams. 25 grams come from visible fat.
We do not need to use single vegetable oil, use a combination. Non-vegetarians should have the fatty fish in their diet, not fried though. Include nuts, include seeds to get the good fats in your diet, and of course avoid trans fats such as vanaspati or bakery items such as khari and butter biscuits, which are just loaded with trans fats. Thank you for your time and your patience.
Thank you so much. Thank you, Dr. Meenakshi Bajaj and Mrs. Niti Desai for this wonderful session. As you rightly said, quality and quantity of fats is very important. Coconut oil cannot be used as it increases your LDL levels. And olive oil, what you said is very correct. I also agree with you. Its smoking point is very low, so that cannot be used for frying. Trans fats are to be considered. And attention should be given. One should read the label, how much trans fats are present in that fried product. Then use of antioxidant fortified oil is good, and use of kachi ghani oil is also good, but you need to see that it should be, pure, and it should be hygienic, I can say. And its shelf life is not very high, so it should be consumed during that period only. So thank you for this wonderful session, and I declare the session is open for question answers. If you have any, please quickly you can ask. Quickly, if you have. Shilpa ma'am is there. More questions? Students? So I declare the session is over. Thank you so much, ma'am.
Yeah, I request our chairperson to felicitate our pilots, and I request our organizing secretary, Dr. Kavita Gupta ma'am, to join on the dais. Thank you, pilot, Mrs. Niti Desai and Dr. Meenakshi Bajaj for giving excellent derivation on fats, oils. I request Dr. Kavita Gupta to felicitate our navigator, Professor Nilima Joshi ma'am and Dr. Kavita Vikshi ma'am. So over to Sadap ma'am for next session.
Session is the Sexology Symposia. I would like to invite our honorary chairpersons, Dr. Manohar Sada sir, Dr. Nirmal Jaiswal sir on the dais, chairing the session, and the pilot for this session is Dr. Deepak Jumani sir. Can you all please come on the stage for the session?
Because of unavailability of our chairperson, I request Chatterjee sir to please chair the session. Very interesting session going to delivered by Dr. Deepak Jumani. Dr. Chatterjee sir is well-known physician diabetologist from the city of Gondia. Over to you, sir.
Dr. Deepak Jumani needs no introduction, and it's quite fascinating to hear his session. And without any delay, I request Dr. Jumani to start his.
Thank you, sir. अच्छा पल जरूर आता है, men do get erections, पर कम वक्त पे नहीं आता. वो पल भी आया तो कुछ पल के लिए. सोचा उस पल को रोकूं कुछ और पल के लिए, पर वो पल न रुका एक और पल के लिए. This is what happens in many patients who come to us with erectile dysfunction. I thank Sunil Gupta, Kavita ma'am, Shlok Swar, and all the organizing team of Hello Diabetes for inviting me here and giving me an opportunity to share my thoughts, views, concepts, and passion. With pranams to God and thanks to my teachers Dr. O.P. Kapoor, Prakash Kothari, and Shashank Joshi, whom I beseech to bless me always. I have no conflict of interest, but I have certain disclosures. I'm not from Congress, BJP, Shiv Sena, or Aam Aadmi Party. I'm not a follower of Asharam Bapu, Digvijay Singh, Shashi Tharoor, or Radhe Ma. I'm not married to Indrani Mukherjee. I'm an Indian Medical Association Knight, and I'm passionate to teach you all to treat erectile dysfunctions. And I'm not involved in ED politics. I'm really not involved in this. Mitro, look, our Prime Minister's hands are down because he said, I have offered you GST, I had no other choice. Then he told me, Deepak, look, my hands are up. And I said, I'll also my GST. And my GST to all of you is great sex therapy. Well, friends, Masters and Johnson and Henry Kaplan formed this male sexual response, which begins with the desire, leads to erections, ejaculation, and resolution. Same in females, but in females there are multiple orgasms, the rest remain the same. So there are 4 cardinal events in both male and female, which begin with the desire, leads to erection, penetration, and orgasm. So if you want to know a sexual functions, these are the questions we need to ask, whether he has a desire, low desire, high desire, erections, no erections, less erections, penetration issues, orgasmic issues. We'll discuss about direct. Now this is our first large data of 56,000 patients in KEM, and still it's ongoing, the age of 31 to 72 years. Men had erectile dysfunction, early ejaculation, low sexual desire, and women had low desire, and depression was seen in every woman whom we saw. The prevalence in India and China is huge. So I call it Chindia are the diabetes capital of the world. And erectile dysfunction being the commonest complications of type 2 diabetes in men, so Chindia are the erectile dysfunction capital of the world. Both type 1 and type 2 are associated with increased risk of erectile dysfunction. And in MASH male aging study, diabetics showed 3 times probability of having erectile dysfunction when compared to men without diabetes. But the big problem is that any patient with ED gets affected individually. Also, his partner is affected, and there is definitely a dent in the relationships. So much so that impotence has been the main cause of divorces in India. 1 out of every 3 failed marriages is due to sexual dysfunctions. Let me give you a deeper perspective. Why we should be worried about erectile dysfunctions? Why it is called a tip of an iceberg? The tip of a man, how does it cause havoc in his life? Or how it is serious? Is it a panic? Yes, it is, because it's a red signal for impending diseases or disasters. When we look at the etiology of erectile dysfunction, it is multifactorial. It is inflammation, mechanical issues, psychogenic issues, vascular issues, traumatic, endocrine problems, neurological problems, chemicals, extra factors, aging, etc. All these can cause erectile dysfunctions. And we know all diabetic men are hypogonad, they have testosterone deficiency. But what is more alarming? Are these adults only getting erectile dysfunctions today? Only diabetic, only having metabolic syndrome, only having low testosterone, aging, etc.? No. The worst issue today is that there is a rise in erectile dysfunction in younger patients who do not have diabetes, who do not have hormonal issues, who do not have any hypertension or any neurological issues. And what is the main reason for this? Why erectile dysfunction is the tip of an iceberg? It's all because of porn. Is porn addiction a disease, disaster, choice, medication, or societal need? It's something like a chronic brain disease. It's something like that. Though it is not a brain disease, but it is. It's defined as chronic relapsing brain affect that is characterized by compulsive watching sexually explicit material and use, despite we know it has got harmful consequences. But today, neuroimaging studies have revealed that porn-addicted individuals have structural and functional changes in certain areas of the brain that are critical for judgment, decision making, learning, memory, and behavioral. Now, so much is the impact that India is the 5th highest consumer of porn today, and it had increased to more than 300% during lockdown. And what is more alarming is 15 to 17-year-olds have multiple hardcore experiences which they have. And the largest consumers of pornography in India are between 12 and 17-year-old age. So that is and there is cyberbullying, which is so common, and India ranks 3rd amongst the 25 countries with 53% children between 8 and 17 saying they have been bullied online. Is pornography causing sexual dysfunctions? Yes, it is, because there are a lot of side effects. They don't find, once they watch certain porn, they don't find watching porn again to be more exciting. They want something different. And when they watch porn, they masturbate, they decrease their penile sensitivity. And when they have to ejaculate, it's sometimes very delayed and they don't have orgasms. And sometimes they feel porn is more exciting than their partner. They fantasize about porn to maintain erections, and they don't get morning erections, and they sometimes later they don't even get erections. So there are 4 types of sexual dysfunctions. Amongst them, erectile dysfunction is the very, very common dysfunction in men who watch porn. So it's called porn-induced erectile dysfunctions. Now we all know addiction is all about dopamine, which the brain gets activated and which is a reward center. So there is increased dopamine in the brain when you watch a lot of porn. So pornography is now, when you look at a porn, you will find they're having sex everywhere, in the gardens, in the hills, on the bathroom, in the kitchen platform, which is not true. This is what they watch, and they at any location, it could be in the fields, it could be in the sea, or it could be anywhere. But this is not the ground reality actually. So many young men watch before. These children are watching before they get married or before they have sexual relationship with anybody or any sexual experience. This becomes highly addictive because of dopamine. Now, excessive porn use can make it very difficult or even impossible to achieve or maintain erection in a real life sexual situations. which is not there what they watch in porn, the aggression of all that. So following various studies, now researchers comment that many men having their first sexual experiences outside the real life sexual relationships, their later sexual interactions do not conform to their expectations which they got when they watched porn. So dopamine is right in many good things, but like, eating food or watching something nice. So there is a spike in this thing. But when you get addicted to it, what happens is you look for novelty, and there is more and more and more and more of dopamine being released after every click of the mouse. So continuously clicking mouse, watching various types of exposures of explicit sexual material, this this creates a fog in the dopamine, fog of dopamine in the brain. And when you look at dopamine, you have, when you watch sunset or when you get a friend's email, but having or watching sexual explicit material increases dopamine to be the maximum. So much so that when you eat good food, there is definitely a rise in dopamine, but see the rise in watching new sex or new different type of porn, etc., is more than 200%. And this is all because of dopamine. Now, what dopamine does it? Dopamine neurons are very few, and they have a big impact on your creative, productive functions. Dopamine is nothing but wanting, it's craving, it's anticipating something good. It provides the motivational push. That's why they watch it again and again. Dopamine says only one thing: I have to have it, whatever it is. Now, once you have fog of dopamine in you, there is another transcription factor called delta phos B, which is the molecular switch of reward system. So what happens is this delta phos B remains in your blood for a long time after watching a lot of porn, and it also modulates your genes. It regulates genes to control the region of the brain like nucleus accumbens and amygdala. So dopamine surges, forms delta phos B accumulation, and rewires your brain to want it. You need it again and again. So the bottom line is excessive chronic consumption makes you binge, and there is delta phos accumulation, which cravings for more longing, and continuous consumption leads to permanent or maybe various brain damages, which I would. So brain structure and functional connectivity is associated with pornography. You find your gray matter being reduced, in many sections of the brain, particularly in the frontal lobe. So porn damages your brain, it changes and shrinks certain areas of the brain, and also reduces the function of certain areas of it. Causes so much damage that it deactivates your frontal lobe, which is the captain of your ship, which is the area of the brain for planning, thinking, organizing, judgment, impulse control. It's like your brain is working without a captain. And not only the frontal lobe, the temporal lobe of the brain, we have the reward center, which gets fired out. The dopamine receptors become less. Your brain becomes tolerant to it. Look at this normal brain, which has so many dopamine receptors. But once you get desensitized for watching continuous, dopamine receptors become less. So the porn affects your brain. By researchers have found that it is quite addicting, like other addictions. And like addictions, you need to more and more you want it. Over time, excessive levels of these chemicals, the porn consumers leads to develop tolerance. And just like an addict, regular consumers will end up turning to porn more often, seeking for more and more pleasure. They want to search, how do I get more pleasure? And all. But the bottom line is, the good news is that these porn pathways aren't reinforced. Then they eventually get disappeared, like any addictions. But one must remember that erectile dysfunction due to porn is not vasculogenic, not hormonogenic, not psychogenic, not neurological, not due to any trauma. It is definitely affecting the brain, and PDE5 inhibitors like Viagra do not work. The tragedy is, once they get these youngsters, they go to the chemist and...
Jumani sir, excuse me, just we have to pause for a second. There is some link failure. That's all. dysfunction.
So they go to the chemist and buy Viagra and try to increase the blood flow, which is wrong. And so they get accustomed to using more and more PD-5 inhibitors, which again cause harm to them in their personal life. So this was all about the new aspect, new type of porn-induced erectile dysfunction, which is a very, very sad thing. Younger generations are suffering for it. The best thing is there is a cure for this. That normal endothelium gets dysfunctional in patients who have got vasculogenic or neurogenic erectile dysfunction. Because when we talk about diabetes, due to advanced glycated end product and oxidative stress, ultimately leads to cavernosal endothelial dysfunction and erectile dysfunction. So in patients who are diabetic, there is definitely a link between endothelium, which is the brain of the vascular system. The whole vascular system is covered, is lined by the endothelium, it gets affected. When we look at the diabetic corpora cavernosa tissue, when there is glucose overload, there is increased advanced glycated end products, increased reactive oxygen species. They do a lot of changes in the endothelium and reduce the production of nitric oxide, which is the main chemical signaling molecule to initiate erections. And there is apoptosis, which means testicular, the damage to the tissues. And in these patients, we also find there is reduction in testosterone, and all these ultimately lead to erectile failure. The new thing what we have learned today is COVID. COVID again is an endothelial disease, because in COVID, during COVID, they did a lot of histopathological and immunohistochemical studies in the human penis, and they found that there was coronavirus in the penile vasculature. It's not a sexually transmitting disease, but they found this virus in it. And there is a bidirectional relationship between diabetics and this thing, because SARS receptor ACE enzyme 2 is expressed in the human pancreatic islet beta cells and is upregulated by inflammatory status of the body, which they are in when they have COVID. So diabetes is both a risk factor and a condition worsened by SARS. Now, we are all embarrassed to ask our patients, कि तुमको ये problem है क्या? So how do we ask? We don't want to ask, but we want to know something without asking. Can we come to know? Yes. Yes. There are various methods where you can easily diagnose erectile dysfunction. One is do a CBC of your patients, which you normally do, and look at the platelet and lymphocyte ratio. If the platelet and lymphocyte ratio is more than 104, your patient surely has erectile dysfunction. You do just take a CBC and do a mental calculation. Platelet is 3 lakhs, this is this much, and this is more than 104. Yes, then you talk to your patients that, do you have this problem? Your patients will tell you, Sai Baba, how do you know this? I have never spoken to you about it. So this is another way you can diagnose. And very important thing is, novel predictive risk factor of erectile dysfunction is HSCRP. We know HSCRP we do in cardiovascular diseases. We do it even in COVID, we did it. So if this is also raised, these patients could be having. Now, why it is a tip of an iceberg in adults? Because we know that it is the earliest marker of myocardial ischemia. So if your patient has ED today, has been getting ED today, in the next 3 to 5 years, he will definitely land up with myocardial issues. It could be angina, it could be myocardial infarction. If you still wait, he can even get stroke or claudication, etc. We all know, because of the artery size of hypothesis, these smallest arteries are the penile arteries, and they get affected first with atherosclerosis. So if you have erectile dysfunction, it is nothing but subclinical cardiovascular disease, because even when you look at the symptoms or the risk factors of cardiovascular disease, till the event which he has, we ask our patients, so throughout the history they had erectile dysfunctions. And we know that the onset of erectile dysfunction and the presence of coronary artery disease, the duration is around 2 years to 3 years. So you have 2 to 3 years time, If you ask your patients before they have any angina or before they went for any treatment, Do you have erectile dysfunction or do you have problems in making love? Just ask them simple questions. At the age of 30, in patients whose family having a family history of myocardial infarction or diabetes or hypertension, they will really bless you because you can change their lifestyle. So there is compelling evidence that erectile dysfunction is a risk factor for coronary artery. This is another thing. Now, one more important thing is more than 1 lakh, 1.5 lakh patients were studied who came to us late. Now, what happened when they came to us late? The first line of therapy, which is the pharmacotherapy for erectile dysfunction, did not work. So they needed surgery or the second line of treatment which they had. A beautiful study, 1 lakh patients in Taiwan they studied. They found this 1 lakh patients with diabetes had erectile dysfunction and they landed up with dementia. Now, do we want our patients to become dementic? No, we should ask our patients that do you have problems in making love? And an Indian study by Jipmer, most of the diabetics who are fed up of controlling their glucose, the dietitians tell them, ye mat khao, wo mat khao. And every time I listen to a lecture on diet, I always get confused. Ye nahi khao, wo nahi khao, what to eat, ye bhi kha sakta hai, wo bhi blend karke khao, ek mahina ye oil khao, dusra mahina wo. Well, how do we run our show? It's very difficult. So these patients who committed suicide were on normal drugs and they started getting suicidal thoughts. So this is what is the tip of an iceberg. How erectile dysfunction creates havoc in a man's life. But can we prevent this? Do we have a vaccine? No. Is pancreas transplant available? Not available. Is gene therapy therapeutic? No. So what is the process? How do we go about it? So it's not just erectile dysfunction. So you go to tackle 4 things: erectile dysfunction, diabetes, cardiovascular disease, and depression. All these 4 things have to be tackled. So it's become the main point of sexual health in men, which is to be tackled. So how do we treat erectile dysfunctions? We have 3 lines of treatment: oral drugs, injections of papaverine, vacuum therapy, intraurethral prostaglandins. And if these fail, we send our patients to the surgeons who put implants or anastomotic surgery. But what is more alarming is that you need to counsel and advise your patient on lifestyle measures. So these 2 are the mainstay of treatment for any sexual dysfunction, more for erectile. We have 4 PDE5 inhibitors: sildenafil, vardenafil, tadalafil. All have certain side effects like flushing, headache, nasal congestions, and we can't give it to patients who are on nitrates or who have hypotension or certain anemias and leukemias. But the best for every diabetic today is put them on low dose of tadalafil, 5 mg, 2.5 mg, or even 10 mg for at least 12 weeks. Even if he has HbA1c of any amount, maybe 9, 10, 11, he has dyslipidemia, he has prostatic hypertrophy or hypertension, you can give it to him. My friend Dr. Jyoti, they put these patients on insulin pump and he found 83% improvement in their sexual functions. Metformin is a gold standard. It is now known to improve the endothelium, which is the cause of endothelial dysfunctions. SGLT2 inhibitors, because of its class effect, weight loss, antioxidant, anti-hypertensive, beautiful. So if you give your patient SGLT2 inhibitors and metformin, you are removing all the causes of vasculogenic erectile dysfunction. These patients start getting normal erections and they don't need PDE5 inhibitors like sildenafil or tadalafil, etc. Buried penis syndrome, very common. Just treat them with sesame seed oil, L-arginine and metformin, it gets cured. Now let me give you the last part of my slides, which are modern perspectives today. We have novel treatments like low intensity extracorporeal shockwave therapy, PRP, but we lack Indian data. We do not have good data or robust data to say that there are so many novel molecular targets of this. Only the stem cells, PRPs, gene therapies have shown good promise. Others are all in the pipeline. Now, if we don't have medicines to cure, do we have certain diets or do we have certain herbs? Yes, we have. We have fenugreek, which can be given to our patient, fenugreek in saponized form, L-arginine, which are very safe, compliant with their bodies, and they can be very helpful in improving their desire and also the erections. What is something new today? We have, now when we look at giving PDE5 inhibitors, we have to be very cautious. We can't give it to patients who are on nitrates. Because if you give anybody nitrates who's on nitrates and give them PDE5 inhibitors, their blood pressure may drop. This is the fear which we all have. So to recent study which we just came to know that more than 2.5 lakh patients were studied, and they were given PD5 inhibitors to patients who were taking nitrates. And this study was more than 8 years. So they wanted to see the trend in patients with co-prescriptions of nitrates and PD5 inhibitors and to see whether there is any cardiovascular outcome. So what they found, between 2000 and 2018, 2.5 lakh patients with ischemic heart disease were identified. Of these, all of them were given PD5 inhibitors. Okay. So what they found, there was no statistically significant association found between co-prescription of nitrates and PD5 inhibitors and the risk for either composite outcomes or first or second was. So they concluded that PD5 inhibitors increased the sale of PD5, the consumption was increased to more than 20-fold in these patients and who were taking nitrates. So a statistically significant association between concomitant use of these medications and cardiovascular adverse events could not be identified. Now, when you, on one side, we say nitrates should not be given, and we have this beautiful study which says that nothing happened to these patients. So to avoid all this confusion, we have a beautiful new drug called Avanafil, which is now in the market, available in the dose of 100 and 200 milligram. The onset of action is 15 minutes and the half-life is just 5 hours. It gets washed out from your body within 5 hours. So if your patient is on nitrates, you can ask your patient to skip nitrates on that day. And if he wants to have good enough sex, take Avanafil, which also will get washed out from your body within 5 hours. And the next day, again, he can start nitrates on his own. So this is very good. It has got least side effects and it has been studied in patients who are diabetics. Very beautiful. All diabetics who took Avanafil could have sex 3 times in 6 hours, which was very good. So the point to ponder here is ED, which is the tip of an iceberg, a symptom or a disease? If you think it is a symptom, give them pharmacotherapy. If you think it's a disease, we need to cure it because every disease needs to be cured. So how do we manage it? Currently, we do not have anything to cure erectile dysfunction. Nothing at all. Absolutely nothing. So how do we manage the only treatment which we have which can cure is stem cell therapy. They studied 15 million umbilical cord cells were injected in the cavernous tissue of 7 diabetics who did not respond to medicines, who did not want surgery, and 6 out of 7 men started getting morning erections and they were having very good sex life. So this is what is going to be a promise, but we need a good data on it. Another factor is elevated pigment epithelium derived factor was present in diabetics who had erectile. Now, if this factor was blocked, so the lessons learned from this study that if this factor was blocked, the endothelium became normal. And when the endothelium becomes normal, your patient is cured of erectile dysfunction. Now, is endothelial dysfunction reversible? Yes. With statins, ACE inhibitors, antioxidants, L-arginine, estrogen therapy, they found improvement in the endothelial functions. My late Dr. R.D. Lele, who passed away yesterday, has given us so many strategies to improve our endothelial functions. So endothelium can be restored. The dysfunction of endothelium can be made functional. So we can foresee a cure for erectile dysfunction also. Because we know that endothelium-derived nitric oxide is the anti-atherosclerotic and anti-thrombotic molecule. We know all about this. So if we have adequate amount of nitric oxide in our body, which reduces as we age, we can have a definitely good endothelium. The science behind nitric oxide is that it dilates all the blood vessels of the vital organs, including the penis, and it also reduces as we age. So we need to give to our patients something which produces nitric oxide in the body and which we have in the form of L-arginine, which is available to all us. So this is one thing which we need to understand, that L-arginine is an amino acid donor or a nitric oxide donor, which we all need as we age because nitric oxide keeps on reducing as we grow. So we need to supplement. Another beautiful Swedish study says that if you are exposed to blue light, they studied with rats, and they found that these rats, when they were exposed to blue light, in 37 seconds, they got erections. In just 37 seconds. So my advice to all of you is, just in your clinics, please have blue lights, so your patients will be happy and you also will be happy. Nanotechnology, the new thing, smaller particles are injected in the intracavernous tissue in the form of gel or hydrogels or encapsulated. They have shown to be very promising results. So my take-home message is to all of you. In this world of email, we are all in a digital world, email, e-tickets, e-paper, e-recharge, e-transfer, and e-governance. Let's not forget Ishwar, who makes everything easy for us, for everyone, every day. E, the letter E is the most common eminent letter of our English alphabet. Men and women don't exist without E. Bread and butter cannot be found without E. E is the beginning of existence and the end of all trouble. It's not at all present in war. It is present twice in peace. It's once in hell, but twice in heaven. E is represented by emotions. It could be found in all emotional relations like mother, father, brother, sister, wife, friends, and E in them. So without E, we don't have love, we don't have life, we don't have wife. E also represents efforts and energy which we all need to do. And hence, to become better from best, double E is needed. So for arousal, you need to see properly, hear, smell, or taste, as ear, eyes, nose, and tongue are incomplete without E. Hence, go with E without ego, which also, but what diabetics need today for good enough sex, which also has E, could it be without erectile dysfunction? All they need is education. So we need to educate all our diabetic patients, which is very important. Lifestyle, friends, you may be Hindu, Muslim, Sikh, whatever, but make lifestyle as your first religion. If you do not follow lifestyle, friends, I cannot say what can happen to you. Anything can happen to you. Because two-time Nobel Prize winner Dr. Linus Pauling, when he received his Nobel Prize second time, he implored the whole world that he said nearly all diseases can be traced to a nutritional deficiency. So why look for procedures? Why look for medications? Why not train our own bodies with nutrition and make it better? So today we have got so many things to give to our patients for erectile dysfunction that this can be managed. But what we need to give to our patients and advise to our patients is realistic expectations. You need to understand that women need, the language of love which women understand is nothing but communication and romance. But men only want sex, which they don't have. My last two slides. Friends, understand. Love is a flow. It's creative, and that is why it flows and brings contentment. You may not get all that contentment with sex, but you will get contentment with love. So this contentment is much more deeper and valuable than the contentment after sex. One who knows that contentment will never look for any substitute, just like a person who acquires jewels will never seek for pebbles or stones or anything else. Children should be taught to love from infancy. The myth is that teaching of love will lead the child into the world of sex. This fear is absolutely groundless because our experience tells us the more love grows in a person, the more sex energy is transformed into good sex and is shared. The less love-filled a person, the more sex-minded he becomes. He rapes, he does all the assaults. More hatred a person has, the more jealousy, competitiveness, worry, and unhappiness will be there in his life. We all have experienced all these things. So love your partners unconditionally. You are for life together. And you must respect your partner. You have issues, men have issues. They don't take treatment. They deprive their partners of all the rights which she has. She is not having any problem. You are having. Get yourself treated. It's important for us because feminism needs to be adored, admired, trusted, and respected. Look at Mahabharata, look at Ramayana. What happened? It's all because of feminism wasn't respected or trusted. If any man does not admire, adore, respect, or trust feminism, I pray to God that he should get permanent, incurable erectile dysfunction. That is what. So friends, if you have patients who have got erectile dysfunctions, don't send them to quacks. वो सिर्फ पुंगी बजाएगा, पैसा ले लेगा, he will do nothing. Then you treat it or send him to good sexologists, he will see that he gets good erections. This is my book, Sex Has No Expiry Date. My last slide is, friends, ED is surely a tip of an iceberg. It's endothelial dysfunction and also emotional dysfunction. Early diagnosis can prevent early death. Low-dose PDE5 inhibitors, statins, regenerative therapies, lifestyle modifications are a promise to cure ED, for sure. So, erectile dysfunction is a erectile dysfunction. Thank you all for your love.
It's a wonderful deliberation. It was scientific, it was spiritual, it was philosophical, and I think there is no question for such a extensive and a very, very good talk. I'm congratulating Dr. Deepak Jumani for a wonderful talk and the last the topic of this extravaganza of Dr. Sunil. Thank you.
Any questions, audience?
Any question?
Wonderful talk, sir. Thank you for coming to Nagpur. I think last conference was there. My question is that many times I'm practicing sexual medicine since 2 or 3 years. And many of the patients, they come to us, they have not enjoyed their sex for 5 years or some 10 years also they come to us. And they won't come to us, we give them PD-5 inhibitor, arginine sachet. And if they don't respond to that, they don't come to second time to us. And when I see in my OPD, chances of re-entering in my OPDs are only 5 or 10% they revisit to us. So I want your experience on this. Also, second questions regarding the newer modalities like P-shock and shockwave therapy. Many of the doctor marketing it's a regenerative therapy, and they are the permanent solutions. So are you using it in your clinical practice? I answer from you. Thank you, sir.
I'll answer your first question, which is very important. The studies show that 30 to 40% patients who take PD-5 inhibitors do not respond. That's a myth. Why they don't respond? If at all you want to give your patient sildenafil, first look whether he has got any contraindications. Is he on nitrates? Is he having hypotension? Is he having anemias or leukemias or any other complications or contraindications to nitrate? Look at that first. Then when you have to give him sildenafil for getting good erections and having good enough sex, see that you don't give him in a low dose. If his weight is around 70, 80 kilos, give him at least 100 milligram of sildenafil. And then tell him that you have to take this prior to your dinner if you are planning to have sex after dinner. At least an hour and a half or 2 hours prior to dinner. And after taking the tablet of 100 mg sildenafil, ask him not to watch Astha channel or Sanskar channel or read Bhagavad Gita or Hanuman Chalisa. He needs to think erotic. He needs to stimulate himself for the 1.5 hours before dinner. And when he is having dinner, ask him to have very light dinner. Because we know post heavy dinners for the next few hours, 5 to 6 hours, most of the body's blood gets collected on the stomach and intestines to digest the food, which is a must. And in doing so, his private parts are deprived of the optimum blood which he needs to get a desired erections. Okay, and if he has not had sex for 6 months to 1 year, tell him not to jump in on day 1 of taking sildenafil and have sex. Ask him to sleep with the partner, do all the foreplay, don't have penetrative sex even if you get erections. Feel the difference, experience the change for 1, 2, 3 days. These 3 days of he feeling the difference and experience the changing will get him confidence which he needs. So tell him to have sex on the 4th day. Or 5th day perhaps, that is important. This neither the chemist tells us, nor the diabetologist tells us, nor so many GPs who prescribe PD-5 inhibitors don't tell us. So this is what it is. Some patients who do not respond, they take 5 minutes before going to bed with 5 minutes, or they take it after heavy meal and alcohol, not to get it. Or they don't stimulate themselves. They are on the mobile, or they are on watching television, or they have something else in their mind. So these are the reasons why they don't respond to them. Explain to them these 5, 6 things which are required. You need to counsel them for at least 10 minutes, then prescribe. Then the non-responders will also start responding to this. And your second question about novel therapies. See, novel therapies are there. The machine for extracorporeal shockwave therapy costs around 25 lakhs. And we need to charge our patients at least 50,000 to 1 lakh for one treatment, which I don't think so it's ethically correct for me to do that. So I have not used it. and I've studied very well about these things, that they are effective only in mild to moderate erectile dysfunction. And this mild to moderate erectile dysfunction can be cured with medications, pharmacotherapy. So why should I give them this thing? And P short, we still need to learn more about it. I fully agree. Regenerative medicine is the buzzword. It is the need of the hour because our body is composed of cells, not drugs. It is the cells only which can make us all right. Our skin keeps on changing every month. We don't even realize it. So our own cells will definitely going to produce better cells, but we still need more science. Even the Nobel laureate Shania Yamanaki, he used pluripotent cells, he's induced pluripotent cells and has proven that any organ can be made in the laboratory or in the body can be changed. Even the damaged liver, damaged pancreas can be changed. But we still need to have robust data on that. So this is what is my take. I have not tried PRP, nor have I tried this extracorporeal shockwave therapy. I refer them. If they want, they can go it. But I don't do it in my practice. I believe in counseling, lifestyle measures, and pharmacotherapy if required. If required.
So,
Thank you, Dr. Giovanni.
so I request chairperson to felicitate Dr. Jumani sir. I request organizing chairperson Dr. Sunil Gupta sir, organizing secretary Dr. Kavita Gupta ma'am, please join in the felicitation. I also request conference ATC, Air Traffic Controller, Dr. Shlok Gupta to join because after this felicitation, there will be a vote of thanks. Please join on the dais. Shlok is coming. Now I request organizing secretary Dr. Kavita Gupta ma'am to give a vote of thanks. And yes.
We have some formalities which is to be done by Kavita ma'am. Madam, you can just declare a few names.
We wanted to felicitate the efforts of a few people. I think we missed out last night, especially now the reporter. We would like to felicitate Dr. Sadaf Qazi ma'am. I think that comes to which are left and whom we can give. Sorry. Sorry, sir. Ginger. Sir. We're just thinking. Yes. So thank you. Yes, so we'll have a nice concluding remark from our esteemed judge. Yes, teacher. He was a judge, of course, for HDA 2020 flight.
Thank you for giving me this honor. The valediction. Let me appreciate that this is one of the most well organized, to say, conference, Hello Diabetes, Epidemia, which I have witnessed. I had a fortune of getting associated right from the type of organization. Gupta is full of energy. Kavita is complimenting him. His energy reminds me of a champagne bottle. The moment you open the bottle, everything spurts out. You ask him, and before our question or suggestion is There he will start answering everything and he is ready with all the answers. And he could assemble so great academicians all throughout the world on this platform, which is really commendable job. This is I will describe this conference as a very fulfilling conference. All the lectures, all the CMEs, all the presentations, everybody who presented appeared that they have worked on their topic very well. They were experienced and they wanted to give not only the lecture, but they wanted to give themselves to the audience. And this August audience gathered here also was very receptive and interactive. So the anchors who have done their job so well, and the screen, the electronic screen is such a high quality that everything was depicted precisely, perfectly. Dr. Gupta and Kavita have seen that everyone's ego is maintained, nobody is hurt, and right from food, cultural activity, and the lectures and interactions, they have done a great job. And it is not only he who is responsible, the whole team of Hello Diabetes and all the people like us. And most important element of your conference, the audience, the gathering, the August assembly of all these people who have come from all over this part of the country and from all over the country and from outside the country, who have जिन्होंने आपके कॉन्फ्रेंस को 4 चांद लगाए. I will describe this as a very informative, instructive, illustrious and fulfilling conference. I congratulate you, everyone, for this conference. So thank you for giving me an opportunity to speak.
Thank you very much, sir. Deepak Jumani wants to say.
I have been very fortunate to be with Sunil for almost all his conferences here. Sex is always here, but the talk is always last. That's very true, and that's what's rightly done in this. If I was to bring down the rainbow from the sky, I would do so. And I would write Dr. Sunil Gupta on it and place it back in the sky. I don't know how to reciprocate the honor which he has given me to be a part of this family of Hello Diabetes. But all I can say, Sunil, is that seasons may come, seasons may go. Everything fades with time, this all of us know. But one thing which freshly blossoms, as fresh as dew, is love, respect, and affections for you, brother.
So nice of you.
Thank you very much. I'm really indebted and honored to be here. Thank you very much.
So nice of you for kind words. Thank you.
I think with that wonderful note and blessings and prayers from each and every one who's present here, I would love to extend our heartfelt gratitude from the entire team of Hello Diabetes Academia 2022 for being with us, standing tall with us, working with us, and making us run. You know, it's really not simple. And as I already told, that castles are not built in a day. It really took many months. There were many hands, many brains, minds, all working together to bring before you the entire scientific session. And I think it has taken time, support, coordination, even the love and the respect what you have for Hello Diabetes. I think that all mixed together, and I think that is all with our folded hands and our heads bow. We would just like to express our gratitude to all the faculties, all the chairpersons, the rapporteurs, all our academic partners, education partners, and there's a big long list. I think, and I had already expressed a big thank you to each one of you. So thank you for being with us, and I think we will need the support not only today but ever after and day after day. So thank you so much for being with us.
Every time you thank everyone, but few people, they remain like this without being recognized. And my teacher, Dr. Surenshi, has told me once long back, Sunil, you have once I forgot to thank one or two people, and he called me, Sunil, you forgot to thank one more person. And I feel I will fail in my duty that if I don't thank a person who's with me 24/7, 365 days. I will get up at 2 o'clock in the night. If something it reminds me, I'll get up. बेटी ये लिख, ये करना पड़ेगा. तुम एकदम से उठ के क्या करने लगते हो? Something like this. And it happens almost every alternate day, every third day. So I feel I'll fail in my duty if I don't recognize the role of Kavita. That's a big hand for her on behalf of all of us. Shlok, very difficult to get him, but he's always there whenever you remember him. Shlok, thank you very much. And of course, Swar, where is he? Swar is around? Okay, and Swar. So these are the people, and of course, my papa, mummy, they have all always, sir, they are always 24/7, they are with me. And whenever we work here in the hall, they are taking care of home. And this is the story of last 30 years, and would like to recognize their contribution, their support, their indirect support, their direct support, their blessings. I feel that is what is keeping us walking and climbing and flying since last 30 years. Thank you very much, Almighty, for giving such a wonderful family to me. Thank you.
Just to add on that, so I think we all, the entire Hello Diabetes Academia, so the family has got one godfather. And yes, I know it's Dr. Sunil Gupta who makes us run. Okay, आज ये हो गया, कल क्या करना है, परसों क्या करना है, and like literally, like rightly what he said, even if it is like night 3 o'clock, something what will come to me. Okay, you have to do this, you have to do that. So I think that is what made us what we are today. And I think if that one more, along with the academic take-home messages what we have carried with us, I think this is one little message which we need to carry for the young people who are here, that I think be consistent, be hardworking, and yes, do have a goal in your life, and I'm sure you're going to reach that. So, and thank you, Dr. Sunil Gupta, for always being there. And I think maybe all our staff knows him very well, whether it is from our guard to our RMOs, they know him ki yes, अब सर आएंगे, सर बोलेंगे ये नहीं हुआ, वो नहीं हुआ, and I think that is something what we have learned over the years from him. So thank you.
He said everything, but most important out of that is be passionate. Whatever you are doing should do with passion. And that's what had made us run to this level. Thank you.
Thank you. Thank you. With that good note and happy memories, we hope to see each one of you once again next year, 2023.
You're all invited for lunch. Please join us here in the hall, please. Yeah. Thank you.